porque el día de ayer fue más que nada en español. De la recepción que el gobierno uruguayo nos dio ayer. Y bueno, lentamente vamos regresando al auditorio. Esta sesión, como les decía,
As I was saying, this is the first session, will be in English, so remember, if you need interpretation, the equipment is outside, you may grab it. You know the whole forum is multilingual, so you may speak for questions and lectures, you may speak in whatever language you prefer. About the agenda, some have told us that we are trying to evolve as an institution to not printing are not using paper unnecessarily, so we are not giving paper agendas, but the QR codes you saw at the door, you scan them and they take you to an app where you will find the agendas in different languages. So we will not have paper agendas, but if you look at the QR codes, you scan them and you will get the agenda. Yesterday, as we told you at the end, through these 3 days, we shall be accompanied by these 3 words that define the structure of this alliance that we are launching, which is investment, innovation, and implementation. And today we shall focus on that second I for innovation, those necessary innovations to improve this PHC approach that we want to improve in the countries, and remembering that innovation in digital health, for instance, and information technologies is one of the components of innovation. But we will not only be talking about e-health or technological innovations. Please remember, when we talk about innovation, we are thinking of a wider approach, and we shall have several very interesting sessions today. The first one, up to 10 o'clock, we have called it Innovations in the Implementation of a PHC Approach, Resilient Health Services, Climate Change, and Information Technology Incorporation. For this session, the moderator will be our colleague from WHO, Jean Sied. Jean, as we told you before, is head of policies and alliances in the special PHC program of WHO in Geneva. He was head of the quality of care department at WHO, a very extensive career. He has worked directly with over 30 countries throughout the world. But as I told you yesterday, he started his career as WHO in our region in the Caribbean, working in our Trinidad and Tobago office. So, as we were saying yesterday, you always go back to your first love. So, you are the moderator now, Jans.
Good morning, colleagues, and Juan Pablo for that lovely introduction. We have had a very extensive day yesterday, examining various aspects, and it's given us, I think, a very great platform to now think through what the next part of our discussions will be. And as Juan Pablo has highlighted today, the focus on the next I, on innovate. And this session is focusing in on innovation in the implementation of a PHC approach. And as Juan Pablo highlighted, there's going to be a specific track of thinking around resilient health services, climate change, and the incorporation of information technology. So this goes without saying, and it's no news to anybody, that the PHC approach needs to have a direct impact on how we tackle public health threats and public health shocks. Going back to the Ebola outbreak in West Africa, the lessons that we were shouting about related to the Ebola outbreak, and I had the privilege of being the technical lead for recovery within the 3 Ebola-affected countries from WHO, the lessons that we were shouting about in the global dialogue were not listened to. And I'm being provocative because that's important for us to remember, that those events that have had an effect on humanity and have caused human suffering, the lessons we could have learned, we did not fully learn. With COVID-19, the scale of suffering has been huge, it's been immense, and we hope that we can move forward in a different way. The PHC approach could be a part of that important solution, but it's our responsibility within this room to think that through. Of course, the resilient health services and the thinking around that needs to be able for us to prevent, to prepare, to detect, to respond, and to recover from public health threats while ensuring, and this is an important point, maintenance of quality essential health services during a public health emergency. Climate change was mentioned repeatedly yesterday, and of course it's straight in the news on various fronts in terms of climate change and its relationship to health, a pivotal moment at COP, of course, but our responsibility now is to think through what the concrete connectivities are between primary healthcare and climate change. And then thinking about information technology, it's only as good as the approach that we will be able to take on PHC-oriented health systems. And that information technology is not for the sake of information technology, of course, but it is for the approach to be placed and implemented optimally based on national direction. So we have 4 distinguished panelists who I'd like to invite to join the podium. And while they come on to the podium, I'll utilize that time to give you a flavor of the colleagues' background. Adriano Masuda is a professor at the Getúlio Vargas Foundation in Sao Paulo and serves as the coordinator of the Research Center for Health Planning and Management at FGV. Dr. Masuda holds a medical degree and a PhD in Health Policy and Management from the University of Campinas, Unicamp. He has previously served as the Secretary of Health in Curitiba and as the Secretary of Science, Technology, and Strategic Products at the Ministry of Health in Brazil. Please do take a seat. And then, if I may, Sebastian Bauhoff is the Principal Health Economist at the Inter-American Development Bank. Sebastian holds a PhD in Health Economics and an MPA in International Development from Harvard University. Robert Phillips is the Executive Director for the Center for Professionalism and Value in Healthcare with the American Board of Family Physicians and Professor of Family Medicine at Georgetown University. He co-chaired the US National Academies of Sciences Engineering and Medicine report on implementing high-quality healthcare. And finally, last but not least, Jeremy Viard is a lead health specialist at the World Bank Latin America and Caribbean region and an associate professor at the Dalla Lana School of Public Health in Toronto, Canada. Jeremy has a PhD in public health from the University of Amsterdam in the Netherlands and is ready to be controversial, I'm told. So today, and this is going to be a session hopefully that we will be listening to you all as well. So we've designed this session to be as interactive as we possibly can. Just to give you a flavor of how we'll run the session so you can prepare your questions and reflections, we'll be asking each of the panelists the same question to start with. And then the second round, we'll be asking each of the panelists a specific question based on their experience and their expertise and their organizational positioning. And finally, we will have the third round, which will be questions and reflections from you all in the audience. So please, as you listen to the wisdom of the colleagues here, please think, maybe ask provocative questions, and just let's be open in the spirit of a fora of exchange. So if I may, and I'll start with Jeremy, and this is the first question to Jeremy, and it's the same question that will be posed to all 4 colleagues. What are the practical opportunities to advance innovative implementation of a PHC approach? What are the predominant challenges in the current environment to innovate for implementation of a PHC approach? And importantly, how might these challenges be overcome? It's the same question that we posed, but let's start with Jeremy. Jeremy.
Thank you very much, Shams. You can hear me okay? So let me start by taking an analogy of the tailwinds that health systems are faced with and some of the headwinds, but starting with the headwinds and some of the challenges. So, in my view, there are 4 different challenges that health systems are faced with in a region. The first one has to do with the very rapid pace of demographic and epidemiological changes. And I think it's very important to recognize that today in the world, Latin America and the Caribbean is the fastest aging region. There is obviously a huge impact for health systems to adapt to changing needs, and especially for primary health care to deliver a new and broader range of services and for new technology to be adopted and implemented in health systems. This is coming with very rapid epidemiological changes and a very high burden of non-communicable diseases, as well as chronic conditions and multimorbidities. I think the consequences are really important in the sense that now you have a range of your population that are very high users of services. So a large percentage of all resources are put to use for a very small number of people who have chronic conditions, multimorbidities that are not under control and that have both very important impact for that population and also for the system. A very good illustration has been actually the very large percentage of people who died from COVID-19 with chronic condition and with comorbidities. And we see in some countries, Colombia, about 30% of the adult population has at least, 2 comorbidities. In Mexico, it's been another example. So that's the first headwind. The second one is obviously the lack of preparedness to pandemic and other public health threats. We have seen that, obviously during the pandemic, and I think that, a really important question that has been posed to us as public health professionals is whether your capacity to prepare and plan is sufficient or is a good predictor of your ability to respond with a high level of performance during a crisis. And we've seen that in many countries that was not the case. So not only do we need to make sure that we do all our, all the planning that, is supposed to be done according to the, international health regulations and what countries commit to, but in addition, we need to learn from what we've been able to do well in the context of past crises, and building on those lessons, make sure that we can translate preparedness into a much stronger response. The second headwind, I think, has to do with climate change. In Colombia, only I will take that example. We made an assessment of the vulnerability of primary healthcare and hospital care infrastructure. We found that about 450 primary healthcare centers have to be adapted or rebuilt. That will cost hundreds of millions of dollars, about $800 million for the entire infrastructure in the country to be adapted to the consequences of climate change because of floods and landslides. That's just one country, but that shows you how important this challenge is with just one issue of adaptation. And the final one that we also must keep in mind is the issue of human mobility and migrations in a region. Obviously, the region is the one that is faced with the largest number of migrants in the world. We see the drama of the Darien Gap every day. Colombia, where I live, has close to 3 million migrants in the country. That costs dozens of millions of dollars every month to provide services to that population, and that creates shocks to the system that have to be dealt with. So 4 challenges, those are very important. I think the tailwinds and what's really proving to be a great opportunity is some of the innovations we're seeing in the region. We released earlier this year a report on health systems resilience that tried to make an inventory of all the types of innovations that we had seen during the pandemic, and there are many. I will maybe mention 3 of them. The first one has to do with the use of telehealth and telemedicine that has been facilitated during the pandemic, because that was one of the only ways through which we could provide services. I think it's very important because we live in a region of huge inequalities, especially inequalities between urban centers and rural and remote areas, and telemedicine has proven to be a very practical way to offer more services of quality to populations that were excluded from services, and a lot more can be done. Number 2, the use of data in real time and the advent of or the realization that investing in information system is absolutely critical to be able to provide information that can be used real-time for planning, for service delivery, for better policy making, and also the use of predictive analytics, realizing that we have populations that accumulate disadvantages, and that for those populations we need to understand with a lot greater precision what services to provide to them, and especially preventive services. And the third one has to do with the alliance between the public and the private sector. When there was not enough capacity during the pandemic, it's very often by having public and private sector working together that solutions were found to increase capacity to address pressures on systems. So, you know, some of the lessons learned very, very quickly, I think that, you know, if there are three ideas that you know, stuck with me thinking about the pandemic and where we at with all these challenges we're facing with, I think the first one I want to mention, again, the Colombian example, because we're working with government to improve primary health care for the most disadvantaged population. I think there's a very beautiful way that they are putting it. They say that primary health care has to be preventative, that primary health care has to be predictive, and that it has to be solution-oriented, resolutivo in Spanish. And so what that means is that we need to put primary health care to use to work with communities, to find ways to help people co-produce health, and understanding the conditions they live in, give them the tools they need to be healthier and to produce better health outcomes. You know, systems don't do that. People produce their own health. So how do you put them in a position to do so? Predictive, because we have a lot more information. We understand the inequalities, you know, with a lot more precision. So we need to be ahead of what's going to happen in the future, of those poor health outcomes. And so how do we work with those communities to empower them to develop better health outcomes? And finally, solution-oriented, because you want as much of the care to be provided at primary health care level, and you want that to be as effective as possible so that you reduce the pressure on the rest of the system as well. So that's the first one. The second issue is quality and transparency. And here, I think that we have to be very honest among ourselves. Very often, people look at primary health care as being care of inferior quality. And so if we don't have the data to counteract that argument, we'll keep on having people trying to go to more specialized, most advanced care. Very unfortunately, we don't have the right level of governance and transparency. So we need to do more to empower communities to be part of taking responsibility for their own health. And we need to provide people with the data to show them that they get access to high quality care, and this is what they should want, as opposed to always trying to find ways to get access to more specialized care at secondary and tertiary level. The second point, and the third point, sorry, has to do, and sorry, the last thing I wanted to say is that, you know, quality creates trust. And what we have seen during the pandemic is a lot of mistrust, and we've seen that in many parts of the country where vaccination rates have plummeted, where people did not want to get access to care because they didn't trust that it was safe or will be of sufficient quality. So we need that as a condition for the resilience of health system. And the last thing, of course, has to do with the use of technology and digital transformation, and the fact that the rate of progress in technology and the acceleration of use of new technologies. We talked about telehealth and telemedicine. I think the use of AI and machine learning is going really to augment the capacity of professionals to provide better care, higher quality and safer anywhere you know, in countries, and that's going to be a major opportunities for innovation moving forward.
Thanks very much, Jeremy, for that. And the same question to you, Adriano.
Oh, good morning. Good morning. First of all, I'd like to thank you, Sham, for the kind introduction. It's an honor to be here, part of this panel, and discuss the challenges for innovate in primary care and a primary care approach. So, first of all, thinking in opportunities, I think the first is that we are not initiating now. We have 4 decades, at least, of experiences of implementing primary care in the region. I can talk more specific about Brazil. The experience of implementing the family health strategy was very important to, in terms of expanding access to healthcare, but expanding access, changing the model of care, and having outcomes, impact of outcomes. So we have evidences that having family health strategy in a region improve outcomes. And this is very important because having evidence to stimulate increase investments in this model of care. So primary care in Brazil is widely recognized as important foundation of a system and not a vertical program. Even the private sector in Brazil that's focused on more specialized and hospital care now is trying to implement primary care strategies, but with a different focus than the public system. So in terms of opportunity, I think this experience is really important. In terms of challenges, I think we are in a region with a widely, I think the most unequal region in the world. And this is an important challenge for health systems. We have structural problems in terms of financing, in terms of resourcing allocation, in terms of incorporation of technologies. So the capacity to have the full capacity of providing services in primary care we are far away that the conditions that we need to provide to health professionals to do their best. We have structural problems in this. And there is a lot of competition between the public and private sectors. In Brazil, for example, I don't know, when I went to Harvard, I started to explain the Brazilian health system. We have a universal health system, the SUS, a comprehensive. We provide from vaccines to organs transplants, everything. But when we look to the financing, only 41%, 42%, all during the whole period of time the SUS was implemented, is public financing. 58 around of the financing goes to the private sector. That covers only 25% of population. With these structural problems, it's impossible to provide a universal, effective universal health system. So this is a structural problem that we need to address. If we do not address this problem, we're gonna discuss a lot of things that is important to have primary care, but will not provide the conditions. So how to overcome? Not only discussing with us that everybody support primary care, we need to discuss with the political powers. We need to discuss, for example, in Brazil, with the Congress. The Congress now is increasing their importance in terms of allocation of budget. We have parliamentary amendments that are increasing the importance in terms of the allocation of the federal resources. We do not discuss with them the importance of primary care and the importance of building a specific model of primary care. Primary care is not popular clinics. It's not, the model of primary care needs to be an integrated model. Primary care needs to be connected with other levels of care, needs to be the basis of a health network. And the investments needs to be addressed to the population needs, to the health needs. This is a not easy task to do. Also, we need to discuss with the judicial power. The budget, the federal budget, is increasing, being defined by parliamentary amendments and also by judicial decisions that define where the federal government needs to expand. So these are the current challenges, I think, the current challenge that the public administration is facing now. So we need to find ways to address these kind of challenges, structural challenges, to have a capacity to incorporate technologies for primary care, to train adequately health professionals, to give infrastructure for these professionals do their best.
Super. Bob.
Thank you. I am so grateful to be here as an American to see the Alliance and the Lancet Commission launch yesterday. It was a amazing thing to see happen, and what an important event. And I'm so grateful to PAHO and the World Bank and IDB for doing that. I want to start with a little dose of humility. I come from a country that spends $4 trillion a year on health care, and our life expectancy is the only one of all developed countries that continues to decline. In fact, in our peer states in the Americas, we look more like Venezuela than we look like Chile or Peru. So that's my humility. The Washington Post, in running a series on this last month, made the direct connection that part of the reason is because we have not invested sufficiently in primary health care. And in fact, our primary health care systems are eroding. So the National Academy's report that I co-chaired that came out 2 years ago now called for some, to your mention of the use of practical innovations, a boldly pragmatic approach to reinvesting in primary care. And we simplified it to 5 objectives. Pay more and differently for primary care. It should be more than 5 cents out of every dollar in health care. We should provide access to anyone who wants it. It should be a common good. To the health minister, Rondo's comment yesterday about the social contract, we should give it to anyone who wants it. We need to train a workforce in the community to be a more robust, comprehensive workforce. And right now, we're only putting 15% of our physicians into primary care when there are 30% of physicians currently practicing there. We cannot sustain our system on that kind of a platform. Digital health. We have very poor interoperability in the United States. We have more than 100 EHRs that don't speak to each other, and that means that we're missing many opportunities for the data that our clinicians painstakingly putting to the EHR every day to work for better health and for better public health. And I'll talk about that more in a few minutes. Our biggest message, though, is there has to be accountability. There has to be someone who wakes up every morning in our federal government worried about primary health care, not because of primary health care, but because of what primary health care achieves. We can't get to better health equity. We can't do better on pandemic recovery and resilience. We can't deal with a mental health crisis, an opioid epidemic, unless primary health care is functioning well. And that message resonated so well that our health ministry launched a year-long initiative to strengthen primary health care that has had tangible results. Our Centers for Medicare and Medicaid Services, which spends $1.5 trillion every year on health care, launched 2 huge demonstration projects around improving primary health care that will last more than a decade. They realize the runway is long, and that will put billions of dollars into primary health care in 14 states to try and demonstrate that primary health care can change and can change outcomes. We had our largest research organization put $100 million on the table to help practices make this transition. We have a lot more of examples, including our Assistant Secretary of Health made a commitment to creating a dashboard for primary health care Philanthropy has already launched that. It was one of our recommendations. It came out in February, has metrics, not for primary health care, but for the commitments of government to support primary health care. So how is the government doing in honoring its responsibilities and its pledges to primary health care? And now our federal agency that oversees all of healthcare will be launching a similar dashboard for accountability of itself to these commitments later this year. So those are the opportunities that I see from a U.S. perspective. Listening yesterday, I hear a lot of resonance for those. But one thing I do want to leave you with is that last discussion panel yesterday where there was talk about needing evidence to support investments in primary care, one of our report requirements was to relook at the evidence for primary health care. And what we came away saying, and our federal government has said this since, primary health care is the only sector in the healthcare system that improves lives and longevity. The only sector. And that investments in it are tangibly related to mortality. If you put more primary care into a community, you see a gain in life expectancy. And we published that study with Harvard ahead of our report. And it resonates with what Barbara Starfield published 20 years ago. So the evidence is there. States that spend more on primary health care, for every dollar they put into primary health care, save $3 on hospitalizations. We have the evidence. But we can't continue to make that challenge every political cycle for primary health care to survive. Thank you.
Thank you so much to everybody. One of the benefits of being the last speaker in the row is I guess I get to summarize everyone's thoughts, let's put it that way. But let me maybe start by I echo a lot of what my colleagues have just said, of course, and I'll try to add something as well. But just to say that I think the main challenge as I see it is really that it's a shift in thinking. And thinking how we deliver healthcare and what we do it for, which is for the patients and for the populations that we care about. And I think that sounds very easy, but I think it's actually a really hard task because it's not just one individual's mindset that needs to be changed, but it's the entire health system and everybody who's involved that needs to get on board with that particular mission. This is about patients and populations, and whatever we need to do, including primary health care, is what we should do, of course. And so I think this sort of shift requires to be thoughtful about where we want to go, what kind of investments we need to achieve those goals. And I think that's not an easy and immediate task. I would say that maybe this is all more a marathon than a sprint. But with that in mind, let me outline a couple of areas, I think, where there's opportunities. And some of this my colleagues, of course, already mentioned. The first one is quality of care and patient engagement. The region is already facing increasing burden from non-communicable diseases. It has still some access problems. We need to work on those. But I do think we need to focus a lot on improving quality of care and also engaging patients in their self-management. So to give you a couple of numbers from a study from Brazil from a few years ago on patients with hypertension. These patients are measured in surveys have hypertension. Only 10% of them have controlled hypertension. About 85% had a contact with the health system, so there is part of an access problem. But of those that did have contact with the health system, only a third received treatment, and fewer even received appropriate quality of care. And among those that received treatment, only a third of them had the disease under control at any point in time. So I think that very clearly shows that we can't just focus on improving access, but we also really urgently need to work on quality and engaging patients in the self-management of their care, particularly for the chronic diseases. So that's one, quality of care and patient engagement. The second one, as we just heard, money is not everything, of course, although I think it does help in many ways, but we also need to urgently work on improving efficiency. We have just finished a study that suggests we can gain about 3.5 years of life expectancy at birth across the region with the same per capita spending. Just to put that into context, between 2000 and 2015, the average increase in life expectancy in the region was 3.4 years. So whatever we can gain in terms of outcome, these potential gains are larger than 15 years worth of gain in the region. And I think it's really important. We need to absolutely tackle the efficiency with which we invest and the efficiency in which we spend in the health system. And I think this is not just important, at any point in time, but it's also really important given that we're expecting increases in health spending over the next decades, and we really need to deal with that. PHC, I think, is one of the ways to realize these potential gains. So I think this involves some reallocation towards PHC. I mentioned earlier improving quality is sort of its own issue, but I think it's also really critical for efficiency because care that is of low quality is also inefficient. So these two things go together; they're not in contradiction. And then, of course, there's opportunities when it comes to integration of networks and other kinds of things. But just to say that I think this efficiency agenda is not an easy one. It doesn't involve just spending more money on the same problem, but I think it requires hard choices and actually a lot of innovations, some of them micro-innovations in how we actually organize our systems, how we organize care, reshuffling resources, and maybe importantly also to realign the entire health system towards the goals that we care about. The last item that I mentioned as a broad area, which I think is ripe for innovation, is inequality. We already heard that there's still a lot of persistent inequality in the region, and I think this persistence really shows that we need some new ideas. The old models that we have don't work for many of our populations. We can't just scale what we already have to reach more people. We need to be smarter and better about reaching the kinds of populations that have been left out, either in terms of access or in terms of quality of care. So I think we really need to come up with new delivery models, new service delivery models, new models of financing maybe, and paying healthcare providers, engaging community health workers and communities, and also patients in their own care, and also improving coverage while we're at it. Now, all these three things, improving quality of care, patient engagement, improving efficiency, and addressing inequality, I think is actually a really hard task. So I'm glad we have this alliance, so we can work together with all of you, of course, to tackle these issues. Maybe the last two things I'll say is, we already heard a bit about technological change. I think there's a big opportunity in digital health. There's also opportunity in personalized medicine and other kinds of technological change that goes on. But that change also needs to be managed well. We need to think about where to invest in digital health and how to actually make this work for the patients and the health system. And I think we need to urgently work on managing technology that can be extremely costly and sometimes has low value. And so that requires priority setting. It requires health technology assessments, rules and regulations about medicine, personalized medicine, data, that I think is really still an urgent task. And I think on the policy level, that's where a lot of innovation can come from. And maybe I'll end by saying that I think in the region we have a lot of good examples already of what works, and we need to be better at studying those and replicating them elsewhere. Thank you.
Thank you very much, Sebastian. So, colleagues, you've heard some really wise inputs. Jeremy has highlighted very clearly the tailwinds of aging, the issues around IHR and preparedness, climate change, human mobility. Innovations he's highlighted, and also highlighted the prevention, the predictivity, and the solution generation. Adriano is really highlighting, and I think this is something that came out very clearly yesterday, we're not initiating. This is building on decades of work. We need to build on that. And the nature of primary healthcare not being another program, but actually making sure that it links and is considered as part of a PHC-oriented health systems, and being bold about structural issues and structural problems, and the high-level political power that needs to be spoken to in relationship to PHC. Bob, thank you for bringing the humility word into the dialogue, which is often missing in global health dialogue, but actually really important to put out there. And the US is moving at a pace that needs to accelerate, and that's what you've highlighted and continuously placed leadership efforts on, and being boldly pragmatic. The idea about a dashboard of PHC support from government is something perhaps to consider for us all. But thank you for sharing that. And Sebastian, bringing in always the focus on patients, populations, and developing a shared vision. And of course, the issues around quality of care have been mentioned by all of you, and that comes close to my heart. One of the things that you've also highlighted is practical examples of how quality of care manifests in the care of patients. Using the hypertension cascade makes a lot of sense. So colleagues, that's the foundation. We're going to now go a little bit deeper with each of the colleagues. And again, starting this second round, Jeremy, you've outlined many of the different parts of the equation that needs addressing. How is the World Bank contributing to address all of those issues that you've put forward?
Thank you, Shams. You know, I'll be brief. I think that, you know, the first thing is to reiterate, you know, what's job number one, what's the mission for the bank, and the mission is universal health coverage. That's a mission we have all in common, but not in any way. It's with quality. So we like to talk about effective universal health coverage. And the strategy to do that is to help countries build resilient health systems that are based on high-performing, high-quality primary health care. So having this strategic clarity is really important to us because that helps us be very clear, very specific about what it is that we do. Now, how do we do it? You know, as a multilateral development bank, there are three things that we do, and they're relatively simple. You know, we provide access to financing with a set of incentives and instruments that have their strengths and weaknesses. Second, we provide technical assistance and new knowledge. And three, we use our voice and our ability to partner with others to leverage what value we can bring to countries. I'm going to talk a little bit more about this issue because that relates to the alliance. The first thing is really try to understand a bit the footprint of what it is that we can bring to the table. So Tanya mentioned yesterday that, you know, the bank in Latin America is a portfolio of $35 billion that includes about $4 billion of projects in health. And it's very important to understand that not only do we have this base, this foundation of $4 billion, we work in 29 countries. More than 50% of all of this is going towards primary health care. So that's a place where we can start and we can improve the use of our instruments to have more impact, especially by implementing more projects that are based on outcomes and making sure that those outcomes, you know, reflect the level of ambitions of governments to improve health for their people. But we can also mobilize the rest of the portfolio. And I think it's very important to explain that we're also providing budget support, for example, for countries through multi-sectoral you know, interventions to reduce inequalities, to improve ability to address consequences of climate change, where we can build health into this. And I can give you a couple of examples, right? So, you know, through, for example, in Colombia, through budget support during the pandemic, we finance access to vaccination for 1 million migrants, Venezuelan migrants. Through the same type of instruments, we are financing the upgrade of primary healthcare facilities to better adapt to the consequences of climate change. So these are some of the examples. You know, we're also trying to push very much the issue of health taxes and really try to work with government to have them more ambitious in terms of improving the effectiveness of health taxation, health taxes, and especially around tobacco and sugar-sweetened beverages and alcohol, so that it has a stronger impact on public health. So that's another way to you know, to get more impact. The second thing that we're trying to do is really to try to be a lot more intentional about what are the strategies to improve the resilience of health systems. I don't want to bother you too much, but there are 5 things we're trying to do. The first thing has to do with helping countries achieve quality UHC through a primary health care approach first. The second thing, to better prepare countries for the next public health threats and pandemics. The third thing, to improve financing. One thing, by the way, that I find absolutely incredible is the fact that we have the hardest time knowing how much countries are spending on primary health care. Ask that question, you know, and I wish everyone had an answer to that question, but I can tell you in some of the countries where I work, we actually do not know how much is spent on primary health care. And so how do you make the argument to ministers of finance to spend more when you cannot even say how much you are spending? So that is just a small comment. So improving the financing and making sure there's more financing dedicated to high quality primary health care is going to be key. A fourth element that has to do with aging and NCDs is making sure that we have high value interventions throughout the life course, implemented obviously in primary health care and through multi-sectoral action. And the last strategic direction that we have has to do with adaptation and mitigation to climate change. Make sure that health systems are more resilient, that they're more adapted, and that they are climate smart. These are the 5 things that are really guiding us to achieve the mission. Now, it is obvious that we're one partner. What we contribute to the much broader scale of what countries are financing is very small. So we can try to be smart, and better, we can try to work together. And that's why we have come with a lot of enthusiasm into the alliance. I will give just one example. The pandemic fund, so you know there's a pandemic fund that is hosted within the World Bank. So this is global public good. The idea is to provide incentives through grant financing and concessional financing to countries to invest more in better preparation for the next pandemic. And interestingly, when we look at what the region got out of the first round, there was money that was allocated to the IDB and to the World Bank and to PAHO, you know, through 2 different grants that give us really the opportunity to work together. And I think that now, as we are getting started with implementation, that could be one opportunity through which we could look at the issue of pandemic preparedness, the intersection with primary healthcare, and how we can pool our forces together to better help countries build a resilient health systems focused on very strong, high-performing primary healthcare that they need. Thank you.
Thank you so much, Jeremy. Adriano, how do you envision innovations in the implementation of a PHC approach to ensure resilient health services?
Great question. I think, first of all, we need to consider the thinking resilience in terms of the capacity to respond to shocks, to different types of crises. We need to consider the structure of the system and how the system is organized. For example, in Brazil, we have a very decentralized system. The municipalities are in charge to providing services. We have 5,570 municipalities in Brazil. 70% of the municipalities have less than 20,000 inhabitants, so very small cities. So to build resilient services, we need to think in regions, how to organize the cities in regions, to allocate adequately inputs, health professionals, organize primary care approach connected to other levels of care. Only in a federal level or in a municipal level will not be possible. We need to organize this in a regional perspective. Secondly, I think we need to consider how to incorporate technologies to primary care. I think we, in general, discuss incorporation of technologies in terms of looking to hospitals, specialized services. We need to improve research to specify what technologies we need to have to improve access to exams and several others. Another thing, considering a decentralized health system, there is a lot of pros and cons. In Brazil, our National Congress of the Municipal Health Secretaries, there's more than 11,000 people that go to this Congress. And there's a lot of innovations developing at the municipal level. So how to foster developing innovations in local levels to address, to engage communities, to build, to co-construct solutions to what their communities need. So this is a kind of new perspective in developing public policies at a local level. But also we need to think about in federal and national policies. And then we have, I think, a great example in Brazil is the More Doctors program, Mais Médicos program. The federal government developed a very innovative financing system that allow Brazil to scale up primary care with the family health strategy that was transfer funds from federal government to the municipalities. It was after developing this type of federal financing that encouraging municipalities to adopt the family health strategy, we scale up. But it was not enough to provide doctors in remote regions, but also in the periphery of the municipalities. So to address this, only transferring money is not enough. The federal government developed a program to allocate doctors in these regions. So this is a type of very innovative policy to provide what the system needs in terms of structural problems. So there's a lot of needs in terms of addressing local needs, support, developing innovation at the local level, building health professionals, building public administration capacity to tailor innovations at the local level with national policies to support the system as a whole. So it's not easy, but I think we need to combine this macro, meso, and micro perspectives to have capacity to deliver really innovation actions.
Thank you, Adriano, and bringing those concrete examples is super helpful. Bob, this is a complex question, so just putting it out there. How do you see the linkages between resilience, climate change, and the use of technologies when considering this from the lens provided by the PHC approach?
Shams, thank you. It is a complex question, but I come at it with a digital strategy. Adriano, I love what you're doing in Brazil. We're doing something very similar in the United States to help figure out where are our maternity health deserts, where are our deserts where we don't have sufficient health care, and then how do we realign priorities and policy to fill those. That's fantastic. The other digital strategy that we're using is the creation of a national primary care clinical registry. So as I said, we have very poor interoperability of our electronic health records. So the American Board of Family Medicine has funded the development of a registry that now has 700 practices, 5 million patients across all 50 states. Not nationally representative, but the first kind of entire national cohesive clinical registry focused on primary care. And we published a study in Health Affairs with our Center for Disease Control and Prevention and with Stanford University just 2 months ago, showing that not only did only 5% of COVID-19 vaccine go to primary care in the first year of the pandemic, which is atrocious, but only 11% of our practices could see which of their patients had received the vaccine somewhere else. And that's a problem, because when they came to us, when the White House came to us and said, we need primary care to leverage the trust they have in their communities to get people vaccinated, we said, we are blind to which of our patients have been vaccinated and which have not, even though you created a federal immunization registry specifically for this vaccine. That is a problem. And that helped CDC reorient their thinking about, oh my gosh, we have to help primary care see what's happening on the ground. That registry now has led to 9 different studies with our Center for Disease Control, including one on long COVID, taking their list of 1,500 symptoms of long COVID or post-COVID syndrome, and winnowing that down to 4 predominant symptoms that present in primary care that are associated with that diagnosis, that are different than influenza, so that you can, with greater reliability, say this person with these 2, 3, 4 symptoms has this likelihood of having post-COVID syndrome, and we probably need to address it in that manner. Stanford has become our partner because they take what I call the gold ore of EHR data and they refine it. They clean it, and they put it into formats that people can use for research, and then they help us allow Harvard to use the data set, to let the Food and Drug Administration use the data set in a way that doesn't threaten our patients, doesn't threaten our practices, but gives a much better window on what's happening in terms of medication equity across the country for the FDA, for the National Library of Medicine and NIH. How is kidney disease managed in primary care, and how does that turn into referrals to nephrology? It is a huge opportunity, and it's a very small portion of our primary care infrastructure. We estimate that the clinicians in our registry write the equivalent of 10 novels a month. 10 75,000-word novels a month. And that only serves two people, the patient and the clinician. There is a huge repository of gold ore there to be refined and used, and we've put a proposal into our Department of Homeland Security, the Office of Health Security specifically, to expand this network, this registry, so that it become a real-time radar for the next pandemic. Where are there changes in health behavior or seeking health care that are not normal? And where should we look and really focus to see what is happening there? And how do we stop that from spreading? And my interest is the reverse of that too. Where can we see where good things are happening, where quality is higher, where trust is higher? And how do we replicate that? How do we learn from that area and translate that through the registry back to the practices that are participating? So that's our goal, to use technology to focus on resiliency and on, I didn't mention it, we're using it for climate change. Where do we see climate change? Where do we see pollution? Where do we see water quality affecting health outcomes? And how do we see that in the primary care setting? So I think a digital strategy is needed for that.
Really thoughtful, and it's, as you said, a complex one. Just to complete the loop, Sebastian, from the ITB side, over to you on what's happening.
What's happening, yeah. What's happening? Right, thank you very much. And I'll pick up on some of the other comments as well, but try to give some more specific examples of the work that we've been doing with all of you, really. And I try to organize this a bit and sort of more one example of an operational lever in the PHC framework, and then two systemic levers. So on the operational side, and also on the systemic side, we do a lot of work on digital health together with PAHO, I think very successfully for the last couple of years already. This includes investing in new modes of service delivery, supporting integration of care, supporting intelligence about healthcare, similar to what we just heard, better understanding where are the hotspots, the problems, what kind of populations to serve and how. And maybe as an example that sort of ties together the digital piece, but also our general work on health system strengthening, is an example from Brazil, which I think has a lot of really good examples that we need to hear more about. In the metropolitan area of Salvador, where we supported interventions to improve health management and reorganization of the care networks, and that included adoption of computerized information system, electronic medical records, and all facilities. And I think it's an interesting combination of the digital health investment, but also reorganizing the system around it. It's not just about implementing an EHR, but it requires some reworking of how the organization and system works. And in that project, we found reduced waiting times, reduced hospitalizations for urgent care, and also reduced avoidable hospitalizations. So I think that's a nice example of some of the work that we do with all of you that is sort of impactful in this. I think the challenge in some ways is for these kinds of interventions to really step back and take a very careful and comprehensive approach and be thoughtful about what these investments are at any point in time along a trajectory. You'll hear a lot more about this later, I think in the next session from my colleague Jenny Nelson. But just to say, this goes beyond investing in infrastructure and internet access, but really also means rejigging the workforce, coming up with legal and technical specifications for these digital services, but also for information sharing and all the rest. And that's actually a big chunk of work. It rolls off the tongue very easily, but there's a lot behind that to do this. And I think, again, as what I said earlier, it requires a shift of thinking from sort of vertical systems, including vertical information systems, to integrated information systems. So that's on the sort of more operational example. Let me give you an example of a sort of strategic piece. And that is, I think we have a lot of good examples and also a lot of local innovation, actually, in local communities and local places. So I think another important piece is to improve local capacity and also provide autonomy to innovate. And I think that's both on the idea space and then also on the specific project design. And let me give you one example maybe, which is our Salute Mesoamerica initiative, which you probably all know is a very strong PHC-focused initiative. And that initiative itself inspired a lot of local innovation that we are able to scale up in collaboration with the governments and the local stakeholders. And one example which I really like is in El Salvador, the Ministry of Health and SMI teams do facility visits, and at one of those visits, they encountered a facility that had developed a 3-question checklist to identify early pregnancies and sort of the need for early prenatal care, which is one of the focus of the SMI initiative. And so this facility sort of developed this tool itself. The ministry and the SMI team found this, helped them scale it up, and has since been digitized and is implemented in the National Family Health Records and already used in Belize, Guatemala, Honduras, Nicaragua, Panama, and Chiapas. So I think that's a great example of local innovation, that if it's possible to have it, if you give enough space for local actors and they have the capacity to innovate, we have to pick those up and help them scale it. So I think there's actually a lot there already. Innovation doesn't just mean creating new stuff, but it also means taking existing things and making them better and scaling them up. So my second example would be Salud Mesoamerica. And the third one is innovation, sort of strategic change at the organizational and system level. I think we all know that PHC does not happen in a vacuum. And we, as I said earlier, need to really realign the building blocks of the health system. I think within those building blocks, there's a lot of room for innovation, but I think reworking them is part of the task that's ahead of us. And so again, SMI was a combination of financial incentives, measurement, local capacity building, and training. And I think one of the key lessons from SMI is that it really requires this comprehensive approach. Financial incentives by themselves will not work very well, will not be as effective as they could be if we also do all the other stuff that we need to do to actually make sure that local actors can respond to those incentives, but also then actually do what they need to do. The second example in this is integrated health network in Peru, which uses centralized medical support services. So basically, instead of having decentralized lab tests, imaging, blood banks, this has all been centralized for economies of scale and improved quality. But it also includes health promotion, prevention, and then follow-up of NCD at the first level of care. And I think that's another good example of reworking the organization of the system to be more efficient, to provide better quality of care, and to also expand access. So maybe with that, let me just leave it there.
Thank you, Sebastian. So colleagues, now is the time for us to come to you. Your thoughts, your reflections, your questions. It's a very intense light, so it's very hard to actually see hands, but I am actually looking for hands anywhere in this auditorium. Okay, so who'd like to kick us off? Yes, please, sir.
Hola, buenos días. Mi nombre es Ignacio.
Good morning. My name is Ignacio Torca. I'm an IDB specialist in El Salvador. I would like to ask a question concerning who implements all the things that you have mentioned. Basically, the issue of governance. We always talk about what has to be done, but how? How do we do it? Here in the room, there are experts of international agencies, country representatives, and probably that is one of the main dilemmas. So my question is an open one for reflection. How do we implement these measures? How do you strengthen governance, national or regional governance? Thank you.
Bringing that clear question to colleagues, I will just take 2 or 3 in one cluster. I'm looking out for any further hands. Yes, please.
Good morning, Artenisa Hamilton from Ministry of Health, Guyana. This was a very interesting discussion this morning, especially because most of us are in the place where you are now having this discussion. And adding to what the colleague said, there is a real interest of how do you take all of the ideas that you would have shared and actually making it into something workable. And we've heard that there's so many layers to the challenges that we have. There's so many things that are all happening at the same time. We are looking at finite resources. We're looking at inadequate workforce. We're looking at mounting health cost. And how do we find that place where we can all put every idea that has been shared and make it into something that we can work with. And one of the things that I heard lots of examples, and I thought they were really great examples. But what we really want to get from some of this is that looking at the finite resources, looking at the health systems that we have, that are most of which are in reform, how do we garner those high impact, cost-effective examples and utilize that? Because even if we were to take what we have, some of it is expensive. And there is a real competition that is happening right now in how do we save the lives of persons who already have diseases in different stages, but still have enough money for the people to prevent. There is a real tug of war going on there. How do we maintain that line in ensuring that the resources work? Primary health care is important, but then there is still some of the secondary health care that we still have to look at. And adding to that, a colleague yesterday really put forward a very good initiative. Their primary health care that occurs in other levels of care that we have not really looked at. How do we bring all of that into a place where we can now apply it to see the best health outcomes possible?
Very beautifully put. That's a great reflection and a great question. I'll look out for a third and final one, and we'll come to our panel. Again, it's a little hard to see, but I think there's somebody. Yes, please, go ahead.
Good morning, colleagues. Dr. Gillian Bartlett from the Bahamas. The Bahamas are unique in that we are an archipelagic island. So that means we have 700 islands that we have to duplicate health services, not only in our main city, Nassau, but also across our family islands. So we have, as was mentioned yesterday, and I heard to a little lesser extent today, we have a lot of duplication of services. How do we prevent the duplication? How do we get the innovation out there to all 30 inhabited islands? EMR, very good. Digital health, lovely. But how do we address the internet challenges that we have, the infrastructure to put in this robust system? How do we get it to 30 individual islands? Also, what struck me, I heard this morning, was innovation in that we have to get to the local level. We sit in these high spaces and they're lovely, but it's not how we translating that to the local level so communities can feel the change that has to happen. I think all in the room we agree, primary health care is the way we need to go. We have to get there if we're gonna improve the outcomes of our communities. What was said yesterday also was striking in that if we had one line to tell the policymakers what will make this change is to just calculate the savings we would have of all the preventable illnesses that go into our tertiary care. Our tertiary care is overrun. Dialysis cost is through the window and all the others that come with it. So how do we get this in our unique situation out? 30 inhabited islands, not including our capital. So it's a robust task that we have to undergo there in the Bahamas. I think we're in a good way to get there, and that supportive structure definitely has to be in place. We are also facing all the challenges of all the other islands mentioned. Migration, human resources. How do we, I think, to realign, we have to go, I would think, just hearing what one of the presenters said, to each of these islands and to see and to do a restructuring. What do these communities actually want? We probably think we know what they want, but we could be totally wrong. We have to do, I think, an analysis of each island to see what they want and what level of primary care is needed on each individual island. So you could imagine the task in the Bahamas, not easy. Not easy.
Definitely, and thank you for articulating that so clearly. So there's three very clear questions for panelists, and I'll maybe take it in reverse order, starting with Sebastian. So the governance issue, who does it, How does it happen? Colleague from Guyana maybe highlighting what are the high-impact, workable solutions, how do we get there? And a colleague from Bahamas very clearly asking how can we prevent duplication of services, and how can we also cater for a multitude of needs, particularly in island states with various islands within a nation. So Sebastian, maybe starting with you.
Oh, that's just great. Thank you. Do it all. Yes. Glad to go first. No, these are all fantastic questions, and just to acknowledge that they are difficult questions. No? So just to put that ahead, I guess that's a caveat. I'd be interested to hear what my colleagues have to say. But I think maybe starting with the second question, I think, you know, I'm an economist by training, and we deal a lot with trade-offs, and one of the recognitions is in health that we do have trade-offs to deal with. The money is not endless, even though we would like it to be when it comes to our populations and patients. So from our perspective, I think it's really important to prioritize what kind of services you provide, what kind of populations to help and support. And I don't mean this as a way of excluding anyone, it's just a recognition of reality that we don't have the endless amounts of money we would like. So what we do at IDB, we have a criteria network which designs health benefit plans, and based on evidence of interventions and also evidence of cost effectiveness. So this is trying to figure out how to take the resources that we have and make them maximize the health gain that we can get. This is not just on average, but it's also taking into account, of course, equity consideration and sort of special considerations. Whatever the country has in its sort of goals and objectives is what can be built into the design of these benefit plans. But I think it's important partly because it really helps maximize the health gain for the money that we have. It is also a due process and a clear process about how decisions are made. So this is not an ad hoc kind of way, we'll cover this today and that tomorrow, but there's sort of a clear rationale and anyone can follow it along. I think it's really an important accountability mechanism. I think some of the issues that were raised across the last two questions really have to do with local context, and I do think it's important to go and visit all those islands of yours and find out exactly not just what they need, but also what they have. Because I think in many of these smaller communities maybe, there's also sometimes an amazing resource and a human resource, for example, that can provide a lot of support to the community, and that person requires something else to help them do their job better. So I think it really depends on where we go. Some places have no one at all, right? So and maybe that is the case for some of the islands that you mentioned. So I think it's important to understand that properly, and then really to be able to respond in appropriate ways. And I know that's sort of a very general answer, but I do think it really depends on the local setting. So I think there's no way around finding out about that. I think in terms of maybe the second question, alluded this to a bit in the first as well, what should we do, how should we get started with all of this? I think it's important to take a deep breath and just sort of acknowledge that this is a complicated issue and it's not something that we will be able to resolve in a year or even 5. This is a long-term endeavor. And I think the most important thing is to be very clear about where we want to go and then work backwards to the different steps on actually how to achieve this. That's sort of, I know that political cycles are sometimes short and patience is also short. We know this is all urgent. The climate change agenda, the resilience agenda, the NCDs, everything is really important and is urgent. But I think it's important to have direction and to make sure that the investments that we make, and that includes, as Jerry mentioned, the investments that are made by the World Bank and the IDB, that they are strategic investments to leverage resources and other investments in the public sector and also in the private sector. So I think we'll need to have a properly thought out understanding of where we want to go and how to get there, and then to act on that. So maybe with that, I'll hand it over.
Thank you. And maybe just going in reverse order, going to Bob.
These are great questions. The governance question, this was our objective number 5 in our report. We said that the problems we had, we needed serial mitigation. You can't solve the workforce problem unless you solve the payment problem. And you can't solve access unless you solve the workforce problem. And we have 14 agencies in our secretariat, our health ministry. We said these agencies need to work together because they have mutual problems, they have shared authorities, they need to combine them. That can only happen if the secretary sets up a council of that group. And that's the group that worked for more than a year to create a strategic plan and a strategic leadership group that was focused on how they collectively work at all of these problems together. Now, the bad news is last month the secretary pulled back from that, That didn't keep a number of our agencies from continuing the work that they're doing, but it made us have to pivot to a congressional activity. We have to get Congress to allocate resources to make this happen. The dashboard becomes really critical then. So the dashboard measures things like percent spend on primary care. People who have access to primary care versus those who don't. Those who have a usual source of care in primary care. The percent of our trainees coming out of nursing and medical schools going into primary health care. So again, these aren't measures of how primary health care is functioning or saving money. It's measures of, are we actually creating the primary health care system we need? And if we're falling short, who is the named agency responsible for that metric? So it has to be practical, it has to be tied to someone who's named as having the obligation, and they have to care about it. And the fact that our Secretariat now is going to put out a dashboard like that becomes really important. I want to come back to the Bahamas because we have the same problem in our Hawaiian Islands. The state of Hawaii has 7 islands. The state of Molokai for the last year has not had a full-time primary care physician for its 7,500 inhabitants. That is a problem. Yours is very particular, but the way that this has been addressed since 1940 when the Karks developed this in Lesotho, South Africa, and took it to Australia and Israel is something called a community health needs assessment. It's the heart of community-oriented primary care. So localities have to be able to ask a similar set of questions about the ability of the community to benefit from primary health care, but then also turn and say, what are their particular needs and goals, and how does that system need to address them? And you have to bring those together to make community-oriented primary care. And what we've tried to do on Report is link that local obligation to a national infrastructure and help them connect the dots on how they work together.
Thank you, Bob. Adriano.
Thank you for the questions. I think are great and put the finger that it's not easy to address the issues that we need to address. We need to consider first that health problems are increasingly becoming more complex. Managing health systems is also becoming more complex. Primary care is fundamental, but it's not enough. We need to consider primary care as a part of a system based on primary care, but it's not enough. So to address health problems, manage complex health systems, we need to have a strategic thinking, strategic planning. But who's gonna do that? I think we are living a period that the problems are becoming complex, and the public capacity to address these problems is becoming, we are losing capacity in terms of public administration. I did my residency program. I did preventive and social medicine, and our main training is health planning and thinking how to formulate policies, how to implement, how to measure. And in Brazil, we had at that time a career for public health professionals, sanitaristas. The sanitaristas movement was the most important movement to create the universal and comprehensive health systems in Brazil. We lose this capacity, and PAH was really important at that time to prepare these professionals, to train and prepare governments to work in collaboration with governments. I think we need to come back to this. We need to train again people. We need to develop the delivery capacity at the governments. We need to work with private, public and private partnerships, but we can't deliver the thinking to the private sector. This is public. We need to strengthen public capacity. So this is a crucial moment, I think, that we live in our region.
Thank you.
I'll say 2 words about the first question, but I think that the other speakers also raised the issue of implementation and building on what you said, Adriano. I think it's a very fundamental question, the issue of implementation and implementation support and capacity, especially at sub-national level, to implement complex reforms. I'm saying this because we talked a lot about diagnostics, about solutions. I think that's the easy part. I think that's actually pretty clear, but implementation is really hard. And so there is actually a lot of value for countries and for this alliance to come together to think about how we are going to make this happen, how you're already making it happen, what are the lessons learned, and how they can be scaled up. And so, perhaps 2 messages. The first one is that we do not lack innovation in this region. I see innovation in every country, every possible way, and really remarkable work, remarkable results. What is a lot harder is to scale up and to implement in a way that makes a difference. And so it's very important to say that among our 3 organizations and within countries, we have actually a lot of knowledge about what works, what doesn't work, what is innovative, what has the potential to be scaled up, how it can be scaled up, how to work with the private sector at times to help them be part of the solution to achieve better equity and better population health outcomes. And I think taking stock of the experience we have globally, regionally, nationally, and of the instruments that are at your disposal is very important. One thing that we understood, for example, during the pandemic is that even if we made financing available to countries to procure whatever they needed to respond to the pandemic situation, it was very hard for them to procure the goods or services that they needed. So one thing that we developed internally at the bank was what we call a hands-on implementation support for countries, so that our procurement specialists who had global knowledge about procurement and knew the market will actually work directly with your government procurement specialists so that you will have actually a greater chance to get what you needed to get in time. That's just one example. The other example that I would also provide is how the financing instruments that can be provided by the banks in connection with the support that PAHO is providing to countries in implementation at country level can be leveraged. Our instruments have been developed and have decades of history of creating specific incentives to support implementation. So we can provide more resources for technical assistance, to support your procurement and fiduciary systems, make sure that there are safeguards in place so that you have actually strong delivery. But there are also specific incentives that are being created. So if I take some example, we have more and more experience in financing for results, or program for results, through which we build those such financial flows that there's a very strong incentives for ministries and subnational entities to work together to deliver results. And if they don't, then it creates a disturbance in our financial flows, and the problems become so big that it's actually, that governments are really incented, and that's what they want themselves, to achieve those results faster, really accelerate results. So, there are opportunities to use us, the alliance, with all our strengths, so that working together we can help you towards better implementation and faster results.
Thank you so much, Jeremy. I'm really cognizant of the time, and I know I can see people looking at me and waving, so that's a bad sign. One last quick point from each of you, one takeaway that you'd like people to take coffee and think about, and we'll take the same sequence. Sebastian, one quick point.
Thank you. Well, I have lots of takeaways, of course, but I would say keep a clear focus on our goals, be strategic, and remember this doesn't happen today. This is a marathon and not a sprint.
I would say 2 words, impact and alliance.
I would like to think about in how develop in the region a more sustainable, resilient, and innovative health system based on primary care.
My first would be a digital strategy for primary health care. And for using the data to help us understand what's happening and what could be done better. And the second is serial mitigation. You can't solve one problem without solving all of them. And that means naming the names of the people who have responsibility and authority and resources to act on them, and then hold them accountable with metrics applied to them.
Thank you, Bob. It's been a fascinating morning listening to the wisdom of the colleagues. If I may, just one point of emphasis, coming back to this point around complexity and seeking some form of simplicity. So we always are striving for the simplicity on the far side of complexity. It's not all about frameworks, but if you can remember the 4 aspects of the strategic levers for action, what were they? Political commitment, finance, governance, and engagement. Without those 4, and colleagues have alluded to all 4 in the discussions today, we will not make the radical reorientation of health systems towards primary health care a reality. So this is an opportunity, hopefully, to continue this discussion. Please join me in thanking and applauding the great colleagues here.
¿Escucha o no? Sí, perdón. Bueno.
Excellent panel, thank you for your interventions. Remember, we have a 20-minute break and we'll be back for 2 parallel sessions. Today, we are focused on innovation. The 3 I's overlap. In this panel, we have had innovation in relation to the necessary policies and paths to implement them. So in the parallel sessions are 1 focused on digital health, innovation in the more in the strict sense of the word, and the second panel dealing with innovation when including communicable and non-communicable diseases to PHC. Panel A here, digital transformation and new paths for opportunity to develop PHC. And in the upstairs room, room B, we'll have innovation in the integration in the approach of communicable and non-communicable diseases in PHC. Just decide. We'll be back at 10:35.
Bienvenido a Pilas, un programa del Ministerio de Salud.
gracias los que eligieron este panel. Sigamos tomando asiento, volviendo a nuestros lugares. En esta sesión paralela, el tema que nos va a convocar es el de la transformación digital y nuevos caminos de oportunidad para el desarrollo de la APS. Y para esta sesión contamos con un panel de lujo que ahora le va a presentar el moderador. Y le voy a entregar la moderación de la sesión a Marcelo de Agostino, jefe de la Unidad de Sistemas de Información y Salud Digital de nuestra casa de la OPS en la oficina regional. Así que, Marcelo, todo tuyo.
Gracias, Juan Pablo. Buenos días. Bueno, para mí es un gusto. Trabajo en el Departamento de Evidencia e Inteligencia para la Acción en Salud de OPS, que dirige el doctor Sebastián García Saizó, que ahora va a hacer la presentación del marco del contexto del panel. Y mi responsabilidad es dirigir la unidad de Sistema de Información y Salud Digital. Entonces hoy estoy muy agradecido también. No logro ver por las luces, pero no sé si están presentes también los colegas que organizaron de HSS, Jane Fitzgerald y Ernesto Váscolo. Muchas gracias por habernos hecho este espacio. Estamos trabajando juntos en la organización en todos los temas de transformación digital con foco en atención primaria y también destacar, siempre es un gusto compartir con varios colegas de las oficinas de OPS, del BID, del Banco Mundial de los países. Entonces, quisiera llamar a todos nuestros panelistas, voy a ir en el orden que está en la agenda para que se puedan sentar aquí. Sebastián García Saizó, director del Departamento de IH, OPS, OMS. Mirna Marti, asesora regional de Sistema de Información y Salud Digital, OPS. Felipe Proenzo, director de programa de Secretaría de Atención Primaria del Ministerio de Salud de Brasil. Jennifer Nelson, especialista senior en soluciones digitales del BID. Jimena Hernández, directora de Salud Digital, AGSIC, Uruguay. Y Gianluca Cafaña, especialista en salud del Banco Mundial. Quería destacar también la presencia de Tania Dimitrachenko, la gerente de salud de América Latina y el Caribe del Banco Mundial, y a Pablo Ibarrarán, el jefe de División de Salud y Protección Social del BID, que también nos acompañan. Entonces, la idea de hoy es, vamos a tener primero una keynote de Sebastián, donde nos va a dar un poco todo el contexto y hacia dónde vamos en la OPS en transformación digital del sector salud, y después vamos a tener presentaciones que hemos intercalado, presentación de OPS, después del Gobierno de Brasil, el BID, el Gobierno de Uruguay, y cerramos con el Banco Mundial, y la idea es poder después abrir a preguntas o reflexiones al final. Cualquier cosa, Juan Pablo, vos también guíanos en el proceso. Entonces, sin más, le paso la palabra a Sebastián. Y le agradezco si pudieran poner la presentación, la número 1. Ya está, gracias.
Muchas gracias Marcelo. Y bueno, me sumo a los agradecimientos a James Fitzgerald y a todo el equipo de HSS por la organización y por supuesto a los colegas del Banco Mundial y del BID con quienes desarrollamos este panel y no solo este panel, sino un trabajo que ya tiene más de 6 años en la región de las Américas y que es parte justamente de este contexto que vamos a presentar. Y bueno, y agradecerle a Marcelo también. Marcelo siempre es muy modesto y se presenta como el jefe de la unidad de sistemas de información y salud digital y no da más contexto. Pero Marcelo ha sido un motor incansable de la salud digital y del fortalecimiento de los sistemas de información en nuestra región por más de 2 décadas. Así que bueno, Marcelo, también muchas gracias a ti y por supuesto todo el trabajo. Y bueno, vamos a plantear entonces esto que se propone como una ruta hacia la transformación digital del sector de salud en las Américas, algo que escuchamos en prácticamente todas las sesiones hasta ahora, como una de las prioridades que nos presentaba el doctor Barbosa y por supuesto uno de los ejes también de lo que implica trabajar en una visión renovada hacia el fortalecimiento de los sistemas de salud, el plantear sistemas de salud resilientes y este enfoque particular hacia la atención primaria a la salud. ¿Dónde está el rol de tecnologías que hace más de 3 décadas, cuando empezaba la noción de la transformación digital, no teníamos como tenemos hoy? Es decir, transformación digital no es algo que ocurre en estos últimos años de COVID y que nos dimos cuenta que existía. Esto es algo que ocurre en muchas esferas de nuestra vida como miembros de una sociedad cada vez más globalizada y que sin embargo salud ha quedado en muchos sentidos relegado en muchos otros momentos y que necesitamos aprovechar esta priorización que se hace hoy en día y por supuesto este foro que nos permite también comprender esta priorización dentro de todas las diferentes esferas de lo que implica fortalecer nuestra atención primaria para la salud. Entonces, en este contexto global en el que nos encontramos, la transformación digital del sector salud no es algo que ocurre en aislamiento, no es algo que ocurre para salud. Muchas veces lo vemos así porque descubrimos que hoy en día existe software especializado para generar, por ejemplo, se escuchaba en uno de los paneles ayer, ¿no?, la posibilidad del tamizaje en imagenología basado en inteligencia artificial. ¡Wow! Bueno, pero esto es algo que ocurre en todas estas esferas, en todos estos sectores gubernamentales desde hace más de 3 décadas. Esto es algo que ocurre dentro del gobierno. La mayoría de los gobiernos, me atrevería a decir todos los gobiernos de nuestra región, tienen agendas muy claras y bien definidas de transformación digital gubernamental desde hace décadas. Sin embargo, salud, uno de estos sectores, ha quedado fuera de estas agendas, ha quedado fuera de estos panoramas. Hoy en día nos cuesta trabajo imaginar no poder utilizar nuestra tarjeta bancaria en cualquier parte del mundo para acceder a nuestro dinero. Esto se logró más de 15 años atrás. Y sin embargo, todavía no podemos imaginar eso para nuestro sector salud, en donde podamos cambiar de proveedor o tener al alcance nuestra propia información, nuestros estudios de salud, nuestra información en general. En el sector financiero ocurrió muchos años atrás. Y lo mismo en otros sectores estratégicos que lo vimos también como determinantes y como factores claves de lo que ocurría en el entorno.
Or key factors of what was happening in the pandemic and how we could respond to social needs, or how could we respond to a lot of what were considered limiting factors and barriers. We must also understand that digital transformation doesn't occur as something that health may generate per se. There was an interesting question in the previous panel about how do we do it. There are determinants that we shall not be able to respond alone. Connectivity and bandwidth. If we do not have adequate connectivity, even if we consider a comprehensive digital transformation in health systems, it will be hard to achieve. And the possibility of the digital gap or digital divide to generate negative impacts in health, and that our gap of equity in health is increased, has a high risk indeed. So how do we understand these determinants which are outside our reach and which mean to really move towards this transformation, and to consider these accelerators within public policies, data governance, and here's something that the EH4H, the strengthening of information systems, has been proposing for over 7 years, the possibility of generated information systems that are interconnected and interoperable from the first level of care. And all of us know that situation in this primary care in localities. We have information systems living together for census, for nominal census, that help promoters carry out and update for mother and child and adolescent care, for immunizations, for epidemiological surveillance, sometimes not only in different platforms, but in different machines, because funding came from a vertical program, which meant that that unit received a computer for immunizations, and then another program provided a different one for surveillance with platforms that do not interoperate, and it is the same health personnel carrying out the actions. So if we do not understand all these blocks, these basic construction blocks in this environment of digital transformation as a larger thing, we will be destined to perpetuate these fragmentations that were generated from the institutions themselves. Digital literacy, anything new and implying change, needs to generate those competencies. Digital literacy of all our health personnel, that they are able to generate the benefits that technology can provide, but also all those users, and to bear in mind differences amongst populations who will be benefited from the use of those technologies, who are the ones who are most vulnerable to change and to this benefit, and updated regulations. This isn't a technological change only. It's a change in how we think of systems, interaction amongst different elements in the systems, and implicancies in regulatory legislative frameworks that do not only allow this, but also to make it sustainable, something that is not just buying equipment, but that allows us to maintain it to the future as part of a policy in a more structured environment. And the basic component, digital infrastructure, yes, we need to mobilize this layer in line with these elements, I insist. Oftentimes, something that the health sector cannot do per se without articulating with other areas in government. So what do we want? Why are we talking about the need for this digital transformation? Why is it in all the conversations we have had and we shall have in future about in this road that we're all building? We are looking for equity and access to health services, but there comes a time when we cannot build another unit. We cannot generate a service in terms of constructive blocks, Windows tables. How do we reach those populations where we shall not build something? In the previous session, we talked about having 30 islands, and maybe we cannot build a hospital with all its capacity to solve problems in all 30 islands. We need to generate enlarged coverage, particularly for the most vulnerable people. We want to have equitable access to digital health solutions, but that are constructed as public goods based on co-creation from the onset, on sharing capacity and sharing needs in order to have a more effective development, and interoperability principles which allow us to think of sharing data beyond our national environments. Let's start with national environments where nowadays we do not have interoperability even within the same institutions, but we have to think of a roadmap that would allow us as a region and as part of a construct that goes beyond our countries to have this interoperability as a goal, and innovation and resiliency as factors. So this isn't a new road. I said this from the beginning. This is a roadmap that we have developed, and Marcelo has been a motor in it, and I repeat it, that started in the Caribbean when countries questioned what else can we do to set up these shared notions to strengthen information systems. And this gave rise to a framework within the IS4H initiative, the strengthening of information systems for health. And I have to acknowledge joint work with the IDB, which allowed us not just to generate a proposal from an organization in countries, but a shared proposal that allowed to align these efforts and to have a same language, indicators, proposals, routes, and the work that we carry out in the region. That led us through years of implementing the model, generating tools around the model to be able to think of the review from the countries and to say, okay, where are we going? And this happened in 2021, and it allowed us to generate this view from the countries, not just focusing on information systems for health, but to take that to a sort of roadmap for the digital transformation of the health system. What is digital transformation? What are the basic elements we must consider in our environment and according to the priorities set by countries? And with this, we can build all the necessary tools, generate all the technical cooperation that would allow countries to articulate their plans, their programs, and relate that to their needs at the local environment. With whom? With all the partners in this initiative, the World Bank, CDC, Vital Strategies, Bloomberg. This isn't just a route that is built from one day to the next, or that allows you to walk alone. This needs us together and to share the road because challenges are still very big.
This to generate a shared vision around 8 ruling principles around the health sector. If we don't part from universal connectivity, even if we introduce technology and equip the units, we won't benefit everybody, generating once again significant divides that will impact on the health outcomes. Generation of digital public goods as a focus where we co-create environments and share solutions and resources. A vision towards an inclusive digital health, enabling interoperability focused on human rights. And I emphasize the legislative update of countries for this to be truly sustainable and related to our current situation. During the pandemic, we saw countries generating significant changes for technological innovation in telehealth, but the law didn't enable this. So that isn't effective. If a patient make contact a physician, but then go to the facility to receive a prescription, we're not truly solving the issue. This, I insist, often is related to issues that are not in the everyday operations of health institutions, but is related with a more holistic vision of the digital transformation of governments and the strategic visions in countries. The focus on AI as part of the joint development to improve our understanding and participation, but also accelerate this safe and regulated inclusion in the health environments to have a truly positive impact on people's health. Information security. If we advance in the digital agenda and leave cybersecurity aside, we'll risk the most sensitive information generated within systems, personal information. And last, an item focused on rethinking the architecture of health. Digital transformation doesn't mean digitizing the processes we've been doing for over 100 years sometimes. It has to do with rethinking what we may do within public health with the tools we currently have available and open doors to generate a better future. This became a resolution adopted by all countries in the Americas that entails a vision as presented by Dr. Barbosa within this project that we adds many players and drives equitative and timely access through health innovations in all countries in the region. The digital transformation, and more specifically this focus on telehealth. And we decided to do so as one of the priorities within a broader agenda, whereby the countries are clear about their wish to go on this path. This is related with a multi-sectoral approach and resilient systems based on PHC, reaching more vulnerable areas, reducing the waiting lists, generating second opinions within systems and services with the elimination agenda that is being currently discussed in Room B, including the non-communicable diseases agenda within PHC to generate continuity of care, a greater possibility of having an effective outcome. But if we don't bear in mind the key determinants to achieve this agenda, it will only be one more initiative in vertical programs that do not include this. With connectivity and bandwidth, with these major determinants for including these new options. But what happens in the connectivity of our health systems? And I must thank Luis Tejerina from the IDB that generated these slides from their studies, adding this vision about what is happening in our region, about the availability of connectivity services within our health facilities. All these dots are the health facilities in the region, and in general terms, we observe good connectivity. 23% of the health centers are located in areas without mobile connectivity, and 18% approximately in areas without fixed connectivity. So this has taken decades of encouraging connectivity in the health system. But if we speak of telehealth, it's not only connectivity. If we now look at what is happening with this connectivity, the blue dots now become red and yellow. So it isn't enough to enable telehealth services. We have then 36% with insufficient mobile connectivity and 45% outright with fixed connectivity that is insufficient because a wideband is not good enough. So this is a major issue we must solve, and health is not responsible for the connectivity agenda, but it must be positioned in the government digital transformation as a priority to enable enough connectivity for services. And this is seen in the maturity analysis in the region conducted in the past 5 years, where we have all countries and territories with an assessment of IT system maturity, where connectivity and particularly availability of infrastructure and functioning are one of the major structural challenges. And we must understand and advance to truly prioritize this in the government agenda to strengthen IT systems. Similarly, specific tools such as this one generated in the pandemic between IDB and PAHO to measure the maturity or capacity of facilities to provide telemedicine services. This tool has been applied in over 1,800 facilities in Argentina, Colombia, and Uruguay to generate specific routes to reach where we must and show results. Some of the hurdles identified, technological, economic, whatever, issues with inappropriate infrastructure, lack of interoperability that we mentioned as a dominant item in systems, particularly in relation to the local environment, what occurs in the primary healthcare facilities, issues about the risk of privacy and security, confidentiality of information, and likewise issues related with the digital divide, particularly in more vulnerable populations, an organization culture that hasn't been easy to change, allowing a more systematic option for the transformation, lack of training in many centers, lack of research, and in turn, research that is not related with true needs, where we must carry these guidelines and the governance area that we identified in the maturity analysis in the IS4H model, a lack of governance structures within the ministries of health, enabling structured change, including these elements within public policies, plans, health plans. That is a digital transformation with the IT system capacity building within the health plans in the countries. And indeed, the economic aspects with lack of investment models, specific funding addressed to technological solutions, and the whole modification of the environment, lack of a budget and associated monitoring enabling sustainability. For the future, we want to generate these information systems, particularly in APS, that are interoperable with a digital transformation that is part of cross-sectional strategies in the capacity building of the health system, not only accessory or annex systems, but core of the capacity building of resilient health services. If we don't implement telehealth services, not leaving anybody behind will be difficult, particularly in situations such as a pandemic where there was a clear disruption of the health services. We were not ready to generate this deviation of services towards a different priority. We, of course, need to integrate the health ministries within the digital transformation initiatives in government. Health cannot be alone, and new law or an update related with the digital transformation as a critical factor for success, apart from the constant work with partners such as this relationship we've had with IDB and the World Bank and others that will add on, without leaving aside a very significant part of the digital agenda, the private sector. These are part of the transformation agenda in many of the sectors that we observed were strategic in a governmental path. Then this leads us to rethink the map of players involved. What are the indicators we must share to truly work together? Where are these critical factors we must know about countries and health initiatives that will lead us to have a better follow-up and a dialogue among stakeholders to draw a joint path and the digital transformation in our health environment and in the population. And this is an example of the progress with the priority of telehealth and what is available in the virtual campus of PAHO with this telehealth approach. When we consider the 8 principles of digital transformation, so we made a call to countries for Pan-American action, sharing work towards a digital transformation with this vision to understand the needs and exchange experiences in our countries, to better coordinate and motivate supranational cooperation and national environments, including digital literacy, not only when training our staff, but also at the early training stages. And indeed, strengthening the basis, guaranteeing that everything related with the digital transformation be focused on ethical inclusion and human rights principles. During the pandemic, in many countries, people decided to stay at home. We discussed this in many places. It wasn't possible in many places, starting with inclusion for social security, employment conditions, and so on. But clearly, connectivity factors change this for many countries. It isn't the same to stay at home if you have connectivity, accessing health, education, financial services, telework, and many others that in countries such as Uruguay made a difference. I'll leave you with some of the tools available within the toolbox for the digital transformation in the health sector, updated regional indicators, over 300 health indicators for the region, and indeed, the 8 Principles publication that is a key instrument to formulate future policies in the Americas. Thank you, Dan. I apologize for taking long, and nobody told me to stop. I hope we have a rich discussion. Thank you. Thank you, Sebastian. I didn't speak loud because he's my boss. Well, thank you for giving us the context. Excuse me, I hadn't seen you before. Thank you for this time to discuss this important topic. We'll now continue with a presentation by Myrna Marty, Regional Advisor in our Department for IT and Digital Health Systems. We also have, well, Sebastian mentioned it. We like to strengthen this, saying that this started with a vision in the Caribbean, in particular from somebody from Dominica, Dr. Ricketts. We insist that the place where the health information systems became known, well, we changed them to Information Systems for Health, and this was a recommendation made in 2016 by Dr. Rickett, who told us that if they had any emergencies, or if we had an emergency, we would need data that went beyond the health sector. So our acknowledgement to him, who died, but he was a visionary person, so thank you. I now hand the floor to Myrna. I will discreetly put this 5-minute notice here. Well, I'll try to stick to the time allocated. Well, of course, I am also grateful for allowing us to be here, Dr. Fitzgerald and Dr. Bascolo, for allowing us to participate in this forum for primary care, where we have room to speak of the digital transformation. This is very much appreciated for the people by the people who have been working long years on this. Thank you. And please, I want to tell you about what Sebastian said. Nobody can transform or change alone. Changing in solitude is being a bit isolated.
And I believe that what for in information systems for health, it's impossible to digitally transform the whole health system or the health sector if we do not come integrated. Along these lines, this presentation, which is more of a proposition, tries to stress the vision and priorities of PAHO that Sebastian has mentioned before. It is the view presented by Dr. Barbosa. Basically, this timely and equitable access to health innovations, always thinking of the people who have been vulnerated, those who are always left behind, of not increasing the gaps, telehealth, telemedicine, that may truly give a greater and also more effective, if possible, response in primary health care, national health systems that are resilient. They are necessary. We have seen this in the pandemic. We showed resiliency in urgency, but it would be good to be better prepared. And we have to strengthen information systems and digital transformation. Many things have been transformed and updated. Amongst them, the essential public health functions that have been so valued by countries at the times of thinking health systems. And along this line, it's so horizontal, the role of digital health that, as was mentioned by Dr. Vasco in Relaxis that took place, that meeting a couple of weeks ago, digital health is at the center, not as something central, because of course what is central is to have better access to health and better health for everybody, but that in every action and in every function, digital health may be integrated as space to be able to accelerate each essential function, monitoring and evaluation, policy development, and to be included in policy development as fundamental for, as Sebastian said, so that we may advance along this roadmap that we are building. He also just mentioned that we made this theoretical model of information systems for health, where we carried out an analysis of all countries in the region with a mixed model, including a desk review model in those countries where we could not participate actively, a virtual model, and an in-presence model. We gathered a lot of data, more than 300 indicators that describe all that has to do with information systems for health and how the region of the Americas is right now. It's quite encompassing and holistic, but it has lots of relations, some of these indicators, just to mention some, it is highly related to primary health care, and they may be used and valued at the time of making decisions or thinking in the countries or the region what issues have to be considered and why. When we talk about data governance, about being able to set roles and responsibilities, we are acknowledging that there is a percentage that needs to add more countries and that the region needs to advance to a better data governance, which is what finally happens with the sources, and primary health care is one of our pillars for this. So then the development of information products, always the request is we do not know, we are outside political decisions. Well, let's produce more information also focused on primary health care so that it may be understood why it is necessary to have a digital transformation and why it can be a facilitator for the worker in this case. Regarding management and governance, we always talk about legislation and agreements. There is a question that we ask when we gather data from countries, and it is about mandatory notification diseases. Update of legislation on mandatory notification diseases is always way behind the cases that occur, something that hurts me basically because we are talking about vulnerable people or vulnerability, and disability is the least reported because of health. There's very little data. Perhaps they reported to other ministries, hence the four information health forward systems. Of course, risk factors. We are always ready to promote or act on non-communicable diseases, but there are no reports, or very little, because they are not mandatory, this reporting. That is why legislation is so important. There is another weak point in the Americas, and that is knowledge management and exchange. And this has to do again with we do not transform alone, because exchanging knowledge, both top-down and bottom-up or horizontally, and to generate knowledge constantly, knowledge that is useful for the other one for decision making, is fundamental. And that is what data are for. But we need to understand what the others need to know in their daily practice at every level. This is an issue where we are still missing a lot in our region. And digital health, digital transformation, transformation management are key factors to mobilize digital transformation in the Americas. The last point in this question is innovation. How do we innovate in the region? Innovation must be constantly innovated because it changes constantly. But we focus on primary health care in our health analysis. The knowledge on health analysis is very difficult to get and to be really considered. So we should work a bit more in order to analyze and make decisions to be able to improve our knowledge in that area. What opportunities do we have? We have a template here, and the idea is to first mention opportunities. As always, there are many. I believe one of the great opportunities that we realized existed after the pandemic is commitment. There is commitment by people, by patients, by decision makers. The latter is the one that we have to work on because other health issues arise, and what has to do with the digital development or connectivity lags behind. So it's important not to miss that, and that is why we are not alone, and why these associations, this collaboration with IDB and the World Bank is precisely for that, not being alone and be able to push governments not to forget this issue, that it doesn't become relevant once again when there is a health emergency. Everybody is talking about electronic medical records nowadays. Everybody in the health sector, we are all talking about that. We are still needing more interoperability, but that is also something that everybody is talking about, integration. I want my data. I want to see my data from my X-ray. I want my physician to be able to see that. Without saying interoperability, the patient wants it. And decision makers today are speaking about that. There is a lot of advancement in data analysis and big data, particularly lots of movement towards AI. These are truly opportunities because nowadays they hear us, they listen to us. I say us, those of us who have been working for many years in digital health, and we used to knock on doors and they were not open, but now they are open and there is room for these discussions. A forum like this, so important. I think it's really a big event for us and critical factors for success in order to strengthen primary health care through digital transformation of the sector. Sebastian said it before, digital infrastructure that is robust at every level of the health sector. We are truly lagging behind in many places in robustness, and as he showed in that map, as Luis showed, the poor quality of access in some areas. We celebrate access and connectivity, but it really is not good. So many things cannot be done. Becoming digitally literate in a continuous manner for all of us, using and being part of the health system, that is the whole population, to be able to create a model framework to follow up and assess the implementation. Well, health system programs are hard to assess. It's not something very easy or nice for those working in public health. It's something that you want to do, but in practice it is quite complex. But for our area, it is very important. And of course, to go on and advance towards a more agile legislation, particularly regarding data exchange with the definition of roles and responsibilities. Key indicators of yield, well, to be able to adopt or greater adoption of electronic health records, that there is digital access by the patient, that is more commitment of institutions to provide the patient their portal, their place where they can have access, greater use of telehealth, automating administrative processes, and achieving connectivity. Areas for collaboration that we may have, and we already have, but they could be increased to align our visions. That is key because countries get confused when different agencies appear, and we think we are talking about the same, but it is confusing, and they are right. Technical cooperation that is coordinated and articulated with a work plan, a joint work plan, to collaborate in the creation of tools and conceptual models, strategic networks in which we participate, but also to join other actors. It is fundamental, and also together with the co-creation is to create educational proposals and create alliances with educational institutions in order to promote digital literacy.
To end, I think that the most important thing to work together is to act at practical level. We have models, strategies, mandates, commitment that has been renewed in 2018. We must begin to move and act more on the field, connected those who are not truly have a disconnection map to advance there and accelerate digital literacy. With this, I think I am ending. In the Standard Declaration, they said technology will drive the success of PHC, among other things. So it is time to act. Thank you. Thank you, Myrna. Thank you for sticking to time. As we said, we'll now include country presentations. It is a pleasure for me now to invite Felipe Proenzo, Director of the Primary Health Secretariat of the Ministry of Health in Brazil. And we're grateful to him because we're about to sign an important cooperation agreement in the areas of IT systems and digital transformation. Thank you. Good morning, everybody. We will now tell you about the Brazil experience, focusing on PHC with a series of items that are important in relation to the digital transformation. We speak of the Brazil experience. During that administration, we created an IT secretariat with digital health. But to contribute into today's discussion, we are more interested in speaking about the experience of primary care. Although all that has already been said in the two first presentations are quite essential, I would like to highlight this concern we have in the Brazil Ministry of Health, that is that the digital transformation shouldn't generate more inequality. This was discussed because we are a continent, but when we speak of countries with great inequalities, the digital transformation must be presented as a public policy, as a path to decrease and tackle inequality. And that is a concern we have. People also already spoke about the dimension of our country. We are over 5,500 municipalities. We have a system articulating the federal government and the 26 states and federal districts, and the people who implement PHC every day are the over 5,500 municipalities. This country has over 210 million inhabitants and many health regions where there is another challenge, that is to discuss this in a regional manner when we're discussing the digital transformation to strengthen the health system and in turn strengthen PHC. We have a series of complexities and challenges in the health system, always strengthening the essential part of the public health system. We have a public administration law. The system is publicly operated, and this is conducted by municipalities and all the people who are in the family strategy. In the other presentations, people didn't speak so much about provision and professional stability. We have family health teams complete in Brazil with a family health strategy, and they are qualified for health care, and the workers must participate in the system. And we need to consider the regulatory matters in the system, including digital health. And we're currently speaking of the second generation in regulation in Brazil to access to tests and special care and admission. And this is done in a joint manner when discussing the digital transformation. As for funding, it must be created, and we are significantly extending health in Brazil for next year. And then we have the challenge of governance among the different agencies, the federal, state, and municipal levels. After locating these challenges, we will be better able to understand PHC in Brazil. And for this, it's important to have further information. 85% of the municipalities with a broad territorial distribution have under 50,000 inhabitants. 1/4 of the municipalities have less than 5,000. And in this scenario, the implementation of the digital system for the health system and PHC for primary health managed to reach a public supply of 86% of the Brazilian municipalities. So some have their own systems, private systems, but we have this public supply of a system for PHC at digital level that is used by 86% of municipalities. And this is a 10-year experience of installment. The SUS PHC for primary health care has its major strategy to restructure PHC information at national level, adding the information of everyday work of the over 5,500 municipalities, knowing that the qualification of the IT information is essential to improve quality of care in the Brazil population. And after that general information about our system, I will share more specific information that even has a conversation with the two first presentation. The SUS streamlines resources and data concentration of data in one place with the IT structure. We have over 1 million procedures recorded daily, be it health care, home visits, vaccination procedures and others, prescriptions, requests for tests, and all this is done via the public system that also makes viable the systematization of the information, making it available via monitoring and assessment by public managers or for research conducted at university level. And this availability of clinical data within the ethical limits required for personal information of the people cared for in the SUS. So we avoid duplicating records, and if somebody moves in the territory, may have the information available for the health team. And in this way, we have this possibility of having the tools I will now share, such as, for example, prescription. In the 10 years of the SUS, we managed this system that is used by a very important part of municipalities with primary health care in Brazil, and we envision new possibilities that will also be shared. And one is extending the use of SUS for services beyond PHC, and this is a manner of considering interoperability. And directly with the same system, there is a possibility of telehealth, teleconsultation, and interconsultations, articulating with the telehealth hubs we have in Brazil at the different universities, with the health secretariat, the possibility of sharing care using the SUS and the electronic case history. Many of the community health agents may conduct the home visits, bringing the information that they will feed on with SUS PHC with a collaborative analytical intelligence collaborative network. This is an initiative of the Ministry of Health, municipalities, and states. But this has already been said. We need integration and a joint effort, making available open data so they may be assessed and used for research. And another element that was discussed, the need to educate and make people digitally literate. So one of the current discussions, together with a new national policy for specialized care, is an extension of the SUS. We have many tools for primary health care, for recording vaccinations, to report diseases. And now we have a system that was created and developed at PHC level that is being used at the units for care and mental health departments and outpatient clinics. So it's a tool developed in PHC that is being used also in more specialized care, that is, managing to have many networks, understanding their need in the health service. Another item is interoperability of SUS PHC in the hospital system. We're progressing in this use. Another new tool in SUS PHC is digital prescription. We have this possibility of printing a prescription, but together with the new SUS modes, this is done with a digital certification, and we're progressing to make it be sent to the patient so they receive this via the mobile to know what is the best way. And this is a public tool made available by SUS. Another essential matter, because we have the telehealth hubs in Brazil providing support to second opinion for training, teleconsultation, interconsultation. This is all available in SUS, and we have the possibility of video calls, and this tool is available whereby the family care physician describes a clinical condition to a specialist in the territory, and they have the possibility of having a second opinion and the need and relevance of admission in a specialized service. So SUS PHC is a communication tool in the system to coordinate care within the family health team. It's also a way for a system to uptake access of people to PHC and manage to assess which are the demands for continuity of care. From the antenatal care to the first prenatal care consultation, the system programs this and therefore also follows up the frequency of consultation.
So these are a series of possibilities, of functionalities that show what is being developed regarding digital health, digital transformation, which is one of the priorities at the federal environment, but also at the municipal and local level in Brazil. And that incorporates new possibilities to SUS, just as the experience of the users, so that we may have a national parameter and we locally know how that user experience is. We are doing that through the NPS. That's a tool that's being incorporated. And finally, as has been said before, we need educational processes. We need training processes. And that is why, together with the Secretary of Work and Labor and Education at the Ministry of Health, we are discussing tools such as Educa, ISUS, APS, so that there is this digital training for workers, for health workers. So we think that this makes sense because of a road that is considered as a strategy of family health with this approach of public primary health care in Brazil that strengthens our public health system, and we need to work so that digital transformation is also there to combat inequities. And we think that with these initiatives and tools, we are struggling against inequities. Thank you very much. Thank you very much, Dr. Felipe. Congratulations for what you are doing with ISUS, and through you, my thanks to Secretary Anici for all this. And we also wanted to acknowledge Dr. Anastela Das, Vice Minister of Digital Health in Brazil, and the whole Brazilian government, because it is the first country in the region to have a vice ministry devoted to information and digital health. It's a very interesting model, so thank you very much for your presence. I wanted to stress and thank, we have key representatives of USAID and the State Department, the health sector in the USA. A lot of what we have been able to advance in PAHO was due to the financial contribution we received during the pandemic from the U.S. government. So since we have the presence here of people from the USAID and the State Department's health sector, we wanted to thank them. I am now very pleased to introduce Jennifer Netson, a colleague and friend with whom we have been working for over 5 years. We are working together on information systems, digital transformation, and also to stress the presence of Sergio Pablo Alex. I don't know if there are other colleagues here, but we have worked a lot together. This started a long time ago. Of course, not just Pablo, but also Fernando Regalia, who was one of the first persons who met with Dr. Barbosa to say that IDB supported this initiative of information systems, and from there we built a road together. So you are introduced now. And look at this sign. Thank you very much, dear colleagues, and particularly Marcelo from PAHO, because, as he mentioned, it has been a real collaboration. We have trust and facts, and so we are excited to have more people in groups joining this effort. I would like to talk a bit about how we are working to leverage the digital transformation and to update our health systems. But before starting, I would like to ask you why you chose this room. So show your hands who is really excited about the opportunity of digital health in PAHO. Well, good. How many of you like change? Oh, I'm surprised, because now I want to be honest. I want to know how many times have you been frustrated when you have to change from your Apple or iPhone or from your office, where they told you now we have a new form and everything will be easier, and you start saying, So we remember now that feeling that transformation is something positive. But part of my presentation today, I want to make you feel awkward, because something that we have learned together, Ernesto told me years ago, if you don't feel a bit awkward, if you are not a bit tense, you are not learning. So let's hug this tension and embrace these changes. Here, just to open some of our views and priorities, our views and priorities we have for the health sector, because the main message here is that salud is what leads to the change that we are trying to reach. And digital tools are in support of achieving the things we want to achieve, like efficacy, quality, and equity. And particularly here for primary health care, we decided to stress some important things that we have worked on jointly. One is to make sure that we really have integrated health services, based on primary care, and the digital health, as we have seen in the previous presentations, that data can be easily moved between networks. And we also heard in many presentations, but particularly in the morning panel, the idea of intelligent health, preventative, that we have an intelligence to use our data and to prevent suffering and health expenditure that can be avoided. And clearly that this is based on the patient's needs. And finally, as Sebastian mentioned, and Mirna too, and that we heard 2 weeks ago in the Relax 4.0 event, the importance of thinking of interoperability for digital health. That it means that I do not, that it doesn't matter if I change city, neighborhood, or country, that I can effectively share my information. I can ensure the same quality and continuity. Beyond that, I would like to show you an example of something that was created in one of the countries that we are pleased to work in. PAHO, World Bank, we are all CAF, we are all working in El Salvador, and one of the things we think of is that because transformation makes us feel uncomfortable sometimes, we said, okay, shall we be able in 6 weeks' time to work differently, to work in a transdisciplinary manner to solve a problem, which was how are we going to prevent the prediabetes to become an important problem in the country. We'll see a video. No, we'll see the video now. Welcome. This is a program of accompaniment of patients with prediabetes. Everything starts when Alex goes to her visit, where unfortunately she is told she has prediabetes. The doctor explains the severity of the situation, and today with the diagnosis, she prescribes her now program. On arriving home, she receives a WhatsApp message to download pillars. She completes the registry or record and programs a teleconsultation with a specialist in order to create a personalized plan to fight her prediabetes. And with this, Alex can really be ready. At the end of a televisit, she sees the commitment that they have made in the teleconsultation. By confirming those commitments, she will also add an ally to help her struggle against her prediabetes. So she adds her best friend, Carlos. In the week, she opens her app to see what rebates she has with pillars. But first, she has to see whether she has fulfilled her commitments. Then she can see discounts and gyms, find recipes, see advice, and a lot more. In the app, she can also see her progress according to her commitments, and our physicians will also have access to all this information at the time of the next follow-up in 6 months. But as is always the case, after a few weeks, she is no longer motivated. She stops eating healthy and ignores our warnings. So in that case, her friend Carlos, whom she added as an ally, will receive a message to give her a nudge. With Carlos's help and with all the pillars functions, despite difficulties, Alex really stays healthy. Pillars, a program of the Ministry of Health. Then, one of the most important things here is not just to see that we have an app and we do not want to fall into the trap of knowing that we'll have several bullets that will solve problems. But what I wanted to show here is a way to work that is different when we carry out our own exercises, how we can create different solutions and try them on the local people for 6 weeks. The whole team at the ministry could create this idea, validate it, and also talk to patients and actors in the field to give feedback to the solution. And probably this solution will need adjustments, but the idea is when we are breaking the silos and work jointly, try to solve a problem, we can do different things, and that is a transformative part that we have to focus on. And here I would like to stress why this is an opportunity. This is just one example on how the expenditure we can reinvest in our sector, preventing 5% of diabetic cases if they are identified as pre-diabetic cases and they do not advance. We know there are digital therapeutic apps that can show a reduction from 5 to 30% of cases. So taking those opportunities, we could do things to really improve accessibility, acceptability, prevention, and equity, which is what we all want. But what are some of our challenges? And I want to stress, well, we have already mentioned some of them, but I would like to see a different approach to the things we are seeing. If we look at the table first, that's a study that we studied, a survey in May to August 2020, to study in 10 countries the acceptability of the using of technology during the pandemic. And perhaps it's important to see the importance of use of technology like a smartphone. We have a high adoption rate, and when we see the relationship of social media apps or instantaneous message, we have a very high penetration of these in our region. Other types of digital services like online payments, we still have to grow, and we are now about to repeat the study to see how the pandemic changed this. But I leave you with two ideas. If it is true that we have to work a lot in digital literacy of our health providers and the population, but it is also true that we have to be attentive to their expectations and compete with the services they already have, because people could use a boarding pass that was digital or are talking with their friends on Facebook or TikTok or whatever is more fashionable at the time, because those things add value to them. If we are not sure that we are really adding value, we will not have the impact we want to achieve. So people adopt things that function for them, and we cannot use this as an excuse for not delivering things as we should, and to compete well, in the good sense of the word, with those actors who are really reaching people. And as you see, we are working together, this map that I would like to share. But I would also like to mention something besides what Sebastián said, the importance of working with government. I also believe that we have to make people aware to see how that is part of our work. Advocacy of our sector, that we are connected and working with government to make sure that is part of the agenda, but we cannot afford to wait for this to be solved. I don't know if Jamaica is present here, but tomorrow they will present it. During the pandemic, we worked together, digital, government, and the health sector, of course, together with PAJO, under this HC4H framework. Government said, I cannot wait till digital government solves this problem. So we have a public partnership that in a year they could connect all the primary healthcare centers.
So we must think that this is part of the issue, and we are committed. The pins I have here are part of the 8 principles we carry close to our heart in our agency. Universal coverage is an issue for our health sector, and we shouldn't forget it. And this just to show how the different factors for success that mention these principles. And thank you for Sebastián for highlighting them. We also lever this matter to balance our investment and use a metaphor of the digital class created by ISO that we tailored. And we're increasingly satisfied to have countries create their own digital houses. But we must recall we are investing in a balanced manner. You can't design a house without a wall, a bathroom, a roof. So we need a similar concept. We need a blueprint, a digital health strategy. This is part of governance and management, and we need a multidisciplinary team that allows us to build this house. And when we consider in an example, this is one more room in the house, maybe in the first floor of PHC, but we won't have a fit-for-all solution. We will work with different systems, the same as electricity and water flowing in the homes. And now some key performance indicators. First, the orange, that are very aligned with those as presented by Myrna, are how to create true added value. Are we truly saving time for people? Are we avoiding long travel times to have impact on climate change? Are we reducing the waiting list? And are we acting on the issues that impact on people? And if not so, we're not really changing things. And in blue, product indicators to see if we're progressing here. But the core is the orange that are key. And we must measure since day one. And how to work together, doing what we've learned. And this started in Jamaica. And it's so important to have one single plan managed by government. We don't have a PAHO or IDB or World Bank plan or CAF or whatever USA. Of course, we could have thousands. The issue is that government should have one vision and strategy, and we should add on so government achieves what it wants. This has been our vision and joint work, and this has been an achievement because 14 countries have already worked together to create these strategies. And these are the key matters that allow us to progress. And for the future, continue with balanced investment, building with the approach you mentioned a couple of weeks ago in Relaxes. So we raise the standard in countries. We're not going to only have a national plan, but have a regional one with ISA 4H 2030. And I stop here, just reminding you all that tension between the digital and the transformation. It's sometimes good to feel uncomfortable, and here's some tools you may have seen. Our flagship was published last year. There's a lot of monitoring that Marcelo mentioned, and things to measure where we are, how to act, how to procure and assess and implement, and particularly related with PHC. If you want to tackle primary healthcare issues, they may be of interest. Thank you.
Muchas gracias.
Thank you, Jenny. I wanted to underscore what she said about this one agenda, one country study. When in 2018 we presented the information system action plan for the board, there we had for President represented by Marcelo Cabral at the meeting. 18 ministers of health took the floor, and apart from supporting the resolution, they highlighted joint work. That was the message we had of these 18 ministers of health at the board. I also wanted to highlight the presence of CAF. We have Alberto here and Pablo, with whom we have had discussions in El Salvador. Jenny mentioned it. And excuse me if there's somebody I missed. I wanted to ask Juan Pablo to allow me to have 10 minutes more. Good. So, apart from calling Germán Hernán, the Director of Digital Health at AGESIC, I wanted to acknowledge the fact that 16 years ago, Uruguay had this vision of creating a national agency for the IT society. We had the honor of participating in the launch, and something that might seem natural today, 16 years ago, occurred for this information society. And of course, the response of Uruguay in digital health in the pandemic wasn't a surprise. Please, Jimena. Good morning. I have the pictures of that period. First of all, thank you for inviting us. It's an honor to be part of this panel. The leitmotif that has led us throughout this period has been this idea that the health digital transformation cannot be isolated. It needs a digital transformation process in the country. That's why I wanted to start with these figures I can now share with you. These correspond to the small country of Uruguay, 3 million inhabitants, 12 million cows. And ultimately, these are the figures that currently show the connectivity in Uruguay. 91% of homes have access to the internet. 90% of people over 13, likewise, have internet access. 83% of Uruguayans use it daily, and we've reduced the territorial divide to 7%. In a country characterized by having most of the services centralized in a country, managed to have this decentralization process basically through the digital transformation. As Marcelo said, in 2007, we had the Electronic Agency for the Society of Knowledge. It's a long name, quite pompous, that had a privileged place in the government structure. This agency works within the presidency with a strategic vision for the whole state. We're not a ministry, but rather an organization that is part of the presidency. During the first years, we created everything regarding regulation and creation of institutionality. We needed an agency, but had to start to base our work together with all the state players. Of course, the regulations, to which we will dedicate a special chapter, to the construction of infrastructure, investment technology, safe platforms, particularly government platforms, enabling us to integrate different public agencies, facilitating information exchange. All this was part of the creation process. Another issue also mentioned is cybersecurity, that is cross-cutting since the beginning to date. And the digital transformation in health is an essential access in our platforms and together with the health agencies and community creation. We really need to be quite convinced that technology is a means and not a name, because we just don't want to include technology, but just as a means to allow us to provide better services, health services, and equality and access to users and patients and inhabitants as a whole. When we speak of a global digital transformation, as for the regulatory framework, it's quite essential. People are at the center of all our digital transformation actions, and particularly at health level. We want people to have better health services with the tools provided at technological level. The regulatory framework was complex to design. We wanted to have basic rights at digital level with personal data protection that is essential when exchanging information at health level, with empowerment of all individuals with their own health information and being able to decide with who to share it, be it within the country or elsewhere, wherever we are in the modality chosen. Access to public information, digital signature, and identity. We needed to provide security to transactions. Digital transactions need security about the authorship, who's behind a digital transformation, and similarly in the health ecosystem. This is cross-cutting for all digital transformation processes. Information security, secure environments with all necessary measures for our systems to be protected to any sort of internal or external attack. Interoperability, information exchange, that is essential for the health digital transformation. People need access, but that the information be accessed in a timely manner to provide care. Inclusion of digital systems for citizens with affordable mobile services, and our specialty right now, the national clinical record. It was hard to build because although we were quite convinced that we could have a clinical record that wasn't a hard copy, we had to convince others, and part of this was through the creation of clinical standards, parting from the national clinical record, but then with many standards, adding on and extending access to people, making available their clinical information to access it in a simple and effective manner. And of course, telemedicine, and this was by chance because it started in Uruguay 10 days after the pandemic was declared. This law was passed right then, and this was by chance, but telemedicine then mutated by things that weren't even conceived with the law. The pandemic really marked the digital transformation at health level, and other examples that are being strengthened. The state creates digital health, AGESIC and the Public Health Ministry, but the whole community, the private sector, small enterprises, software companies that favor this ecosystem. And this is part of the digital government commitment, access, and so on. Many standards that contribute to the digital transformation, and particularly at health level.
We also have the idea of saying, where can there be a certain success effect or experience that we can share from Uruguay? And I believe it is the possibility of having a digital strategy. That what's digital is part of an agenda that the country is considering, and it is an agenda that we work on with all involved actors, including creating objectives and goals that the country has to fulfill. And in that digital agenda, digital health is not alien. It's part of the digital strategy of our country. And I go back to the beginning of what I was saying. The digital transformation in health has to be part of the digital strategy of countries. Digital agendas that are encompassing is an interesting strategy. In these 5 minutes that were given to me, I just share that this is not something that you do overnight. This timeline only shows some of the main events that we have gone through today. I'm leading it, but many people in the room have participated in the process of digital transformation in health in our country with that motto, continuous and sustained. The goal was a national medical health record interconnected with quality information, and we enlarge that objective and generate better services. That is just so that you may see that process of transformation that started also with an innovation from the point of view of the integrated national health service, and a different idea of the services that providers give. It's collaborative work with INGLES, with the Ministry of Health, which is the steward of health, the one that determines policies in health, and with several of the technological tools we may create. We provide tools to the ministry as decision maker in health to make informed decisions with true accessible information. That is, finally, the goal that we are working on from digital health, from INGLES, with that wide collaboration and with the collaboration of all the agencies that support us in creating this digital health strategy. That is what I wanted to share with you, so I think I'm on time. Thank you very much. I don't even want to look at Juan Pablo so that he doesn't signal that it's late. I was hiding and now he changed places. Without further ado, then we give the floor to our colleague and friend, Gianluca, from the World Bank, with whom we have started joint projects in Panama, Dominican Republic. So I do not want to take long so as not to take time from your presentation. Please, Gianluca. And Juan Pablo, please don't signal. Thank you very much, Marcelo. Thank you, all the colleagues in PAHO, for your invitation. It's really a pleasure to share the table with so many friends. I liked the introduction made by Jenny on management of change, so I wanted to introduce another important concept by asking how many of you right now are a bit hungry. Please raise your hands. Well, but you will hold on, and that will show how digital health contributes to people's resiliency, which is another important concept. Well, good morning. The presentation, I wanted to start it by stressing an important factor, which is the time factor. It has been said before, we are really at a time where we have an opportunity to go on investing and obtaining value from digital health and the digital transformation. Three elements that really have come together. There's a critical mass of knowledge and experiences that have accumulated in the past 10 years. There is also investment in digital health that have occurred in the region in the past 20 years, and there is also opportunity, potential, one amongst them, AI. So having knowledge, previous investment, and potential together really gives us an opportunity to go on working on this together with the countries. This is a road, and it's good that we saw roadmaps in several of the presentations. From 2002 with digital development. And I stressed a few events that were important, particularly for primary health care in the region. One, 2016, the development of information systems for health by PAHO. Then in Astana, it was repeated that one of the 4 commitments in Astana was to work on technology and in digital health. And more recently, the roadmap for digital transformation in 2021, signed by countries in the region under the PAHO leadership. So these are important events. These are events to which we will contribute together. The most recent one, which is related to the World Bank, is the publication of Digital in Health. That's its title. Digital in Health. He translates it into Spanish. We have just launched the summary version in Spanish this week. And the idea is, through this title, to express the World Bank's view on digital health for this time and for the future, which shows the roadmap also, going from digitalizing, just digitalizing, to seeing digital for health as something that could add value in health. And now probably after the pandemic, the paradigm shift is to see the digital and health as a single thing. If most services in the future will be digital health services, then when we talk about digital, we are talking about health, and we have to think of how digital is part of health, digital in public health, in health funding, and in this case, in primary health care. Here, the support for countries where the World Bank has been working in recent years, we have identified 4 pillars. The first one, which is prioritization strategies. Second pillar is technical assistance generated in evidence for efficacious interventions. We have worked together with PAHO in Panama on telemedicine. There are experiences on data governance, health data governance in Peru, the development of projects and support and implementation of these projects, electronic health record, telemedicine. We should stress that in Argentina this year, in August, we launched the first WB project in digital in health as focus per se, and we are now working in the design of a new digital health project in the case of Colombia. And particularly after the pandemic, many projects have components or activities in the field that is becoming ever more central. And the last pillar has to do with training. We have flagship for health professionals. In the past 2 years, we have carried out one in Ecuador on primary health care and another one in Argentina on health strategies in more general terms. Regarding opportunities, there are several. I just mentioned 2. One, in a post-pandemic world, the challenge we all have is to go from services that were born as response systems responding to an emergency to integrated services, integrated to delivery of services, digital in health. And telemedicine is a good example of this. We have worked in Panama, where in 2021 a law was approved on telemedicine, which provides guidelines for the implementation of telemedicine, and a COVID response program was generated with some innovative elements because patients were called. They were defined through digital data banks, protocols and referral mechanisms were built, and the possibility of having prescriptions after teleconsultation, and all that as a response to emergency. It's not working. There. That had an important number of consultations, and with this image I want to show that beyond Panama City, guaranteeing a good equity, geographical equity, And now the challenge is to integrate the solutions that were given as a response in health services. So our support right now is in the development of a master plan of telemedicine for investments that is especially focused on smaller or more vulnerable populations, also in rural areas and urban areas. Other opportunities, we cannot ignore the issue of AI and wearable devices. The epidemic that we are now living is also a data epidemic of personal data that will go on increasing in the coming years. So the challenge is how can we use this data, this personal data that will always be ever more in surveillance mechanisms so that we can have predictive information for predictive analytics in primary health care. And that gives you an opportunity also to have predictions on non-communicable diseases, but also they pose important challenges regarding, for instance, privacy and cybersecurity. It's an opportunity, and like every opportunity, it is also a challenge, but it is important to consider that for the future. Care always more virtual in terms of primary health care, and also with services that are less traditional, such as physical therapy and mental therapy, mental health, that can be done at a distance, and the opportunity of using digital data for better management of performance. An example that we have is Colombia, where we use digital data and we defined indicators at subnational level to identify the strengths and weaknesses and thus contribute to better performance of the health sector. Challenges. Two are historical challenges in the region. One is that of fragmentation, which is of health systems fragmentation, which is reflected in fragmentation in information systems also, and of donors. The latter we are solving quite successfully, so we stress it less now. Then equity, the most unequal region in the world. We used to talk about connectivity before. 650 million people in the region, 200 million have no connectivity. So it is truly something to consider.
And another challenge that will probably increase in the coming years, that's the issue of privacy and cybersecurity, where we will always have to pay attention. As for the factors contributing towards success, I will briefly mention these recommendations that we identify with this publication we just mentioned, digital health, and related with the digital health principles already mentioned, and related with 3 areas, that is, prioritize individuals and particularly the more vulnerable, connect, and there we refer to leadership, data governance, digital infrastructure, and the information divide, connecting people at regional and global level, as we're currently doing. And the third area is scaling up. So we need to invest on education, promoting partnerships with the private players, and thinking digital health as something beyond health itself, identifying funding and implementation systems. In order to be successful throughout, I will focus, well, I only have 1 minute. I wanted to highlight the fact that we need to collaborate. It has already been said we have to have a joint route or roadmap defined by the countries trying to work together. It's important to highlight the possibility of considering global experiences and consider how they may be relevant in the region. This is the example of Serbia. This is a very good example for the capacity to develop an interoperable clinical case record in 6 municipalities with strong regulation from the Ministry of Health and economic incentives. And now to conclude with indicators. This is an example of telemedicine to highlight indicators associated with the priorities. So based on each specific priority, we can link this with an indicator, and we could have something similar with the electronic records. So the percentage of primary health care centers with connectivity as a condition to have a health service, the percentages of primary health centers using telemedicine services, an use indicator, percentage of APS PH centers providing at provider telehealth services. And this contributes towards solving inequalities, and percentage of PHC centers that implement referral using telehealth. And this is a good indicator for health integration, and ending with the patient experience, percentage of PHC centers where patients reported a good experience with telehealth comparable with the traditional service. As areas of action, we mentioned continuing to work with IS4H, digital health knowledge, collaborating through a coordinated agenda for implementation of digital strategies with electronic health records and telemedicine. This to highlight 2 good experiences with PAHO. We hope to replicate with other IDB partners in digital health, both in Dominican Republic, where we work together with the IS4H maturity model and a telemedicine model for Panama. We're closer to lunch now. Thank you for listening to me.
Hay pocas cosas que me gusten menos que controlar el tiempo.
Well, it's not nice to have to control the time. So we must end. Thank you, everybody. We'll later have more time. Well, I thank Pablo and Tania, but time is up. So a round of applause for all the panelists. Thank you, Marcelo. We're the good and the bad cop. I also want to be the good one, so I'll chair a panel in the afternoon, and I hope to give you time enough. Let's go for lunch like yesterday, and then we're back to the plenary in the afternoon. Thank you.
No sé por qué no terminamos esta.
fijándose para empezar nuestra jornada de la tarde. Con el trabajo de este foro regional. Damos un saludo también a los colegas que están conectados a distancia.
People are connected at a distance. The group that is arriving today, we shall start with the implementation axis. So there's great expectation. Our greatest challenge is implementation. So we shall have 2 plenary sessions in this room. We will not have the other room apart. Now we are having a conversation that's called the implementation of PHC with a territorial equity approach. Now, Jonas, please. Well, thank you very much, Laura. Good afternoon to you all. Laura Mónica. It's the coffee that's missing. I wanted to be the best moderator, and it has already got complicated. Anyhow, you know, we have a new mantra to relax and innovation, innovation in implementation. And we start in implementation. We start with the final one, implementation. We have a luxury panel. The keynote will be Ernesto Váscolo, whom you do not know, of course. Ernesto Váscolo is head of the primary healthcare unit and integrated healthcare delivery at Pajuju. And we have to say that he is really a promoter of what is happening these days. Thank you, Ernesto. We shall also have with us Eduardo Guerrero. It's difficult to synthesize his trajectory. Today, He comes with a special hat that he has had for a long time from academia, from the university, and as president of the Colombian Association of Public Health. But he is experiencing in international cooperation and health systems and services, including having been a member of PAHO, is really very extensive. Then we also have with us the participation of the Inter-American Development Bank. Irma Iriarte will be here. We invite her to join us. She is originally from Honduras with a ample experience in implementation, and particularly regarding projects in Central America. And finally, a country experience from Brazil. We shall listen to Olivia de Medeiros, who is coordinator of interprofessional actions in primary health care from the Ministry of Health in Brazil. Be welcome. Without further ado, in order to take advantage of our energies and time, Ernesto, please.
Buenas tardes.
Good afternoon. We have considered this time the most challenging one after lunch. So I have not prepared any sketch or any motivation because we do not have time. So I will go straight to the presentation. I'm waiting for it to appear on screen. But while I wait for the presentation, I would like to tell you that it is divided into 3 parts. One of them, thank you very much. Next. No, I can use it here. Okay. The first part is not just an introduction. It has to do with the fundamentals that we could consider at the time of emphasizing implementation with the different logics, different from just thinking that there are these traditional stages of design, planning, and evaluation, but to think of implementation as associated to knowing the territory as a fundamental space where things happen, where transformations take place. And that has to do with the fundamentals because I will share some critical arguments. Critical not just because they're important, but because somehow I would like to share with you a critical perspective on policy-making processes in the past 20 years. The second time, for me, is to really land on the territory as a dimension and a space that determines public policies, thinking that beyond certain levels of influence at the macro level, and the territory is where we can recognize an integral management and the relationship between services and population as a key element. And when I talk about services, I don't mean just individual services, but the whole or the set of public health interventions, population interventions, even with incorporation of an intersectoral approach. The territory with a space of truth where actors and strategies are articulated trying to solve the problems of the population.
And in this framework, when we speak of the territory, we need to incorporate the access dimension and equality in access to health services. And last, something that in the past years, but more recently, quite clearly, with the new administration at PAHO, apart from the mantra of the 3 I's, we have that mantra of this need to go from hands off to hands on. And that's why we have these three mottos for primary health care. And we also need our technical cooperation working on concrete elements guaranteeing certain effectiveness in the countries regarding their health system capacity buildings based on PAHO challenges. First, I must highlight, and I think Juan Pablo said it when we closed the meeting, it's not that the countries have slept a long nap in the past decades. And the first 2 decades of the 21st century experienced quite interesting fiscal conditions in the region, particularly Latin America, and also in the Caribbean. And this was an outcome of different economic and fiscal conditions, but also a political decision to increase social expenditure. And one of the destinations with a great share was increased public spending. On average, I'm not specifying any country in particular. I know there are large countries where the challenges for public funds are great. But in general terms, when we discussed yesterday what we could imagine for the future decades, we imagined this need to increase 30% of public expenditure. And this is an increase we had looking back in the past 2 decades, and it's quite a lot if you analyze history long years before. So there was a significant increase of public funding that once again, on average, was translated into a reduction of out-of-the-pocket money and one of the barriers to access health services. However, these changes, in very general terms, were framed in reform processes that wanted to modify the funding model and generated incentives with the new architecture to improve transformation of the health service organization. But this didn't necessarily become or have a significant outcome in health conditions, particularly access to health services. Although WHO and, of course, PAHO, where we monitor, well, one of the indexes regarding coverage acknowledges significant progress in the region for coverage related with some indicators linked to the services incorporated in the countries as part of these policies towards universal coverage. It wasn't necessarily an increased coverage with a service conception, at least so when we analyze this significant increase of insurance. That's a manner of achieving increased coverage, bearing in mind the population with the manifest coverage. But the translation of these improvements in increased public spending, reduction of the out-of-the-pocket spending as a significant element, and increased coverage conditions haven't necessarily been translated into a substantial improvement in the capacity for response in our health systems to respond to the different sorts of hurdles to access. And of course, this impacts still, even before the pandemic, avoidable deaths that could have been avoided if we would have access conditions to quality services. And when I speak of the important weight of the access component, I wish to underscore the fact that, unfortunately, the scarce progress, even in terms of inequality to access, as another central item. We're not only counting a population that has or hasn't the possibility of accessing, but in general terms, and yesterday much was said in this regard, we part from structural conditions of social inequality that are translated into inequality at health level, and which unfortunately we haven't really changed in a substantial manner. And this is also reflected in different sorts of barriers. As mentioned, apart from financial ones, organizational, institutional, cultural, well, they still weigh significantly in our countries. And even when we compare in time series, analyzing contents of the reform processes that several countries in the region had, we have increased conditions for insurance. In case of Peru yesterday, we had a nice discussion where the Vice Minister mentioned important progress in the universal insurance condition, not necessarily translated into improved access conditions. And when we told about the view we have about the countries with a greater scope for coverage in terms of insurance, with improvements and reducing certain gaps in different insurance systems, and therefore this could be interpreted as a proxy for equality under those conditions, using the health services when the population needs it. But these outcomes are not translated, as we said before, in terms of equality and access. And now to the core of my presentation. And this is, in my view, one of the points associated with the territory. The context matters. It determines many of the factors regarding the approach towards organizational, institutional, social dimensions that might improve the capacity of response in our health system. Context matters. Diversity of territories in our region, and even diversity of territories within the countries. There are different social groups where these factors that might be a barrier to guarantee the capacity for response must be necessarily honed into, to interpret and understand, to know which are the best policies to act upon them. And it is in this framework that I think that a trap would be considering the territory as a recipient of national implementation processes. The territory is an area where, in most countries in the region that have made significant progress, the change processes part from the territory, not from a wonderful design built in a vacuum, but it's always related with the country's history, and not in terms of the literature, but in terms of the experience in the territory. So what occurs in this diversity of situations, because a trend, the unavoidable narrative where we summarize the situation of country with an average, often hides very interesting situations of very essential innovations that are not related with PAHO, IDB, or the World Bank, but are related with a set of players that have a certain diverse and strategic positioning in a concrete area that encompasses public state institutions in the territory, a municipality, a region, or whatever, but professional and union groups and academia. When there's an interaction among the stakeholders, an agreement and commitment, and they build this, that is a social and political process that isn't magic, and that is the transformation of the reality starting from the issues in the territory. Of course, this can go hand in hand and have a conversation with national processes. There are communication channels for a dialogue and to negotiate at institutional and political level between the processes produced in the territory and at national level. This is why the application in practice is key. We must acknowledge that all processes to formulate policies should acknowledge diversity and inequalities within the territory as part of its design, but at the same time, when implemented, when it's considered strategically, it is key to recognize which are the main players that will enable the transformation process. So it isn't only a matrix for analysis that is essential to somehow reveal inequality and the relationships or the lack between the population and their needs and the health services or state agencies, but also stakeholders, wills, conflicts that occur in that special territory, to interpret the reality in the countries that is so diverse in terms of barriers to access. It is great. And I say that because the risk of being schematic, defining certain patterns about barriers without acknowledging this diversity are great. And even when you relate this when analyzing a special population in a territory. And if you articulate in the territory the population health needs and the different hurdles to access the health services, and you first have this matrix to acknowledge the issue and analyze the reasons of non-use and relate this with two very important elements at conceptual level: certain social conditions in the population, employment, income, and also certain key social relationships that are power relationships that even appeal from a gender perspective when we analyze condition of women in a certain territory and the level of autonomy to decide about their own health and disease process. And it is in this framework that we must acknowledge those specific issues in a certain territory for a certain population, but also the social and factors and relationships that somehow complexify the population's issues. A major part of these studies have been published in recent document from PAHO called Analyze and Overcoming Access Barriers to Strengthen Primary Health Care, that seeks to build a good diagnosis of the conditions, but also generate policy options together with the players participating in the territory.
Even when we incorporate actors not just in the design of the territory, but analyzing the evolution of those problems, it is very interesting to see to what degree policy initiatives, not just in the subnational space, but often at the national space, have a positive or not, or negative impact on that problem. It is almost obvious that if the policy-making model has only the center of improving insurance and reducing out-of-pocket expenditure, which are important, that doesn't necessarily mean that the other problems will be approached. The problems related to organizational deficiencies or social determinants of health. This is a key point for me because there is a factor that correlates very well with access barriers to health care. These are social conditions of a country, and this is reproduced and amplified when we do a more disaggregate analysis. This is just another way of saying that from services we can do a lot. Initiatives and the logics of reform processes are necessary, but at the same time, without good articulation with the problems related to social determinants at the national level, certain agreements with different sectors on basically on the territory, considering that population problems, it is one of the explanatory factors for our failures to respond better to those challenges. Another exercise we did was the analysis of certain reforms and to interpret which reforms had greater impact in terms of reducing inequities in access and improving access. There's something that's good news because it backs our thesis, which is the PHC conception. We all know, and this was discussed yesterday as part of the discussion with the public, we often do not use the same ideas about PHC when we talk about it. And it is important in this forum. Sometimes it's just a packet of services, sometimes a first level of care, sometimes just a promotion of health. Sometimes it's a strategy with a territorial approach. This final or latter case is the most successful one in terms of reforms improving equity. But above all, this is possible when there is collective action of actors participating in the territory in that process to implement policies. And to close, I know I do not have time. From theory to practice, it is fundamental to link the dots, to see what are the more structural challenges we have in the countries. When I talk about technical cooperation, I mean by PAHO. First of all, we have to acknowledge that there are problems of fragmentation, organizational and institutional fragmentation in our countries, clear weaknesses in that sense. One of them have to do with segmentation in coverage schemes, and this is shown in this avoidable mortality results, conditions of inequity and access barriers. Our technical cooperation works with several tools that I will only mention. I will just show them because of a lack of time, but they point to what and how. I don't just want to talk about what, which is to improve stewardship and governance, public financial management, and service management of comprehensive health services, but how, to what degree must our technical cooperation not just be adapted to context characteristics, but to integrate dialogue and to be an input in the processes of policies and policy where we work and we have an incidence as technical cooperation activities. Whatever the instruments are, there has to be an exercise of problem analysis, study gaps in different ways, different levels, and roadmaps in the policy formulation. Our products and processes have to do with strengthening those capacities and collective actions that are involved in those processes. I do not have time, but we have a wide range of tools working in that sense. I just want to point out that some of these tools have absolutely necessary articulation with political processes, policy-making processes, and the actors involved in different institutional levels. I apologize, Jonas, for having taken so long. Thank you very much, Ernesto. I think that Ernesto has clearly presented the problem for discussion. How do we advance in the implementation of primary health care, bearing in mind the reality of inequity and of barriers, and how this is conditioned and explained and influenced and affected by context and territory. From his role, Eduardo Guerrero, as president of the Colombian Association of Public Health, what do you think about this context? Well, what Ernesto presented is very valuable. First of all, because I've got to thank for the invitation to this forum. This is very valuable forum. I think this alliance that is being born here will have important contributions for the region of the Americas. And on this issue, I would say that my experience, and as a former officer in Pajo, where I was for several years, and from Colombia, where I have returned, and what Ernesto has just said, I would say that this vision of the territory is the one that can lead us to change and transformation. In the case of Colombia, it is a good example because at least in the past 10, 12 years, Colombia has wanted PHC. When I went back to Colombia, we made an effort with different groups for Colombia to have a law, because we always think of laws like the law goes first. If law is passed, everything seems to be done. But experience shows that it is not so. But still, we passed for Law 1438 of 2011, saying that the Colombian health system has to advance based on primary health care. Based on primary health care, it's the first article of this law. And the second one, it has to advance in integrated health services networks. And third, it has to advance with a 10-year public health plan. And fourth, it had to consider human talent. You would say a perfect law, a very important one to be able to advance, that has allowed us in time to recover since 2005, because Colombia has had very interesting experiences in primary health care that arose from that echo of renewed primary health care in 2003, 4, 5 at different times, and it has different sites for that. And you wonder, well, what has happened? Colombia has a peculiarity. It has a health system that does not look at the territory. It looks at people as clients and users of a system of insurance. So it doesn't look at the territory. It looks at the individuals. And that is called individual risk management in Colombia. It looks at the individual. And on the other hand, it separates functions where it says that the state secretaries, the departmental health secretaries, consider collective health risk management. So they take care of public health with few resources, because most resources stay at the individual risk level. So understanding that separation between individual and collective risk with a difference in resource allocation is very important. It is true that at a given time in the financial protection, it's practically 95% of the population. But at the end of the day, that division, which has generated this individual risk study instead of collective, but this has led to a concentration of services of disease in the large cities and in some intermediate cities as well, that allowed us to have a great gap of inequity in access to health services, which we are now trying to solve. Colombia now has financial protection for everybody, but access is inequitable because large territories, the most vulnerable areas, have no access to health services. So it is very important to solve that, and it's part of the challenge of transformation now. When we talk about that, we've got to go back to the territory. It's impossible to provide access to the most vulnerable people if we do not consider them in their context, where they live, where they suffer, where they work. That is where people have to solve their problems nearby in order to solve them. And that is the current challenge that the government is facing. This government is trying to solve with a health sector reform how to bring together individual risk management and collective risk management on the territory in order to reduce the gaps of inequity that we have now. We have enough financial resources. Colombia is one of the countries with a GDP of that is almost 7.5%, nearly 8% of the GDP devoted to health, and it has grown in the past 10 to 15 years, as Ernesto pointed out, for a large group of countries. So there are the financial resources. How do we distribute them? We have a sentence in Colombia that says that financial resources follow the insurer. But right now, we want financial resources to follow the citizens and the territories, because there are many territories that have citizens, but their financial resources do not go back to the territory to solve their problems. So it is necessary for the territory to receive the financial resources so that they, together with their capacity existing there, they may transform the situations. On the other hand, I would like to point out the issue of universities. Colombia is a country that, as you all know, has lived a war, a very serious situation from the political point of view. It has suffered a lot in recent years. It's still suffering the sequelae of drug trafficking and war, but the universities have been present. But universities grew apart from the territories due to different reasons, political, whatever, because of security. The university grew apart from the territory. We have seen in the past 10 to 15 years a transformation that has changed, particularly in the past 5 or 6 years. And right now there is a group of universities that has a hope to return to the territory, and not to concentrate its training of human resources at the university centers, but that they may take education to the territory. We are now talking about a proposal that we have built of the territory school or school territory. There are schools at the territory. There are primary schools. There are daycare centers, places where they take care of the elderly. There's a lot of protection of self-care at the territory. If you look at indigenous communities in Colombia, they have very valuable experiences where self-care and the care of communities is very valuable. As with a hierarchy of regions, these are ethnic regions where populations who have worked a lot on self-care live. So the message is that the universities are considering this return to the territories, and that means that the ancestral wisdom, traditional wisdom, the one that exists in people together with the knowledge that occurs with the training of multiple professionals who have not have that experience in the territory, because this is not like 50 years ago when we used to love the mandatory social service and we were at the territories with no problem. Nowadays, university students do not want to go to the territory, and a problem is how do we convince them to go back to the territory in order to live the needs of people and be able to solve them. So that is an important effort. We have just finished with PAHO, a very interesting initiative with the Ministry of Health, of showing experiences, and we were surprised. There are experiences, very valuable, interesting ones. There are people working at the territory. There are people from the universities and different organizations who are together with the communities because there is solidarity. But I would say this is a very interesting call, and I would say it is there, and that is why I like the proposal to go back to the territory, because there is a great potential there.
Teachers in Colombia and the people who work at health level want people to go back to the territories. They've always lived there teaching at school. Physicians and nurses have left for different reasons, and their territories that want us there. And last, I would like to say there's a very significant element of going back to the territory that the pandemic taught. Part of the reform we experienced in the past years was removing weight to the health authority. Governance in the territories. Colombia lost strength in the territories. The health secretaries at department and municipal level lost strength. It was all centralized elsewhere due to different financial reasons responsible for the current model. And therefore, it is interesting to understand that the health authority during the pandemic showed its capability and rescued this capability of advancing in different policies to save lives and protect them with very precarious PHC. And we must acknowledge we don't really have a solid one. It's precarious. It's just being born. There are some proposals, but not enough. And we have this hope. And the idea is that one of the fundamentals to solve this is that sanitary governance and authority return to the territory with capabilities, strength, and resources. So the health authority, the university, the territories, and the population may create the necessary transformation for the future. Thank you, Eduardo, for sharing in this summary manner, but without leaving anything aside, the recent experience of health service provision in Colombia and lessons learned, this call to return to the territory that can be very important for other countries and experiences, and how they gather this diversity to advance in the agenda. Well, thank you again. And now we'll have a comment from the point of view of somebody who comes from Guatemala but has worked long years in the IDB in the US with direct responsibility in project implementation, and according to what I know, very based on outcome-based immediate from the IDB. Your thoughts? Thank you. We're in this place called San Nicolas in the mountains of Honduras, and we were having a conversation in a small health center with the team to improve the quality of services provided there. Antenatal care, deliveries, cervical cancer, vaccines. And Mr. Gregorio, the promoter, health promoter, working 20 years there, stood up. We had people from the secretariat, from the central and regional level and the bank. And Mr. Gregorio stood and says, with all due respect, I don't need you to come to tell me what are the reasons why the ladies don't come for antenatal control in the first trimester of pregnancy. I need another manner of support. So I start with this because I would ask you all now. Well, we've been yesterday and this morning discussing at this high-level studies, analysis, tools, proposals. But let's forget that. But meanwhile, the health services at territorial level, while the other players in the sector and not only supply, are working every day. Whatever any of us say about financing and models and intervention proposals. And it is there in that chaos where what we're discussing occurs, and how to support a network of services, a small or large hospital or a community worker, to do their work better, because primary health care is that. It's not only local care, not only a hospital matter. So remembering what Mr. Gregorio said, and all the community workers and nurses that every day deal with these things and are unfortunately absent in these discussions and decisions, I'm going to share the experience of the IDB with 2 regional initiatives involving 9 countries, Salud Mesoamérica and the Regional Elimination of Malaria Initiative, where starting from Chiapas to Colombia, Dominican Republic, and all Central America, it's a matter of the science of implementation. To implement was fed with all the science of design, analysis, assessment, and so on. But the science of implementation, implementing a financing model that is outcome-based. It's a little bit of money, but at least $50,000, $100,000, $100,000 have obtained real results. Reduction of anemia, increased quality of services of management of neonatal and obstetric complications, increased coverage in the poorest 20%. So all this issue of inequality and poor quality is greater. So what we learned is a lot, and I have many stories, of course, but I will focus on some items that you both mentioned, starting with the fact that the first major change for PHC to truly begin to be what we all wanted to be, producing results, must be considered in the framework of the whole health system. It isn't a matter of programs, but performance, because the issues we are struggling with are quite complex and not linear, and don't have one single solution. They're intersectorial, and thus require that we consider them systemically, taking into account the complexity and trying to contribute to make all these programs that are so vertical be integrated in a same team. People from HIV, IT people, everybody will fall in the same team. They're in the trenches working with people. And we haven't worked to integrate this hands-on. One of the first things we learned, that is the countries, the donors, partners, and even the bank, after having agreed on these general goals, we began to discuss not the money. And when we're in the bank, it's hard because the countries and counterparts first ask, how much money is there? Forget it. We're not going to discuss money. What do you want to change? What do you want to manage? An increase in reduction of prevalence of anemia, such a percentage, such a percentual increase of the hemorrhagic obstetric complications, and of these according to the needs in the countries. And then we began to work backwards to obtain the necessary outcomes. And at this level, we don't need to know what will be funded by the bank and PAHO, but rather how to achieve the result, whoever pays. We need a single good plan to achieve these results. This, it seems quite obvious, allowed us to focus on people, health condition, and the results we wanted to obtain. The work then was to organize financial and administrative aspects, selecting the interventions that really impacted. And another critical matter was accompanying teams, particularly well, at the 3 levels, in order to plan and have a monitoring of results that is quite different as planning and monitoring in budgets where there are different lines, costs. That isn't easy. We must change a whole mindset we have used in the past 50 years, thinking of specific results. And then the most difficult task, when a country is told we're going to reduce maternal mortality 30%. Well, we all aspire to this, but when I know that my contribution in the territory needs us to find the 60 women that will be pregnant that year and the 60 children, well, it's quite different. I know what people, what territory, what community, and I must monitor that, not only what the country achieves. This seems quite obvious, but you know that changing behavior and patterns at individual and collective level is very difficult. So this demands accompaniment for the local teams, not consultants coming to study or experts to tell us what we need to do, coming 3 months later to ask us if we did implement it. What Don Gregorio asked was for accompaniment in the whole process. And here, another thing, we can't expect, and there are many people who work in cooperation here, and this is a general comment, to expect outcomes in PHC in the condition of people, quality of services, or financial protection after investing 3 years in a little part of a hospital that isn't even scaled up. We must educate ourselves, and when negotiating with the countries about what is feasible as a function of the country's needs, the context will work, and the time needed to modify these behaviors, because change behavior is ours also, accompanying and understanding that cooperation is also responsible, not only the countries, because we have a great responsibility regarding the support of competences at local level. And that is a major learning. Local competences, well, we can't expect all the conditions for funding to be perfect. So as things are, we may work together with teams to help to improve their manner of organization, how they will make the most of the innovations at local level and scale them up to learn and improve analysis with their own local data. It's not a major IT reform. You need the data and quality data. I could tell you about experiences in the different countries of how the analysis of the denominators used entailed a great change in the planning to reach children, to vaccinate, or for family planning in women, or understanding the combined methods for family planning, not in the country, in that region, and what they need every 1, 2, or 3 months, or how the malaria teams are not waiting at central level to manage an outbreak, but rather using their own data to reach a decision at central level when there are greater transmission outbreaks. This may seem evident, and it's what we're doing, but reality is that insofar as we accompany the central, regional, and local levels more in our work, we realize that it isn't always a major innovation or whatever. It's not always like that. Most often than not, we need to sit down with the people and decide how to do things together. And that's the focus of continuous improvement, how success processes may be represented, teams be better organized, how to do things faster and better, and find where we have room for improvement. Those are some of the ideas, and maybe later we can share it. Thank you.
The truth is that we are really hearing messages for change that are very clear. Return to territory and think of Don Gregorio and his family, and results that are relevant in health. And let's build interventions from there. And we couldn't finish this panel better. I'm sad that we have little time, but we have the opportunity now from Brazil to hear from a peculiarly interesting role, coordinator of interprofessional actions. I don't know if I'm just in primary health care. Olivia Medeiros from the Ministry of Health in Brazil. What are your reflections after these provocations? Good afternoon to you all. I will speak Portuguese. Some questions really attracted my attention in Ernesto's presentation and reminded me of situations that I did not live because I arrived with SUS was well consolidated. But I think that there is a perspective of building the national primary health care policy today in Brazil, where equity is treated as a principle of the system, of the primary health care system in Brazil, and the territory is a guideline for the organization. So for us to reach this state where we identify the solution, I think that it was really based on the problems that people were, or we were living. So this logic of thinking, a problem that is real, that is lived there, and the solutions that have to be developed to solve that problem is the basis of that decision. We have a gigantic territory. It's not hard to imagine that without regional, territorial guidelines, we would have even worse problems. So the definition of territory, in fact, helps the system even to survive beyond organizing. It just helps the system survive. When we talk about the situation of equity as a principle and territory as organizational guideline, of course, we structure this based on the family health teams. And when I make presentations, I keep thinking that an essential beginning is to take care so that the parallel decisions do not contradict one another, that there is no competition between decisions. So the family health strategy has to find a policy related to territory, and any other action in the primary health care in Brazil respects that. We do not compete with them. An example that was mentioned before, for instance, is about the multi-professional primary health care teams. These teams, they are not separate from the family health structure. They are related to the family health structure in order to go on with the territorial coordination and also with the principle of equity. And because of the principle of equity, a first very large effort is that family health teams bring this idea in their day-to-day work, that everybody works similarly, and some questions about equity that we could not solve with this strategy, we create then specific solutions. So there are some some groups of visits in the street, providing care to people who are homeless. They have a car and they perform all the actions or articulations with family health to provide care for that population. Another problem that also needed specific actions to create equity are the border health teams in the Amazons and the basic fluvial units that are ships with the basic units of healthcare that travel along the rivers and produce more access to those specific populations that the traditional family health team could not reach. Another factor that I keep thinking a lot about it in terms of territory not being a recipient, and that is an important concern, is that in Brazil, with respect to territory, to think what to do to define behaviors and who is responsible for what in health. So it is frequent in Brazil, and we create awareness in professionals and managers to use the term living territory, because the territory is alive all the time. Things are happening, situations are happening, social determinants, health situations, etc., that need adjustments in our actions. So I would say that territory without problem solving and all those lists of unsolved problems, yes, solution to problems, and that it is very important for us to think that conditions should not contradict one another. We shouldn't have somebody defending the territory in isolation but not other actions. So the person chose the territory, but actions have to respect that organization. I would stress those points. Thank you very much, Olivia. I think as final message that living diverse territory and how multidisciplinary teams and how we provide services has to respond to that diversity. Thank you very much. And yes, now, Monica, you have the floor. Thank you very much. We thank you very much. We all want to keep talking on implementation, what I think is our greatest challenge. Thank you very much to our colleagues for this very rich exchange. We shall now go on. Thank you. I don't know if this is enough. We shall now proceed in this plenary session. Perhaps you can stretch your arms so that you're not still all the time. Now we have our next session, and I want to invite the moderator, who's our colleague Juan Pablo Paragano, who's a specialist in economics and health funding in Pajo, and he will moderate the session that will go up to the break. Thank you very much, Monica. Well, the importance of this session that we shall have now, it touches elements of the 3 I's, the importance of knowing how we are doing in terms of investment, innovation, and particularly implementation, and where we are going. So if we do not know where we are going, it would look like any road would be useful, but that's not the case. So for this session, we shall be presenting elements that are basic in what we regard as good practices in monitoring and assessment for the strengthening of a PHC approach, and we shall have wonderful colleagues with us. I will ask them to sit here in front as I name them. We shall start the panel with a keynote address by Wolfgang Munar. Wolfgang is Associate Professor of Health Systems in the Public Health School of the George Washington University. He is head of the Gil Lebovic Center for Community Health in the Caribbean and Latin America. Dr. Munar has worked in practice and research in global health in Latin America, the Caribbean, Africa, and Asia. He started his work in Colombia, where he was departmental secretary and vice chairman of health, and he has worked in different international and philanthropic agencies, the Inter-American Development Bank, the World Fund of Struggle Against Malaria, TB, and of the Melinda Gates Foundations. And he is now working on the development of primary health care in Salvador and Honduras, Democratic Republic of Congo, El Salvador, and Pakistan. Jeremy, who has been in other panels, you know him. He is a leading specialist in health of the World Bank for the region of Latin America and the Caribbean, and he is also associate professor of public health at the Public Health School, Dalalana, in Toronto, Canada. He has a PhD in public health from the University of Amsterdam in the Netherlands. Now I will ask Mario to come, Mario Sanchez. He is, there you are. I couldn't see you because of the light. He is a senior specialist in social protection and health in the IDB. He is currently assigned to Argentina, but he has been in several offices, has collaborated with governments in 11 countries in Latin America and the Caribbean, and before working with IDB, he was associate researcher of the population economy in the University of Chicago, has a bachelor in economics from Mexico and a PhD in economics from the University of Chicago. Finally, Brianna Rivas Morelo, who is a technical officer at the Integrated Health Services Department in WHO. She works on capacity and performance development analysis of health systems with emphasis in PhD. She studied public health at the London School of Hygiene and Tropical Medicine. We shall hear a presentation, a keynote speak from Wolfgang, and then we shall have questions and comments, 5-minute comments from the different panel members, what they are doing in their institutions regarding monitoring and evaluation, and then we shall have some individual questions so that Wolfgang can close with the conclusions in just 2 minutes, because we are very humble and we did not include ourselves in the panel what we are doing in PAHO in monitoring and evaluation. So in 2 minutes, I would like to tell you that it is an issue that we cover from different perspectives. Ernesto has said a lot about access barriers monitoring to health services, which are not only financial, but in terms of financing, we all know we do not only monitor the financial factors, trying to identify which are the determinants of the lack of protection for type of homes, location, etc. And we are also involved in the measurement of PHC expenditure. What is the discussion that we heard in previous panels, the WHO panel, OECD approach. That's part of our monitoring. And on essential public health functions, we have a specific tool to monitor the capacities in the countries to perform the 11 essential public health functions. Work developed in a very large number of countries. And finally, more recently, we have the development of our own dashboard with indicators that we monitor, for which we use the framework of monitoring and evaluation of PHC developed by WHO, which Brianna will discuss. So we have several studies about it and different outlooks, but now Wolfgang has the floor for his inspiring presentation. Thank you very much. First of all, let's measure time. I don't know about you, but I love this event. I was telling you if the same happened to you, but this event has been wonderful for me, the level of discussions, reflections, and for instance, in the last presentation, I also liked the critical position with which the discussion started, and that the other people also continued.
I decided not to speak about successful experiences, the academic assessment, the publication. For the first time in my life, I decided to sort out some thoughts I have been flooded with during long years about how to continue and assess the behavior of the system as a whole. It sounds like science fiction, but it's scientific, and that's what I wish to share with you. So, I want to start with the basic functions at public health level and remind you what you know, that one of them includes 3 of the elements we've been discussing this past hour and right now. That is continuous assessment and improvement of quality. I'm going to refer to the 2 first. So, what question guides my thoughts? The one in the bolder print that I'll try to answer. The second is a different formulation of the first, but both approaches should work. The critical issue here is that what I want to try to do is to think in a critical manner of how to use our methods, tools, and capacities to conduct monitoring assessments going beyond what we've been doing to date. And when the goal is learning, well, it's a very fashionable word, systems that learn. The U.S. National Medical Academy published some time ago a very influencing report, and WHO another one, another flagship report, like they call it, about systems that learn. And that will guide my presentation. First, because it's a critical position, is to disclose my privileges as a male, somebody with a professional career in working in organizations with authority and power. And the academia has many biases, and sometimes I can't see them, but you will. So as a university faculty, I use many metaphors, and this is one I have really liked, to speak about complex systems, the iceberg, where you can only see the tip, but not what is below. So that's my example. If, like this week, I've used a caloric diet and haven't gone to the gym, well, maybe I increased weight. And if we were to do this analysis at population level, we'd say that poor nutrition and lack of exercise are the reasons for obesity, for this pandemic of obesity. But I would say that at a systemic level, that is not right, because we're not going to what is invisible. In our language, that would be the social and commercial determinants of health and many more. So how should we study this hidden spectrum to respond to these questions we have with the idea of improving our learning? This is also very gross, but it has helped me. I am very used to work with tools, methods, and manners of thinking and of knowing that are focusing on what is observable, and that in time have shown that they are useful to understand how incremental change occurs. But in order to understand how a transformational change has to occur, I must change my approach and my position in relation to knowledge. Let's see how that works. I have a friend and a colleague with who I worked when he was in England, working in Søren Haldrup. He works in UNDP in New York, and he's leader, the informal head of an informal network of assessors and people who monitor called the MNME Sandbox, where we play. And after working with this wonderful group, and I do recommend common language they use in blogs and not in scientific journals, they publish this learning we're all acquiring, and that's a very significant public good. So we must highlight what we all learned, and this has been repeated several times, particularly Sebastian. System changes, and we're speaking of PHC, are long-term and need time to become a reality. Monitoring and assessment of these systemic changes are difficult for us as observers, because when this process starts, we cannot know how it will work after a certain transformational change time is required. And for those who monitor, the issue is how to measure the change in the system at the same time as the system is transformed. As you are aware, the metaphor I use in relation to systemic or transformation changes is the one of the tango we saw yesterday. 2 steps forward, 2 steps back, to one side, etc. Well, that isn't linear. We know that with this sort of change. It's never linear. It's a multiple regression, but it won't help us to understand what is occurring. Another complicated matter in this role, when we are the sorcerer's apprentice trying to learn of a transformational change, and this is more related to assessment. The causal paths for change are never single, but multiple, and we can't tell during the design and implementation where we are. And last, when we have evidence of progress in terms of proximal and immediate change, we can't know really up to what point these changes will truly generate the transformational change in the future we're referring to. Well, that's theory. Now I will frame the remaining of my presentation in what I think we ought to do and better in order to do assessment and follow-up of this very complex thing that is PHC. I don't want to sound axiomatic, but I think these are the 3 rules of thumb that are heuristic, general guidelines you must bear in mind, in my view. First, that systemic change may promote health equity or equality if the conditions that maintain the status quo today are modified. We don't need to know which they are. We'll see that later. And second, adopting in a full manner, in a comprehensive manner, a change of this sort demands that we question our own manners of thinking and knowing. If not, we'll be as colonizing as we're complaining about the colonization of global health by the northern universities and research centers. We must all face this change of our mental minds models. And last, in order to support in time changes in these 2 steps forwards, 2 steps back, 2 steps to one side, we must be able to work together at the same time in 3 different levels: structural, relational, and transformational. Somebody said this before, a person who came from the US, who insisted that in order to change the PhD in the USA had to work simultaneously at many levels. Well, this isn't my language. I'm a sorcerer's apprentice, and I have learned much from the work of others. As a good academic, I ought to mention them, but there isn't time. So, the tip of the iceberg, the upper part that we can see, allows us to understand the structure and the structural change in the system. The lowest level, that is quite implicit and refers to what all of you mentioned in the previous panel, the relational, social level. And the lowest level, we have what a dear friend, a former vice president of Colombia, called the culture, the collective mindset. We have different names for it, mental models, for example. Let's see what they are. This won't be foreign to you. In the structural level, where we have a manifest change, we're speaking of policies and strategies, practices, and not only for providers, but decision makers and communities, families, and so on. Large global corporations that flood us with awful food, and that is one of the reasons for our obesity epidemic. Resource flow that has been discussed, although we call it here flow, because remember, it's a tango. One step forward, one step back. Administration changes, somebody stops something and starts another. And that is democracy, but part of the complexity of our system. What do we mean by resources? I'll choose one, but you have mentioned human talent, supplies, medicines, and I'll give the example of information, not data. I'm not a computer. I cannot manipulate data, but rather information, and I process it with others in a social process. So here, information means an IT system, but some of the things you mentioned in the previous panel mean that there's somebody in the system that is currently aware of something they didn't know yesterday, and because of that have the power of using it or not. That's human agency. It's a flow. It shifts. It's dynamic. And in the next level, we have relationships and connections, power dynamics. And in the end, the deepest change, that's mindsets. So let's see each briefly. At structural level, policy strategies, practices, they are familiar to us, but it's a different manner of speaking of the building blocks of the health system or levers in the operational framework of PHC, with a difference because it's a flow. They're not static. At relational level, and we'll enter into detail, relationships and connections regard the quality of personal exchanges and inter-organization exchanges, quality of communication among the players that are individuals and groups, NGOs, health units, pharmaceutical industries, the Ministry of Health, and so on. And critically, that quality of communication and interaction occurs among players with different histories and prospects. But speaking about conflict there. And the idea with transformational change is to solve it in a manifest manner and manage it. And after, the power dynamics are related with distribution of the decision-making power and authority, formal and informal influence of individuals and organizations that, my dear friends, I'm speaking about racism, sexism, homophobia, all these expressions, the social expressions of the bias that we have sometimes unconsciously as persons and groups. And these power dynamics must end.
Regarding relations and connections, interaction with the patient, citizen, or the community that is not beneficiary but demanding its health rights is very different from the tradition with which I was educated in my medical school. I am the one who knows, I have power, knowledge. That is an example of the change that should occur, but it is collective. Finally, mental models are those social rules that in fact are the origin of that racism, homophobia, sexism. I'm sorry for the poor interpretation, he says, translation, but he didn't learn them in Spanish. That is essential so that we can talk about community participation, people-centered services to help solve problems of the most vulnerable populations. This is the main challenge and one of the reasons why this is a long-term change and a tango. What can we do and what are we doing? I'm convinced that at the tip of the iceberg, we are working fine with the existing frameworks. We can still have many innovations, but they will be incremental in order to respond to the question of to what degree is the system fulfilling its objectives. I think we should enlarge the framework of indicators, but I think we are fine. We have what to work with. And the second level, that is assessment about learning questions. I think of examples of questions that could be answerable with the instruments and methods that we already have, but we've got to be able to do more in this region, I think. Questions such as what are the results, how did they occur, who was benefited, and how did that happen? That is implementation. How did it happen? Somebody said, I want you to tell me how to implement it exactly. And there are several methods that we may use. I only want to note that I am not a positivist, and there are some social research methods that are not part of the armamentarium that we are taught in public health schools. I don't know in Latin America, but they were not taught in my school. And then the most difficult thing, which I would consider a collective challenge for the Alliance, to find ways to respond to questions, to generate a basic vocabulary to understand and operationalize these things. How do you integrate equity in the system? How do social actors interact in health production? How do these actors face the challenges of social determinants, political, commercial determinants? How do they recognize and face power dynamics that have maintained status quo for many years? And here we have to find new instruments. I write some there. I know something about some of them, but this is not what I see my colleagues do in my university or in many organizations present here. And I think we have to start really put in practice where our speech is. So bring social sciences research that is very rich in Latin America and the Caribbean together in our processes of learning and evaluation. An example, my friend Pedro Bernal from the Central American Health Initiative, he's now working at the department led by Ibarran, did an experimental study on an intervention of Central America and El Salvador some years ago using a randomized controlled trial. Sorry, I don't know the word in Spanish, he says. Just by chance, my team was there doing qualitative analysis of that process. And I said, read both papers if you have the time, because they go together. They give you an idea of the tip of the iceberg and some of the relational at the level of teams and relations with communities. And I end saying, let's remember that it's very difficult when we want to evaluate and follow up because of being accountable and telling government or the donor that I have a report or a dashboard that shows my progress. That's good, but I would say this is rather marginal in terms of the capacity of learning. But when the learning is the objective. We are talking about systemic changes. We need a new vocabulary in Spanish that I am inventing it because I don't know it. Practices, methods, changes in our mind to confront our own biases and our own powers and influence. And to remember, as Emma said, that we have to change our behavior in order to help change the things. Well, this was my story. Thank you very much. How wonderful to have a full-time professor. Wonderful, 20 minutes sharp. I couldn't ask for more. And it really is quite challenging because as partners in development, we work a lot in monitoring and assessment. We are doing and will go on doing things, always thinking on how to contribute to the national reality in each member state and the countries where we collaborate, not with an academic outlook, perhaps a mixture of producing knowledge with accountability, but to direct actions of policies. So I thought you were going to mention it in your conclusions, but the challenge of having a study object such as a moving target, when the objective is to transform systems, the types of instruments and indicators are different because they have to help us see if we are moving in the right direction. And the importance of what we do not see going on with your metaphors, we have a flashlight and we see what we illuminate. So in what direction to shift that light, but starting with certain ideas of knowing where we want to go, not just illuminating the whole field, but thinking of where we want to go. So first of all, I wanted to give the panel members 5 minutes so that they tell us about the work they are doing from your institutions. That is a lot. It's very rich. And for that, Brianna will have the floor first, because the framework for monitoring and evaluation of the PHC framework by WHO has been mentioned often times in the meeting, and I wanted to know what work WHO is doing about it and what is the main objective of that work. Can you hear me? Yes. Thank you very much, and good afternoon to you all. As has been said before, yesterday, today, historically, there have been different measurement frameworks that have been focused on results and structures. We have already talked a lot about the need to understand how results change based on the investments made. We have heard several cases where governments and ministers request funds they need, they invest them, but results do not change. So what we need, as has also been mentioned several times before, is how. Yesterday, the 3 elements of primary health care were presented, and also the 4 mechanisms of the operational framework of primary health care. That is what we consider the ingredients of the how. But the how itself, that is, how do you choose the ingredients, how to prepare them, how to give them flavor, will change specifically from country to country and within countries at the subnational levels also. What we can say in general terms is that the framework tries to give guidelines for how to measure capacities and development and performance in PHC. The framework includes a conceptual framework and a menu of indicators that the countries may use, prioritize, adapt to do the follow-up of performance and capacities in PHC. It has been developed working together with countries, with partners, including, of course, the World Bank, in a method that it may be used within processes and mechanisms of assessment and planning of the countries. That is why this framework has been positioned within a logical chain of results. And to fill that vacuum about processes, the framework includes results, critical inputs, but what it gives is an approach about processes and structures that are needed for PHC based on those three elements, the PHC concepts and the 14 mechanisms. That includes, for instance, metrics for policy and governance, intersectoral governance, metrics for mechanisms to get communities involved in the design of services, and metrics about capacities of services and models of care, of integrated healthcare models. As was mentioned before also, and some of these concepts are rather new, in the best cases, data sources are scarce. So PAHO and WHO are developing a set of tools that would help answer some of these critical questions. At PAHO, for instance, people have already mentioned the new tool for the essential public health functions that will be discussed more in the coming session. There has also been the development of a new tool to assess integrated networks of health networks. And in WHO, we are also developing a set of tools. That includes a tool that may be used at the national or subnational level, particularly focused on policies, governance, intersectoral governance, and integrated health models. It also includes a rapid survey to be used in the health delivery centers for primary health care that tries to assess not just some more dynamic aspects that change, but personnel, drugs, but also those mechanisms and the existence of systems in order to improve resiliency. For instance, quality of services, integration of services. And it also includes a survey for patients about quality of services in PHC from the point of view of patients, something that is the key source of information. Currently, tools are being applied, and the framework as well are being applied in different countries by the networks of partners and regional networks, and we hope that if there is interest, we may also learn from their use and application in the region, which is particularly important in the values of PHC. Well, thank you very much, Diana. The importance of flexibility of a framework because it allows adaptation and adequation to each region and country, which is part of the work we have developed in PAHO too. And as I said before, it's the basis of the dashboard that we shall present in the coming weeks. Thank you very much.
Jeremy, shifting the order so you don't fall asleep. The World Bank has a wealth of experience for monitoring and assessment in general terms, and particularly PHC. I'm thinking about the PHCPI coordination, and many more. What can you tell us about the work you've done and are currently doing, and particularly what are the lessons learned from successful experiences and things that didn't go well? Well, thank you for your question. I really wanted to share with you the experience we've built in the years since 2014 to measuring performance of health systems at global level with the performance initiative and a PHC, and some thoughts in the context of PHC when building more resilient health systems. First, we must account for this initiative that we started in 2014 together with WHO and the Bill and Melinda Gates Foundation, together with Harvard University at the Yan Labs, and with colleagues from another NGO called Results for Development. The aim of the initiative was to summarize or compare performance in PHC systems throughout the world with a diagnosis, and it's quite complex, and particularly it was very complex for our friend Bill Gates, who thought it wasn't possible to have a high-level conversation with the ministries of finances saying we have a performance issue with PHC, and it's hard to do it without data. And that is the aim. We worked hard during these past 8 years, and I think that the initiative you described is also a consequence of all this work we did together. Thank you for that important work. But what we did is realize that countries were missing in many countries to account for the performance of the health system. So we had 4 data blocks we were searching for to answer 4 basic questions. The first was PHC spending. How much money goes to PHC within the health system? And in many countries, we don't yet know to date. And this is an very important management issue, particularly if we are in the context with great fiscal pressure on resources. So how to improve allocation of resources? The second question was related with all the different capabilities and input to adapt PHC to epidemiological issues and shockers, and it's quite complicated to answer these questions only with quantitative data. You need triangulation of quantitative and qualitative data, and together with our partners we developed a maturity model to use all the evidence available. Third question regarding clinical quality with the goal of placing quality and holistic care that is focused on patients in the center of this conceptual framework, and last, final, population health outcomes. So we had many things, but many gaps to close. So it was a great effort to work together with governments to close these gaps and develop all the IT system investments to respond systematically to these questions, because ultimately many of the PHC public policies are only due to a partial understanding of the situation and its performance. It's quite different in the tertiary sector, secondary and tertiary, where there is much more investment in IT. But there we started with a significant divide. So we worked hard, hand in hand with our partners, and to date we've implemented this initiative in 25 countries in the world, in Latin America and the Caribbean. We did it in 6 countries that are Chile, Colombia, Panama, Belice, Costa Rica, and El Salvador.
Un país como Colombia lo hemos hecho también al nivel.
And we did it at subnational level also in Colombia and during the pandemic to understand the performance gaps that were a hurdle for better response or mobilization of PHC to help to extend services to respond to the pandemic. So I think that we had very good experiences. This initiative has already nearly 10 years, but it is evolving due to many reasons. First, because WTO consolidated its own framework based on this experience. So we have made great progress in the conceptualization and operationalization of indicators, and at World Bank and other levels, we've internalized this conceptual framework we used in our projects. But the first part, but we've learned a lot. A couple of lessons learned. First, and this was one of your final conclusions, and I think it's important to stress. Monitoring and evaluation systems are developed with different goals. So the design will vary according to your goal. And you have 2 major clear and correct categories to know if we're developing systems with an accountability goal or to improve quality. That will change the rationale in the development of these systems. But I think there's another prospect, and that is how to have a good balance between this top-down or down-top positioning. And we all have our preferences and strategies, but the truth is we need to develop systems that may at the same time reflect a system as a whole and also specificities at local level. So, how to progress as a system when we need system indicators at national level, but also understanding inequalities and variations and local realities that ought to be reflected in these systems, particularly when they feed decision-making. And the third last item is that I think we are at a turning point, meaning that we've made a major effort to improve the monitoring and assessment performance indicators, but the world has changed a lot, because what we learned in the pandemic is that we need to measure health system resilience. So, where do you have the intersection between PHC and climate change and preparation for future pandemics and PHC and future shocks? There are many intersections we need to include in our monitoring and evaluation framework. So I think that the partnership and all the work done during these 10 years will be most useful to have these data that will improve performance, but also build the necessary trust to increase resilience in the health services to access PHC systems that are preventable. that are resolutive also and predictable. Well, we have homework also, coordination of these initiatives, and that's what we offer in this forum. Mario, a lot of IDB experience in this area, particularly in some countries. Could you tell us about some of the specific experiences you consider relevant with the gaps of evidence you found? And these are many. Well, first, I want to tell you I'm very glad to be back in Uruguay. I lived 2 years here, so it's nice to see many friends again. And I think it's good to tell you about the Argentine experience. As Jeremy said yesterday, the importance of considering the specificity of the territory in the different countries. And I'll tell you about 2 important things we must know about Argentina. One, that it's probably the most fragmented, or one of the most fragmented health systems in Latin America. And apart from that, because we have public social security and private, it's a federal country where each province manages and decides most of the budget, and in many provinces this is at municipal level. So you may imagine how this fragmentation is translated into a governance of information and data issue. It's hard to generate timely information with all this. And second, for long years, and I mean the Ministry of Health of the nation in this federal system has implemented performance-based or outcome-based budgets. So it decides in jurisdictions generating changes in the provision model. And I mentioned 2 programs, the SUMAR and the REDES program. And as a byproduct, they generate a lot of information at local level that is very rich to measure PHC. This is the context. And now I'll tell you what happened historically with measurements. It's a short story. In Argentina, in 2018, we became part of the primary healthcare performance initiative. We used the framework and the indicators that were adjusted because they didn't really represent the information they had generated by SUMAR and REDES. So they tailored the indicators and added qualitative information in the study. And this didn't continue. I'm not only going to refer to success cases. This initiative was stopped and didn't continue. And I will just say that this was it's an allegory, but before knowing all this, if we are okay, we must be clear as to where we are going to. If we're not clear about that, and if we don't have a history, we won't know if we're close or far. So all this measurement framework wasn't supported in a process of change of how we would use the information to improve. It was an isolated event, and that was one of the reasons that led to the lack of continuity. But it wasn't related with the payment mechanisms. So with that complex governance to obtain data, it wasn't considered as part of the payment mechanism, so it would be hard to obtain. So the previous administration ended, we had the pandemic, we continued with the new administration, but with a different view. And the position of the new administration was to begin to measure with self-assessment instruments, self-assessment in the PHC centers to know how it was implemented, the primary health strategy.
A model was generated. We do not know what's going to happen with it because it was finished in September this year, so we don't know what will happen to it, whether it will have continuity. But we know the model, for instance, was taken by a province, La Rioja. I don't know if Martin is there. Well, some jurisdictions have taken that model. They are measuring it. Unfortunately, in La Rioja, with a perspective of change, they took it because they think it's an instrument they need to transform their health system. So I hope it is successful. The other thing they did is we funded long ago the Redes program. I think, for instance, that these instruments sometimes are missing the network look. To incorporate it into the analysis, it ends up being center by center. And although some indicators in the system may reflect that, perhaps it is not the most adequate instrument. What Argentina has done, based on a model, and I see my friend Sergio here, based on a model by the Andalusian School of Public Health that had already generated a tool based on that evidence. Redes now has an instrument adapted from that where it measures the degree of maturity of integrated health service networks. So that is another tool they have. And finally, I wanted to tell you what we are also doing and supporting together with Harvard University is the Quest initiative. The idea is to have data from the user's point of view and the non-users as well. That makes quite a difference with the parties, the OECD. These are users and non-users of the health system, and it is a fundamental instrument to measure the implementation of PHC in our countries to be able to incorporate that perspective. Being a survey, it gives a granularity of data with a very low cost that would allow for more complex analysis and territory-based, which in a country like Argentina is fundamental. Thank you, Mario. In my role as moderator, I will take the freedom to change the agenda because several countries have been named where strategies have been implemented. So I would like to give you the opportunity to ask questions to the panels, some of the countries that were mentioned or others, and we shall have time for 3 questions. I see Argentina that was mentioned here. And can you help me with the microphone? I will only take 3 questions because we have 3 minutes left, and I will let you react to the panel questions. So, good afternoon. I am Adriana Magdalena, National Health Director of Primary Health Care at the Ministry of Health at the nation in Argentina. First of all, to thank all the organizers. Ernesto must be around there. We have frequent dialogue with him, and the health system is just as Mario described it, a complex system because it's federal. But in 2021, already with the pandemic more at ease, the minister asked the national team to rewrite the governance axes for primary health care. Those axes were rewritten, accompanied by the PAJO Argentina team, the team of the 24 ministers and under directors of primary health, and all the Gregorio, as the colleague mentioned, because the construction was done bottom-up right now, so that there is participation and empowerment of the people who implement primary health care policies every day. Those axes were rewritten. There are 12 of them. One of them is digital health, of which we have heard so much. And this is also possible because of the contribution of funders, such as the World Bank and IDB, because writing this meant to give a tablet to every Gregorio in Argentina, because we also created informatic tools for primary health care. In this past year, an app was created which is called Visitar, which gathers data from workers, health agents, and community workers at the home. georeferencing and nominating data. This has to do with all the life courses and the participating programs in order to unify the number of records we had. It's an interoperable app because we have other systems in Argentina. It is online and offline because, as you said, it is a difficult issue, connectivity. While all this was being developed, the minister also made an agreement with Assad to provide connectivity. We have 3,800 primary healthcare centers without connectivity out of a much larger group. Assad is a satellite which gave connectivity to the centers so that we may have information. And the whole team also worked on the development of the integrated health record, which is a health record that is being implemented at all the primary health care centers in the city of Buenos Aires and some provinces, which is free, and it has the times of implementation which are different. We have worked with the strength that the pandemic left, because the pandemic was terrible, but it left many strengths. One of them is digital health, that we could go into every home as a team or through technology. Flexibility of the health teams in the country reached its maximum level. In PHC, we are accustomed to working with healthy people more than sick people, controlling, vaccinating, taking samples of what we find, doing checklists, while doing all that we have to do to reach the person before disease. And what happened in the pandemic was the multi-agenda. We had the teams would go to places, and we delayed other activities, which we are still working on to go back to the values we had. Changes have been very difficult, but PHC teams are easily motivated. What does not motivate them is to give them goals that are unaccomplishable. Sometimes we have this type of goals. That is why these tools were designed with accompaniment and support, because it's difficult to know what every Gregorio knows in a country with 4,000 kilometers length. Was difficult, but that is why we had representatives to talk on behalf of those people. We really liked the presentation made by the professor. Changes are not simple, but in the midst of the pandemic, also other changes occurred. Sometimes they take 40 years to occur, and in just a few months, the COFESA met all the ministers, PAJO, and changes were decided, signed, and implemented. So what do we have to do? We cannot just go into fast change at situations of uncertainty to see how those situations, when we could decide changes in half an hour and implement them in La Quiaca or Ushuaia in another half hour. To work on those changes we need, because PHC policies occur on the territory. We may think about them, those of us who are at the center, but you go back to the territory, and every day, as a colleague from the bank said, there are PHC teams visiting families somewhere in the country. The question was for the... Oh, you had a question. How do we make these changes not take that long time? The question is for you. How do we manage to implement these changes as fast as we did it at a time of uncertainty, such as a pandemic? Well, I have time for only one comment or question, not two. One question, a brief one, please. Rather to tell everybody that we should take heart to see what are the opportunities of going from the tip of the iceberg into the deep, because we see that if everything we have done has not given results in increasing access and quality, perhaps this is a space with the Alliance to try new ways that try to explain why things happen. And I would like to hear some ideas for the three organizations. Munar will close with a colleague's question. He will close. So I will leave that question so that all of you can react to it. Mario goes first. Yes, we are starting to work a lot with the World Bank and PAHO for many years, trying to have those instruments. I want to stress something. It is very important to know that we are not doing this in a vacuum, that we are not measuring whether a strategy is being implemented or not without knowing that there is a strategy, that there are clear indicators, clear goals that the government wants to reach. We can talk about equity and what it means for a country. So working together, there are many instruments. I believe that, consider what Wolfgang said, it is so complex that it cannot be solved with only one instrument. We can combine instruments, what has been working on, instruments that allow for comparisons between countries that are very useful, but perhaps not as flexible as the countries need with their complexities to make them useful for decision making, with other local instruments, with measurements at the user's perspective, self-assessments, how we can combine those instruments in a strategic manner, and I believe we can collaborate on that. Thank you. Brianna, a minute for you and a minute for Jeremy. Yes, the Alliance provides a good opportunity to exchange learning and mostly to adapt, because all the frameworks and tools are for adaptation in countries at different levels in the countries as well, to make sure that monitoring and assessment systems generate information that is needed to identify priorities and bottlenecks, that information may be used effectively to start the necessary reforms, actions, investments, and that all this happens in a way that truly strengthens the system, not just the health information system, but the health system to improve results. So in order to do that, we have to invest at all levels. These are not conversations that only occur at the national level. They've got to involve all levels. Whether they start from the top or the bottom, but they meet at the middle, and they have to be strengthened at every level in an integrated manner within already existing processes in countries to review, to assess, to improve health systems and services, not to create problems and additional redundancies. Now there is a good opportunity to exchange and learn how to do that in different contexts and how to really improve PHC. Thank you. Jeremy. Quickly, two things. The first thing is that we have to recognize that the level of investment in information systems is very low in the sector, and I say so because health is a sector that has a high intensity in the use of information, such as the banking sector, but in the countries of low and middle income, investment level is less than 1% or up to 2% of the total health expenditure, and in the banking system it's between 10 and 13%. So with that level of investment, it will be very difficult to advance with transformations. We have a funding gap that is very important. The second point is that we need to change the type of indicators that we are looking at. And that is why I think that focusing on results that consider the function for patients, the patient's experience, and trust in the system, that could create new incentives. And we don't do that now. The work you have done with Quest is fantastic. It's fantastic, and we have to do a lot more and find ways to invest in the measurement of experience of patients, results, functional results, this cascade of care of truly being able to follow patients who have chronic diseases, for instance. That is the Quest initiative. OECD, with the Paris survey, has a similar effort.
This then is quite key and may change incentives because to date, what we're monitoring are all the intermediate process outcomes that are significant for professionals but ultimately don't make such a difference to people and don't help to build trust and resilience in the health system. Thank you, Jeremy. To close the circle, Wolfgang will close in 2.5 minutes. First part of your question, thank you. It's very hard to answer in a couple of minutes, so I'll put two hats. One, the technocratic, with which I felt more comfortable during 40 years. And of course, I totally agree with this idea that we must start somewhere. We must have a vision and start with the end in our view. What do we want to do? We must learn a lot from what is being done in Mesoamerica. There's a lot to learn from the GFF. I don't know how you say it in Spanish. We do have experiences, and we must translate them in a way to guide and provide support. Well, there's room for a horizontal cooperation there and technical assistance, but we must begin knowing where we're going to. And this is not a grandiose vision and a major statement, but just specific things. Given the complexity of countries such as Argentina, India, Brazil, that are federations quite different from unitary countries, the second part of my answer will be political. Of course, I might say it's also scientific if I place myself at social science level, but it is science po. I'm struck by the fact that during our discussions, we're still speaking in the region of community participation and interaction, communities sort of hands-off. That's my feeling. Forgive me if I'm wrong, but I'm quite struck by the fact that simple things such as, well, speaking about information, who knows something they didn't know yesterday that will help them to contribute towards change? I would like to see specific programs, and I would invite the banks. I know the World Bank does it, maybe not in the health area. Do it. Social accountability. And the communities are demanding politically compliance with goals you or others at the more local levels have promised. That is empowerment. This isn't a fantasy. This is occurring elsewhere. Here we're just discussing it since I was born and I'm over 60, but I haven't seen it hands-on. So like this president said, have people working on that. And that occurs at local level. And it's a political long-term process, and it won't work always. It will have unexpected outcomes we won't like, what they'll tell us, and so on. But honestly, that's my view. Thank you.
Bueno, les agradecemos mucho. Quedamos todos con muchas ganas de interactuar, pero ahorita tenemos un receso. Y para cumplir nuestra agenda, pues les damos estamos...
So, we have... What time is it? It's 10 to 4. So 15 minutes, so we're back on time and end on time. Thank you.
Colegas, buenas tardes. Vamos a seguir con nuestra sesión. Les recuerdo que aquí tendremos presentaciones únicamente también en inglés, así que necesitamos que los que requieran traducción, por favor, puedan ir por sus equipos.
Please, let us start this last meeting today. We'll have two panels. The presentation will be as a panel. With us in room A, we're going to discuss essential public health functions. In the upper part, intersectoral action in the PHC territories to approach social determinants. I now hand the floor to Ernesto Pascolo, head of the Primary Health Center Unit, to chair.
Bueno,
Again, thank you very much. This panel is very special, at least for us, for the PAJO, because of what the agenda of essential public health policies functions has meant for us, particularly after the launching of this new conceptual framework in 2020 and 2021, when the strategy of resilient health services system was launched, with one strategic guideline being the need to strengthen institutional capacities of health authorities through this framework of essential public health functions. So this is a very interesting panel because we have combined the honor of having a presentation from Andrew Pinto, who is director of the Upstream Lab at the University of Toronto in Canada, because of his publications, his academic experience, but particularly because of his work articulating not only the components of essential public health functions, but that discussion on essential public health policies globally, its articulation with PHC. And we will also have a panel of comments, but I really want to say that most of their comments will become presentations as such. They are three vice chairs, vice ministers, and they are three vice ministers from three countries that have implemented and are carrying out the agenda of essential public health functions. And each one of them have behind them, or behind their participation, they remind me of a very wealthy or very rich experience in each context. We shall have with us Luis Alberto Martinez, Vice Minister of Social Protection of the Ministry of Health and Social Protection in Colombia. We will also have the participation of Dr. Alejandra Lucia Hidalgo Ugarte, who is Vice Minister of Health Insurance and Management of SUS at the Ministry of Health and Sports in Bolivia. And we will also have participation of the Vice Minister Eladio Perez, Vice Minister of Collective Health. The presentations of these three colleagues, health authorities with very different contexts, such as the presentation that we shall hear from Andreu, are really a luxury in terms of the possibility of sharing with you this discussion and also this view of very different actors, and from their experience we'll have a very rich space at the end of the presentations and comments. We shall have time for questions and answers if we have time, up to 5:30. So that was my introduction. First of all, I ask Andreu Pinto if he could come up here for his presentation, and the three ministers if they could also come. Thank you very much for that introduction.
English. I really wish my Spanish was much better, but I hope everybody can understand what I'm going to convey, and also if you need to use the translation function that we have. It's a very, very great honor to present today with such amazing colleagues. A very special thank you to all of the people involved who invited me, to Pajo in particular, who made the introduction, and all the staff involved with this event, and to Uruguay and the government for hosting this really wonderful event. I just want to begin by telling you just a little bit about myself and where I'm from. I'm both a practicing family physician and also a public health and preventive medicine specialist. I spend most of my time doing research, but that tells you a bit about how I come to this work, kind of at the intersection between public health and also primary health care. Also in Canada, we have a tradition of beginning by acknowledging the land and our history. So Toronto, where I'm located, is on the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit. And Toronto is still home to tens of thousands of Indigenous people from across Turtle Island. Here, where we're meeting here in Uruguay, there's a history of also the Chorua people, and I just want to pay tribute to them, although they are no longer with us. This is our objectives of what we're going to cover in this session overall, to look at the connections between primary healthcare approach and public health, to look at initiatives that integrate, and to have a discussion about not just the theory, but also in these three countries, how integration has happened, to talk about the role of health authorities and also what is necessary to enable it, and think about the contribution to this approach to the essential public health functions, which PAHO has done a huge amount of work to define. And I'll start right out with kind of my three main take-home messages, which are, one, that although I'm located in Canada, there's a huge amount that we can learn from all of the countries in PAHO, and that this is a shared challenge. And that's, I think, a central role of this new alliance around primary health care, is to make those connections. We also face challenges that are very similar to many other countries. The second kind of main take-home is that the interlinkage between public health and primary health care is not just a technical one, but as was spoken about in the last panel, there's also something deeper, that we actually have to go to the roots of Alma Ata and think about the connection between public health and public movements that have actually taken on the political challenge of investment. And the third take home is, when we do have new resources and funding that's flowing, we have to be sure we're not just doing more of the same, that we're not just doing the same thing but faster, but that we actually open our eyes to this idea of something different. I'll frame that as more upstream systems. But think about the last panel, which kind of made this point of the need to be transformational, not just on the surface as well. So I direct a team called the Upstream Lab, which is a growing team, which we've had the privilege to collaborate with colleagues in different countries, as well as do a lot of work within Canada and similar countries. We divide our work into three areas: tackling the social determinants of health and seeing what works, data science and artificial intelligence, and then clinical trials. And I made this point that in Canada, we also are facing some of the same challenges. Compared to many other OECD countries, we actually spend far less than we should on primary care. And it may be surprising that even in a country that has universal health insurance that covers physician services and hospital care, 1 in 5 Canadians does not have access to a regular source of primary care. And this has reached a real crisis where we now predict in the next 5 years that's going to grow to be 1 in 4 Canadians. This is to the point, just on the weekend before coming here with a colleague, Danielle Martin, we had this opinion piece in one of our leading newspapers about the need to fix the primary care crisis, and the need to, we know what we need to do, but that we need to actually have a movement, a public movement to push our decision makers. And just last week, we hosted this national event on how do we address this crisis while building upstream health systems. So that main point that this is not a problem that we have solved, but it's something that we share collectively and that we can learn from one another around this. In terms of the points I'll make about integrating public health and primary care, I want to just acknowledge my co-authors on this chapter, which is coming out in a book that will be released early this year, likely in February, from the World Health Organization. And the colleagues who played a huge role in shaping this primer. But I think this will be a very useful resource to everybody here and everyone in the Alliance. And we wrote this chapter specifically about what do we know about integrating public health and primary care, and how is this really central to the primary health care approach. So I want to begin this by referring to the World Health Organization vision for primary health care in the 21st century, and pose the question to everyone here who come from many, many different countries, over, I think, 36 countries at this event. How can this vision be implemented locally? And we often focus on the bottom part of this, which is primary care and essential public health functions. But we have to think about this synergy that happens with multi-sectoral policy and action and empowered people and communities. And I think in the discussion we'll get into this. How does that actually happen? How does that work? So public health, of course, is the organized efforts of a society to protect, promote, and research health, and engages in collective or social action. The key roles of public health are outlined in the essential public health functions, And these not only support population health outcomes, but they contribute to health system strengthening. The pandemic, of course, showed this enormously, that when we have weak public health systems, our healthcare service delivery systems suffer tremendously. But conversely, when we have very strong primary healthcare and when we have strong health service systems, they can reinforce and amplify public health responses as well. And so this is the PAHO essential public health functions, which I know colleagues in this room have worked very hard to develop. And situating these functions within an integrated approach to public health that goes from assessment to policy development, resource allocation, and then looking at access. And you'll note a number of key functions that are very, very relevant to primary health care. And I'll talk a bit more about that. This is another way to show this, which is using the essential public health functions. And looking at the evidence from around the world, we identified 5 of them that were particularly relevant, and I'm going to go through each one of them, relevant to primary health care and primary health care systems. So these are the 5. You can see health protection, health promotion, disease prevention, surveillance, and emergency preparedness and response. And a really key argument for investing in primary health care is that it strengthens these functions, that when we're speaking with decision makers and those in the ministries of finance about why they should allocate funding to primary health care, we're in this time right now when the pandemic is still, clear in our memories to say that this is going to help us prepare for future public health crises. At the bottom here, you can see there's a spectrum of, across all countries, every country falls along this spectrum in some ways around integration, from mutual awareness where there's some communication that happens, to cooperation and shared objectives, to actual collaboration on programs and joint planning like alignment of strategic plans, to the full extent, which is full integration where public health and primary care services are provided by the exact same entity. So let's go through these 5 key areas. The first is health protection. In primary care, of course, we know that we work with individuals, we can identify their risks, counsel them, promote safety. As a practicing family physician, I do this with families with young children, with women when they're pregnant, with older adults. But we can also envision all of these thousands of primary care entities also supporting and amplifying public health campaigns and supporting policy change around these key risk factors like tobacco, alcohol, infectious agents, and environmental risks. Of course, public health has this key role in shaping the policy environment, working on legislation, and helping with enforcement as well around these risks. So there can be, and the evidence suggests, there's good examples of synergy between these different areas. A second area is health promotion. This figure is from the Ottawa Charter that really was a start of bringing together what do we know about health promotion and has remained a really powerful framework. And you can see one of the key pieces there is strengthening community action to enable the idea of building healthy public policy. And so in health promotion, we work to empower individuals and communities to make healthy choices. Often the overall population strategy could come from public health, but the actual engagement and the trust that exists between individuals and providers happens at the primary health care level. So primary care services have this important role of communicating and leveraging the trust they have. Also thinking about individual support for people around social determinants. This is something integrating health and social care. It's something that is not present in all systems. And you can think about your own country. How much at the individual level, do we integrate really high quality primary care with also social care services? Public health has this role around assessment and supporting community action. One of the ideas that's come from this meeting already is this idea of maybe a standardized way of assessing communities and the centers of primary care that are within those communities. And you could think about how could this fit with what public health has done for many, many decades, which is community health assessment. So tying together this idea of community-oriented primary care with also what public health has been doing for a long time. A third area is around disease prevention. So of course, primary care has a key role in areas like prevention, like vaccinations. With the amazing video that was done to launch this alliance, a lot of the images we saw were of primary care providers immunizing people against COVID and helping with screening as well. And of course, there's a focus on risk factors in chronic disease. Public health has this role of identifying patterns and can do much more to help direct limited primary healthcare resources to where it's really needed. Also, it can be a strong area to support multi-sectoral action. So where it can actually bring primary healthcare together with other sectors, like the sector that is dealing with transportation, or the sector that's in charge of green space, or the sector that's in charge of food prices or housing. So public health has a convening role. Primary healthcare can be a key member at the table that actually conveys what is it like on the ground, what are people seeing, and how can these things work synergistically. A fourth area is around surveillance. This is probably one of the more obvious areas of integration. These are two examples. One is from Canada, something called the Canadian Primary Care Sentinel Surveillance Network. What this has done is over about a decade and a half or so, Canadian primary care sites have joined together in networks, or what we call practice-based research networks. Part of the work has been pooling together electronic medical record data and creating really robust profiles of areas, and then bringing this all together at a national level. What this has allowed is for surveillance of chronic diseases like diabetes, COPD, and other chronic diseases. On the other side is an example from the UK, which has been a long-standing respiratory surveillance system, which actually collects both electronic medical data, but also swab samples from sentinel sites. And this has proven really important during the COVID pandemic. So two examples, chronic diseases and communicable diseases, of using the rich information that is in primary care electronic medical records and helping with it, bringing it together for surveillance purposes. Just a note on this, something that we're working on is automated respiratory surveillance using artificial intelligence that scans through electronic medical records and pulls out information. So it's happening in the background. And the other kind of piece about this is when we start to implement rapid respiratory surveillance testing, it also can help us quickly link people to trials. We're running a national trial right now of COVID therapeutics, and something that's enabling that is really rapidly diagnosing people in all these thousands of primary care sites, and then helping link them to a trial as well. Finally, and a fifth area is emergency preparedness and response. As many will know, public health plays a key role in developing community-level plans, as well as training and helping with other services like emergency services and others, and often has a key role as a leader in emergencies. And this can be everything from heat emergencies, floods, forest fires, and others. Primary care has kind of untapped potential to be part of an early warning system and helping with the data that gets collected and could be updated nightly to actually be part of that warning that tells us we're starting to see an uptick in, say, diarrheal infections, or we're seeing high rates of people with an odd set of symptoms. So there's many different examples of this, and what we found from the literature and examples are key aspects of collaboration are information sharing, prioritization of vulnerable groups who often have trust with primary health care, risk mitigation, and also seeing primary care as a way to roll out interventions and supports as well. So just a few things that we learned from looking at the international literature. What drives this? What are kind of the key enablers of this type of integration? These are 6 points. Leadership and having champions who really get the idea of that the barrier between primary health care and public health is often very artificial and that we're all part of a single system, and who really can support change management, because it's often difficult because people are used to working within their silos, within their institutions. Dual training, so having more people who actually get training in both frontline care and public health. And many different countries have specified competencies, but also supporting joint training, like imagine doing more simulations or exercises where you have public health and primary healthcare practitioners. Data sharing, of course, is key. That enables that type of integration. So having a system that allows, say, immunization data to be collected in primary care and fed up to a national level, or it goes in the other direction. So data on, say, what are emerging patterns of communicable diseases or chronic diseases, and feeding that back out to primary care clinics. Having an explicit shared vision and set of goals, funding mechanisms that support this type of collaboration and doesn't pit it as competition, and also multi-level integration. So you have people working at the individual clinic and regional level, things happening at more of a meso level, and then at the national level as well. And I know our colleagues will talk a bit about kind of what has been the reality within their 3 countries. The final points that I'll make are, can we, while we start to envision this new integration, can we also use this as an opportunity to build more upstream systems? And remember, made that point of when we have new funding flow in, let's not just do the same and do it faster, but how do we actually change our cognitive models, our mental models of what we're doing? So we've done some work to define what do we mean by an upstream system. This is a proposed definition. It's a system that continuously supports the improvement of health in a broad sense, and has a deep-rooted connection to human rights that are throughout the life course of all members of a community, that focuses and has a primary focus on root causes while maintaining this capacity to address acute illness, and also has this aspect of community ownership and governance. That's come up a few times at this event, is how do communities feel a sense of ownership over their work? That actually engages in direct action on policy change. So is a vocal, a member of the community when policies come up that govern things like employment laws, housing laws, investments in different areas. But also it's a health system that sees itself as a place, as a catalyst for creative alternatives that tackle these other social determinants. So envisioning our health centers and our hospitals and community centers as places that bring people together to tackle these causes. What are some of the building blocks of this type of upstream system? These are 5 building blocks that we've defined. Evidence-based services, we need to have the evidence that these services work to actually integrate health and social interventions. Having health and social data that tracks the inequities, but also is a foundation for change and holding systems accountable. A deeper connection to public movements, that could be the local community, that could be at a higher level, that actually really pushes for the system change. Public communication that really reframes health as more than health services, that your health is not just determined by being able to go to the hospital. It's determined by many of these other factors. And also the need to change how we train folks. I know that I was not trained in thinking in an upstream way, and I know that many of the students that are still being trained are not getting that bigger idea. They're not getting trained in skills like working with communities, working with the public, having that broader analysis as well. So just to finish off and then turn it to my colleagues here, primary healthcare and public add value to each other, that you all know before here. These are 5 kind of key areas out of all of the essential public health functions that we found evidence of successful integration. There are key enablers that make this all possible, and something that these enablers should be considered in strategic planning. And as we move to integrate primary healthcare and public health, there's an opportunity to build more upstream systems. Thanks so much, and I'll end there.
Bueno, estoy esperando darle las gracias a que se ponga los auriculares para que quede claro. Yo agradezco mucho esta presentación por distintos motivos. La construcción del consenso del abordaje de funciones esenciales en salud pública en nuestra región, tiene que ver con un ejercicio reciente, digamos, ¿no? De hace 4 o 5 años, cuando pudimos elaborar en la región, entre todos, cuando digo entre todos, más de 200 expertos, más de 30 escuelas de salud pública, y el análisis crítico de muchos países que reflexionaban sobre lecciones aprendidas de lo que habían sido las funciones esenciales en salud pública de nuestra región, que habían sido formuladas a principios de este siglo, muy vinculadas con un tema central, vinculado con la necesidad de fortalecer las capacidades de rectoría de las autoridades de salud y de alguna forma interpelar lo que fue en la década de los 90 un proceso de reducción de las concepciones de fortalecer los sistemas de salud simplemente con una lógica de seguros sobre servicios individuales. Obviamente esto no es una discusión en el vacío, tiene que ver no solo con la realidad que tenía nuestra región, con políticas de ajuste estructural en la década de los 90, en donde la participación de las autoridades de salud y del Estado en general se ponía en cuestión, sino que además tenía un diálogo muy interesante con una discusión que se producía en la América del Norte, y no solamente en Canadá, especialmente en el caso de Estados Unidos, en donde si había un elemento clave para discutir era la necesidad de incorporar en esa discusión los componentes de salud pública inevitablemente como parte de las estrategias de fortalecimiento de los sistemas de salud. Esto ya desde finales de la década de los 80, distintas instituciones, incluso el CDC en Estados Unidos, incorpora esto como una voz.
As an advocacy and as a need to strengthen public health and integrating it to as a key component for strengthening health systems. The added value of all the colleagues at global level is having a deep dialogue, not only in terms of the perspective of systems, but with PHC, as he stated. And I think that this is one of the key elements. Each time we speak of access, it isn't only access to individual health services, it's to the set of health interventions, even public health, and even intersectoral interventions approaching social determinants. And the discussion is occurring in the other panel, but I don't want to make it complex. But this element of considering primary health care as a key area to articulate and integrate and even approach the fragmentation within the field of collective health. So I think this was a wonderful contribution by Andrew, and now I hand the floor to the health authorities.
Somehow, always considering the peculiarities and processes of each country, they have carried out exercises of assessment, implementation, follow-up of essential public health functions in the region. First of all, I will ask Luis Alberto Martinez, Dr. Luis Alberto Martinez, please to make his presentation. Good afternoon to you all. Special greetings again. We are being asked to talk about essential public health policies, functions, as catalyst of implementation of a primary health care approach in organization of services, and two perspectives. What are the strategies to move towards the PHC approach, and what are the essential functions? What is the synergy with the PHC approach? Quickly telling you again part of what we said yesterday at the beginning of this forum, where we may see how allocation of resources somehow determines the future of care in the population and health resorts of this population. This is a map of my country showing how resources are allocated per capita through a sort of private insurance paid with public monies to the different regimes, the contributory and subsidized regimes. And at the end of the day, we see that the territories that are darker green have more resources, unlike the other departments, the ones in yellow, that have less. Nevertheless, these departments with that per capita allotment that is higher, coming from that formula of what is called the insurance prime, the per capita payment is estimated with frequency and severity with the use or consumption of services. So you go into a sort of vicious cycle where resources are allocated, there is more consumption, more services are present there, and this has generated what you see there. We have 305 municipalities with no delivery services because they cannot be funded. They are not profitable. 183 with no emergency services and 347 with no hospitalization for adults. And a traditional indicator of beds per 1,000 inhabitants that shows an average that hides somehow the differences and inequalities at the territory. The same happens with the distribution of workers. Here again, comparing with OECD countries, we see an average of 2.5 physicians per 1,000 inhabitants, but within the country that is also unequal. The same about nurses. And we also checked the distribution of that medical personnel, and particularly specialists. And we see that it is quite similar to what we saw in the first map, where more resources are allocated, the greater supply there is in services and human talent. And that brings along a situation in which there are better health resources, where more resources are allocated. That might look obvious, but we wanted to show it, how this system that is based on that individual insurance logic, trying to have financial intermediates to become stewards of the country, of country system, displacing the authorities, has not yielded good results. So where are we going to? We are trying to strengthen capacities at the national and territorial level so as to be able to recover those lost capacities in these 30 years regarding health personnel, which is now tertiarized, whose decent living conditions and working conditions have been lost, to recover structure that has been lost. Also about technologies, as I said yesterday, the World Bank and the IDB have accompanied us and also generated incentives towards results with a suitable allocation of resources that we shall now see. And all that under the guidance of primary health care. So we start with something basic that we do not have in our country now, to make a territorial division, some sorts of clusters where we could draw regions and sub-regions, and to be able to connect them, to identify in a study led by Dr. Carlos Arango how these different municipalities communicate and what are the capacities that they have and what are their needs, and how do we come close to costs. What is the cost of setting a primary health care center or a multidisciplinary team, a basic team, depending on the number of families, the geographical dispersion, and supported by technology, we could establish 9 regions in our country and 92 sub-regions, districts or provinces. Some of them are beyond political limits in the departments, because sometimes we're crossing a bridge. They are communicated and they create a jurisdiction, a de facto jurisdiction even if they belong to different departments or different municipalities. So we have identified that because primary health care is territorial. It's not individual. So in order to identify determinants in each territory, we have to advance in that first determinant suggested by PhD of population and territory. So in order to allocate resources, this is the path of resource growth where we are still struggling with the Ministry of Economics. How do we allocate resources, growing resources? This first part in dark blue, how do we determine what it is and to allocate it to municipalities with something that economists do not like, that whether that allocation produces something or is inefficient, because we have emergency services in small communities, delivery rooms in small communities, but when the lady comes in explosive phase or with a myocardial infarction, there he has services. So we are growing in order to have 26% of resources allocated to primary care centers in the whole national territory. Also improving the hospital system and resources for training people, amongst others. Hand in hand with the study led by Dr. Bascolo, we were able to organize and make an assessment with collaboration of the Colombian Association of Public Health Physicians or Practitioners with PAJO, the Federal Association of Departments, and we identified two initiatives: the sectoral reform required by territories, because public health and primary health care have to be developed with subnational governments, and the initiative to review the capacity of the workforce available, characterizing it together with this framework of essential public health functions. This is a program that was already carried out. These are evidence of the work carried out with collaboration of PAJO in each one of the regions. These are the health secretaries in each one of those regions, the methodology, generating a sort of traffic light of how far we are at the territory and countrywide to really work with these essential public health functions. These are some first assessments just to show where we are in this evaluation phase, policy development, access, and allocation of resources. And we have basis now to go on elaborating the strategic plan to strengthen essential public health functions with description of the main gaps. Of course, we have many, more in some departments than in others, because we have tertiarized functions that should belong to the state. We have transferred them to financial intermediaries. Each one of these functions is mentioned with its objectives. So we have this work plan with these phases to implement and close those gaps in access, evaluation, policies, and resources. And we have this time frame built with different agents and territorial agents. And we are drawing this roadmap, how to advance in regionalized models of public health management, identifying needs of the territories and advancing in the definition of a supply that is functional for everybody. Finally, we have this objective image. How do we advance to reach it? Where the idea is based on all the road that has been shown to us by PAJO, that we even have in the Colombian legislation, to be able to define a territory, to be able to analyze its needs, identifying in people and families those determinants, but also the demographic and epidemiological profiles, and be able to organize social sanitary supplies, starting with a strengthened first level of care that we call the primary health care center, where multidisciplinary teams work that have a relationship with families and help them in the process of feeling healthy, and having different territorial agents at the territory and at the national level with an intersectoral action for health and with an comprehensive integrated network creating coordinations. And all that under the three basic pillars of participation, of social civic society participation, creating capacity of agency that Martha Nussbaum reminds us of, also advancing in that intersectoral action that transcends in time and reorientation of services, going from competence between or amongst actions. This is a great challenge in our system because we are used after 30 years of competing with one another and to go into cooperation in order to ensure that permanent cultural dialogue with our diverse communities, with indigenous people, with black people, and equality of treatment and advancing in human dignity. And the tension is that we are changing a paradigm, one that today is focused in individual risk management. We want to transcend that into a family and community approach. We have a curative approach which is concentrated in secondary prevention and rehabilitation of damage that tries to provide care, the third level of care, particularly in emergency services that are always collapsed in the production of hospital discharges due to a high burden of disease that we have assumed. That is the financial profit based on competition, fragmented, segmented by payment capacity, and full of barrier access in order to really go to guaranteeing the continuity of care, universality of care, and that the fundamental right to health is enjoyed throughout the territory in all residents in the country, and that we may advance initially in being able to cooperate with all agents with health needs in the center. Thank you very much. Thank you very much. It's a very interesting example, not just because it presents the context of where you're starting, what are the problems, but also, as we said in the previous panel, not just the context, but the process through which authorities approach the problem and the actors, because the doctor mentioned who are the participating actors.
In turn, the articulation. It's three things. The system reform process with this broad vision, the use of the FAS framework as a guide or tool or agenda, and on the other hand, this PHC view with a territorial vision. Let's now pass on to the Vice Minister from the Health Center and Management of SUS, Dr. Hidalgo Udar. Thank you.
Muy amable. Buenas tardes.
Very kind of you. Good afternoon. I want to greet the authorities from the different countries present today and thank the organizers for hosting this very important event for us as countries in the health area. Let's start mentioning our experiences of process and outcomes when assessing essential public health functions.
Muy bien.
Okay. The primary health care-based health system guides structures and functions towards values of equity and social solidarity and the right of all persons to enjoy maximum degree of health. We'll check these principles we've been using in PHC in Bolivia and the pillars and the transformation achieved with all the work conducted. Here you may see one of the commitments with which we've complied in Bolivia in the 30-30-30 agreement that, as you will see, you may see that in our constitution since 2009 we have the right to health and social security. This is a very important part because this was included, but starting in 2008 we have been implementing the family and community and intercultural health policy. In our constitution, in the state, we have different articles that have prioritized this sort of care. As we will see in Article 37, the state is obliged to guarantee and maintain the right to health. That becomes a supreme function that is a financial responsibility first of the state. We prioritize also health promotion and prevention of disease. Another commitment is to eliminate barriers to access 30% at least. And as stated, through the implementation of the intercultural community and family health policy that has been applied since 2008 and focused on individuals, communities, and families. So, as Bolivia, we are implementing this because this policy guarantees compliance in a comprehensive manner and an intersectoral manner, but also in an intercultural manner. And an important thing within the SAPSI policy, that's a name, is social inclusion and community participation. Another important thing that has strengthened the whole health process as a country. And in 2019, one of the commitments we mentioned impacting on the determinants on health with intersectoral interventions via Law 1152/2019. We have implemented the law for the single health system. This law guarantees first and second level with a budget that is allocated as 15.1% of the budget in every municipality, meaning we guarantee access to the single health system because in Bolivia we have three systems. Managing entities, short-term social security for all those professionals or personnel working with access to short-term social security. Then the remaining population has no health coverage insurance, and they are in the single health system thanks to this transformation we had. And the law is implemented. We are allowed to guarantee that all Bolivians count with the single health system accessing to 100% of health at all levels, and we'll see how we work. According to the commitment of increasing public expenditure to at least 6% of the GDP, And we've recorded the fact that since 2022, 2021, we've reached 6.3% of the GDP. And in the following year, that is 2024, in the general state program, we are already guaranteeing 10.1% to guarantee universal access to health. And this is important because it will allow us to achieve many of the strengths we must have and that have been developed with tools. And the idea is to now implement quality processes, monitoring and follow-up. There you will see that allocation indicates that at least we will have 30% of the spending at PHC level. Although the framework law for autonomies in Bolivia, we allocate 15.1% of the budget. That's a minimum, 15.1. Municipalities may allocate a larger budget according to the needs in first and second level facilities, because the central government is responsible for allocating resources for third level hospitals. The governments in this case have a tuition over the third level of care and allocate a budget counterpart. Here we have an important thing, and that is the sub-health teams. These include professionals that will strengthen PHC in the first level with neighborhood offices, strengthening health centers, together with the over 3,500 health facilities we have. We have over 3,000 professionals displaced and visiting the homes, visiting and checking participation of the families, conducting, preparing the medical records in each area according to what has been allocated in the territory.
Si me ayudan, por favor, ahí. Muy bien. Dentro las
Among strategic policies and guidelines, we have the intercultural community family health policy guarantees a comprehensive care during pandemics, emergencies, and disasters caused by climate change and others. And we observe that access to the single healthcare system should be universal and free of charge and quality for individuals, families, and the community, with strengthening and development of the health promotion strategy. These are the strategic guidelines we have posed. Comprehensive management of human resources in the single health system at all levels of complexity, implementation of participation social control in health management. These guidelines will strengthen the whole identification we've conducted, and here you may see that among the essential public health functions, we had 203 gaps identified. These have been gathered with 11 problems, and these, well, Juan, what is the learning or the lesson learned here? They are already being included in the institutional strategic plan. But what we need to do is to have these strategic actions have their budget and a responsible person and have a timeline. We must say this because the National Directorate for the Single Health System in Bolivia is working together with technical staff specifically on these areas in order to obtain health planning, meaning that the health administration that has its technical strategy will also have a strategy via the annual operations program, and with it will manage to check the investment, but not only check the amount of the investment. The goal is to check what we're achieving and what are our results with the investment made. So the system that has already been elaborated, well, the important thing now is to train the human resources to use the system so that in the health center they will be able to plan their programs and manage health efficiently. And in the process, we're now emphasizing this process. And this is the same structure, well, maybe more complex for second and third level hospital, but they must also be measurement units demonstrating how we will later manage to change and meet the indicators. So what is the important thing we're managing with the allocation made by the President Rizarce Patacora, 10.1 for the 2024 period. We will have financial resources, but the health centers and hospitals of second and third level will be able to have this system. And the important thing is to work to strengthen capacity building. We've already stated that social participation is vitally important, and that's why the SAPSI policy at intercultural, community and family level should participate in the construction of this whole model in order to obtain all this. And now we see the different phases and the timeline in which phases we've organized and assessed. This has been seen from August to November 2021. We have had the self-assessment of institutional capabilities, not only regarding infrastructure, equipment, also regarding the resolution capacity of the health personnel. And we must act in relation to this capability, apart from clinical care, but also in the capacity to solve and manage health. It's important to have everybody at hospital level, starting from the top to the family or physician or GP in a health facility. We want them to all be aware about health management so that with a strategic planning conducted, we will be able to contribute to the national indicators. So there we have this prioritization and identification of gaps. The action plan for strengthening, where we're now working on together with the next period.
You may see there are 11 important points which are the problems, but we must also consider as a country how do we strengthen them. And these are tasks that we have seen that their fulfillment is achieved. We have demonstrated that through one of the main strategies of our Minister of Health, Maria Rene Castro, and the President, Luis Arce Catacora, has been that of strategic alliances. Today we are here to carry out an alliance, and we are definitely taking with us lots of strength, because in 24 hours or more that we have been here, we are already making alliances as Bolivia in order to introduce our country into digital health. And digital health is something that is weak for us. That's true. But right now, with these interventions that you have made, definitely we take away great experience. But it is important that you verify that these alliances between municipal and departmental alliances have managed to make us advance and show the fulfillment according to the 30-30 commitments for Bolivia. Thank you very much.
Muchísimas gracias,
Thank you very much, Vice Chair. Alejandra Hidalgo will not take longer because of time, but again, the context and something interesting in this case, I would like to point out institutionalization of the process of analyzing gaps within the strategic plan by the ministry, and second, the utilization of this exercise and dialogue with the regions at the subnational level, considering the Bolivian context. The final participation by Dr. Eladio Perez, Vice Chair of Collective Health in the Dominican Republic. Good afternoon. First of all, I would like to thank the invitation to this forum and greet all the colleagues here with us. From my greetings from my country to Ernesto Vascolo, the Vice Ministers of Colombia and Bolivia, and also to Canada and the University of Toronto. I have prepared a presentation to contextualize, because it is really a panel where we are going to establish a dialogue, but I wanted to show you the context regarding the evaluation of essential public health functions at the Ministry of Health of the Dominican Republic, since this was a process. I don't know if it remains so, but we were one of the first countries to carry out this exercise, and it was a very positive experience. I have been Vice Minister for 3 years, and this was one of the first policies we had to start my time. I had participated as director before in the first surveys, and then we were able to have a ministerial resolution to strengthen this. I will not define the essential public health functions with the public such as you, and we have commented a lot about them, but it's important to point out by April 27, 2021, we launched this ministerial resolution where we named the intention of assessing public health policies. This responsibility fell on the Vice Ministry of Collective Health, and objectives were very clear: to carry out diagnostic of capacities, develop an action plan, articulate this with a Plan DES, which is a strategy. There was a social debt in the Dominican Republic. It was a strategic plan for the development of the health sector in the Dominican Republic, which had never been carried out, and also to establish a baseline for future assessments, because this is just a baseline first assessment, and then we'll be able to see how much we have advanced. Likewise, this was an exercise that took 21 months. There were over 99 virtual meetings more than 299 hours, and it was a development that was not just by the Ministry of Health, but 150 different actors from the public and private sectors, but also NGOs and academia mainly. So it was an exercise that was quite ample, and we could identify the functionalities and roles of each institution. This work plan had a management team. There were socialization workshops, elaboration of a work plan in 3 phases, which I shall describe, follow-up meetings every week, training in each phase, accompanied by PAJO, and documentation and generation of evidence. In the first phase, it was situation analysis and institutional mapping, collecting all the data and information to create an analysis, a health situation analysis. We had a first questionnaire with a selection of indicators. Accompanied by PAJO, we could have preliminary results, and a second questionnaire with description of each function and with a particular axis trying to identify the following dimensions, which was a legal framework to how we exercise essential public health functions, its institutionally, actors, relationships, and barriers. This exercise was very important because in the Dominican Republic, fragmentation has been something that has permeated the system. In 2015, all hospital management was taken out of the Ministry of Health, but without preparedness in order to divide functions. So we have a duplicity of functions. We have a Ministry of Health that did work that was operational, and operational people were designing policies. So that segmentation came from there, and thus be able to use a tool with a new government management to use such tool in order to diagnose what was happening, what were the main changes, and where we should go in order to really have a north of what stewardship is in health and what are the essential public health functions of the ministry that is no longer responsible for the direct provision of care. After this first phase, we had these results with an institutional map, and we saw that out of all the essential functions, only 34% belonged to the Ministry of Health. 10% with the segmentation of the service, 5% for private services, 15% to the deconcentrated part, and other sectors, agriculture, tourism, etc., took part that should work within the essential functions of the Ministry of Health. That is what they should have been. Then that analysis of barriers, we were able to identify those key actors which allowed us to have accessibility and also to identify financial gaps for adequate stewardship, measurement of institutional capacity, those external teams of experts, including also people from the ministry in all these workshops, plenary sessions, and preparation, how we could report and measure each one of these results. Now we have these indicators, which are the 11 functions, and to know where we are, there are many results that are not the best, but it is necessary in order to say, I have to improve. We were also surprised by great advances made even in the past years in order to be able to say that we had some great indicators according to the functions. For instance, in each one of those gaps, we identified 389, quite a lot. But afterwards, we unified them because there were things that were redundant. Then we went down to 277. And when we started prioritizing according to the segmentation of each function, and we ended up that the first 70 were the most important functions. So the most important thing about this part is that look at some examples of gaps. We must strengthen administrative strategies in the system to focus its experts in the reduction of barriers and recognize and orient efforts to strengthen PHC. There were things that were clearly directed to PHC. It is necessary to strengthen activities and strategies in PHC as a transversal way for the social security system in our country. Just like in Colombia, it's quite similar. The social security and health system in the Dominican Republic is basically cut and paste from the Colombian system, with some additions from Mexico and Chile in the pension funds. And priority programs that require a PHC approach, and also the challenge of focusing the strategy towards urban areas, particularly with a community component. In other countries, they have advancements, experiences, but the community part where we have more experience was with HIV. We have a good history also with malaria, colcones. We have important background about community but to really land PHC as a concept, not just for wards and physician and nurse, but as scientific tools at the community level, as you will remember IEPI in pregnant women and under fives, to take those tools to the community, identify those children, and then take them to the health system. This became finally that 10-year health plan for 2030. This government had never had a sectoral plan before, and we were able to be the first sectoral plan based on that great intervention and support provided by PAHO in order to have the diagnosis of what should be the priorities of government in the health sector. So with this Plan DES, one of the most important things, which was with Function 6, Development of Human Resources, we're already working, and with the help of UNDP, we shall start the first national census of health human resources, because in the Dominican Republic we have a gap in identifying on the territory the number of health professionals, not just physicians, but nurses, analysts, etc. What is the real need? What would be the evidence-based and population-based indicators, and how we have to work with academia to cover that, and the strategic plan through 35 projects that were developed. The Essential Function 11 collaborates with the closure of gaps. Integrality and coherence of initiatives for the sector are sine qua non condition to guarantee success in primary health care applications. So here you may see each one of the functions, how they were grounded in this plan. They were organized in 4 groups, and each function was a motor or the designer of what is the sectoral plan that we may share with you. It's available on the internet so that you may have it.
Then we have FASP and PHC focused on each of our interventions. And what has this exercise of the FASP allowed to the Public Health Ministry? A vision of the context and the current status of the health system, priorities for public health and epidemiology, identifying policies and health and outcomes, identification of the institutional environment, including the different stakeholders, structures, activities, barriers, legal frameworks, regulations, policies, and structures. The essential functions enabled the development of the intersectoral strategic plan with PHC as north, sustainable development goals, and thank you. Thank you, Vice Minister. If I were to highlight anything, the idea was that Dominican Republic was one of the pioneer countries in applying the tool. And second item I wish to highlight, well, it's 2 things that don't always go hand in hand and do so in this case. And that is the strong institutionalization of the team that was created initially with a ministerial resolution and the second component and the participation level. In Argentina would say we open the door to many players. As you stated, the private sector, other ministries, civil society, the academia. It was a very long and interesting process. I think it's very well articulated. The institutionalized a very strong team with a capability of articulating with other players. And on the other hand, this third element that is a common factor, and that's a conversation between FESP and primary care. And I think that that consideration, when reflected in part of the issues in Colombia, isn't by chance. It's related with the institutional characteristics of that health system and the sort of reform generated and the major deficiencies that are very closely related to what we've repeated on several occasions regarding inequalities for conditions to access. So I'm very grateful to the three speakers. I know we are short of time. Anyhow, maybe if there are any comments in the room or questions. No? Well, time is short. Armando. Thank you for your panel. I was a bit disturbed by the presentation by Alejandro, I think he said, because I think there's a conceptual confusion. It's hard for me to understand PHC as an approach organizing networks beyond the general ordering framework of public health. So, proposing a conversation between public health and primary care is a conceptual issue, an issue of hierarchy, and could generate a certain confusion because in the long run, what is a challenge is that public health is sorting out the whole actions and systems. That's why I was a bit struck by this, and I think we should have a conversation to solve this problem that is quite important. And then this manner, how they articulate promotion and prevention and protection, I think it's not really appropriate if we consider promotion as a public policy that should articulate all these dimensions. Well, we could have a discussion later. Okay, we'll give Andrew a chance to answer. He said Alejandro, I'm sorry.
So what I think we found looking all around the world is that each country is a bit different in how they are having this discussion about where these functions lie and who's involved with them. I think what we've found that there are good examples in different parts of the world, including, for example, Brazil is one of the countries, Costa Rica, but also other countries in other parts of the world where that conversation is leading to improvements and an actual understanding of where there's synergies between the different sections. The definition of primary health care that the World Health Organization has put forward includes essential public health functions, but on the ground in many countries, including Canada, where I am based, there's a very stark division between these. And it does lead to, like you said, leads to confusion. It also leads to power struggle. And so one of the points that I made was the need to really think about change management and to do that in a thoughtful way that acknowledges that there's going to be confusion, there's going to be difficulties, but how do we move forward? I think the three examples that were given, the three countries that presented, were really amazing, and in terms of the amount of work done to engage different parts of the health system broadly, and then to proceed, using that, feeding it back into the system. Obviously, each country is not done its journey and is kind of continuing in that. But yeah, thank you for that point.
Thank you. Creo que se merecen un aplauso.
I think the whole panel deserves a round of applause.
Bueno, muchísimas gracias. Muchísimas gracias.
Muchas gracias a este excelente panel.
Thank you to the wonderful panel. We have a wonderful discussion. Now we'll close. Well, let's continue. We had a conversation about strengthening social participation, chaired by Armando de Negre from PAHO WHO Mexico.
Adelante, al frente de la última sesión.
Our last session. Good afternoon, night, evening. This panel is a great challenge because we're all tired, and also because this topic, just like PHC, is a reason for discussion. It's polysemic. What do we mean by social participation? And I think that our challenge with our two guests will be to better understand the challenges involved. First, in the definition of this participation, and particularly as based on the impact it may have on our analysis as PHC, as an element to guide health systems. So we will think about this. It will be a long session. We could continue and discuss in an ambitious way all this challenge about participation. Now I will invite our colleagues, as anticipated. Iliana Neves Emeterio dos Santos from the National Health Council Brazil, who will make the main presentation, and then our colleague Pablo Anzalone from the network of healthy municipalities and communities in Uruguay. He will comment. Thank you both. This session will have a presentation in Portuguese and Spanish. So if you need headsets, please get hold of them. I want to sort of contextualize the subject. Social participation has been repeatedly considered something inherent to any process to organize and develop health systems, but it has many meanings in the way how they can understand social participation.
En primer lugar, porque siempre que hablamos de participación social, empezamos a hacer una especie.
And we will have a sort of distinction with what belongs to state and civil society.
Civil tiene muchísimas.
And there are many dimensions. We may understand civil society in a complex and diverse manner in its expressions. Social popular movements or movements organized regarding topics in dispute. For example, in the case of health, groups of individuals with diseases, but civil society also means a set of organized private individuals expressed in the ambit of industry, trade, economic interests, and political organizations such as political parties, unions. So when speaking about this social dimension, we have great diversity that will have to find a manner of being expressed in this exercise of social participation. And this occurs in a framework whereby our countries in general have a manner of democracy that is liberal, a representative democracy. And when we speak of social participation directly in the community, territory, and topics, we are dealing with other manners of expression and participation that may be measured as participatory or direct democracy in many cases. And there we always have the challenge of integrating these different forms, how to guarantee the legitimacy of every exercise of participation within this framework. In this sense, it is interesting to then understand how to formulate this participation in the health sector. Yesterday and today, we've heard many views of participation that you can read between the lines. Some people say participation to have people care for their health, change their lifestyle, change their habits, and have other manners of protecting themselves and those who are close. Others speak of social participation as a way of transfer of certain activities that should pertain to the state, but you want the community to take over certain actions in the area of health. For example, environmental control or improvement of certain material life conditions through the collective effort of the community. A very interesting and delicate topic. Transfer of state responsibilities. And the third one, if you allow, where we speak of social participation as a binding decision-making power impacting on decisions at a higher level that will impact in turn on the population. And this would be a more emancipatory participation, a true participatory power that some may call popular power, others may call protagonic participation with binding decisions and so on. This third modality demands a certain participation architecture that is more sophisticated and would have a greater effect on everything involved with health and its consequences, but also a different architecture and democracy of democratic insertion. I will add an element that I believe is key. In the past years, in the field of bioethics, people speak of a structural problem where participation should help to overcome, and that's epistemic injustice that sets a dialogue between society and state and powers related with the fact that frequently the set of knowledges and the manner of postulating problems and solutions is predefined in unavailable sources to the population. They don't participate, and this epistemic injustice has two bases. Testimonial injustice, where what is experienced by society and communities and individuals doesn't find a manner of expression, and a hermeneutic injustice that has to do with a sort of approach to knowledge applied independent of needs and the expression of needs of individuals.
All this leads us to a framework of epistemic injustice. So on the one hand, we talk about right to health and healthcare, and it involves universal access and integrality. And on the other hand is the abilities of accessing that right and generating a space where there is no access for the population, clearly determines. So having said that and all that on the table, we can say now we're going to have the opportunity, which is very interesting, to firstly hear our colleague Eliana, who comes from Brazil. She is part of the National Director Commissioners of Healthcare in Brazil, and she'll explain how that organism works. She represents those who in Brazil we talk about the users of the system, of the healthcare system. She is an authority of the healthcare providers or of the workers. She's a representative of the users, the population who suffers and demands and implements their right in the healthcare system, and is part of a very large organization of capillarity in the national healthcare system in Brazil. And one of the main characteristics of this system is a system which has an important social involvement. And a political translation of what she's going to speak is what in Brazil is called social control. And unlike what you may initially believe it is, this social control is the control of the society over the state, and not on the other way around, which you might initially believe it is. So this is why we think this present is very important of the National Commission of Health in Brazil, because this is an interesting experience of what a social participation looks like with capacity of decision making and vinculating decisions. So I'll close this initial comment saying that the main characteristic or its pillar is conflict. And the social participation, this tension between society and the state, organizes these conflicts so that they can reach certain negotiations and agreements which are adequate in favor of the population's rights. So now Eliana will share this adventure in 15 minutes, what it implies creating this social participation in healthcare in Brazil. Eliana, go ahead. Good afternoon. I'm going to speak in Portuguese. Good afternoon, everyone. Thank you. I want to thank you for this event, or thank the World PAHO. For me, it's very important to be in this space because as a national representative of the Commission, my name is Eliana. I'm historian. I have a master's in sociology. I studied in the Federal University of Rio de Janeiro, and I come to healthcare through my militant and participation in Afro-Brazilian women and participant in this society. In 1986, in Rio de Janeiro, we had the 8th conference on healthcare, and it was the first time there was an active participation of the social movement. And from that time onwards, there was a reconstruction of the healthcare system until we generate the current commission. And there is about 132 representatives, and they are 50% of them are users, as I am. I'm a user of the system. 25% of them are healthcare workers, and 25% are managers. And how does this work? The way to be involved from the community and from the social society is allowing us to have power in decision making in these services for provided to women with resilience, and to be able to have a focus on equity and justice. How does this happen? Because we believe that if people aren't involved in the generation of public policies and healthcare policies, we will not obtain the results that we want, because it is needed that we recognize our intersectionality and our specific conditions. We are different. We are completely different. So when there's a collective participation based on a legal system and on a mobilization of the society around the world, focusing on the whole person. This is difficult, but it is also possible. We, as a representative, we work in different commissions, and commissions which are related to healthcare, collectives, people for specific population groups, and different issues which are the essential pillars, such as environmental issues. We work intersectorially way. It is not possible to have a commission just based on diseases which are related, that they need to dialogue between the with the equity and justice team. I am coordinator of that commission with other two colleagues. It wouldn't be possible to do it because if we want to work on a specific healthcare problem, lupus or specific cancers, HIV, all this, there are commissions for each one. There are commissions which are focused on each thing, but you can't work on these diseases without dialoguing with others and having intersections with them. We need to consider that there are men, women, and Afro-descendants, different indigenous populations. There are people with specific diseases who come from different regions and from all the different areas, who have different cultures and differences and healthcare practices that need to be respected. We have a commission that works greatly with education and popular healthcare education. We cannot ignore that those people take care of their health in different ways, and their way may be Afro-religious and indigenous religious beliefs. In the latest conference that we had this year, we had the participant of 6,000 people participated in that conference. What was defended by our Minister of Health was recognizing that popular knowledge is important, and Afro-descendants and religions of Candomblé is important. Of course, generated certain conflicts and certain healthcare. From there on, we now are talking about primary healthcare, and we are debating, and we want to generate, how could we generate this and discuss primary healthcare if we don't consider everything that is around it? It's not only about primary healthcare, it's about primary healthcare and everything else it involves. And what is involved, does it involve all these aspects? We're going to talk about territories, and we're going to take into account the population, how that population lives. How are we going to take care of them? How are we going to take care of healthcare workers? The importance of these people in the construction of communities, and those workers, healthcare workers, also benefit from public healthcare, as do the users. We need to think a lot about all these things. We need to discuss healthcare. It isn't a simple discussion. It's not simple to discuss when we need to understand everything that comes into the debate. Understanding the environment, it makes it necessary to understand the needs, the budgets that are needed. We need to have funding for these things. We're just coming out of the pandemic, and we had 700,000 deaths. But if it weren't for the political participation of the society and social society and the activists of healthcare, we would have had a lot worse results. Without a doubt. It is necessary that we build a healthcare. I liked what you said earlier. When it's social control, we monitor these policies of healthcare, and our commission is deliberative. It discusses, there is dialogue, we can reach agreements, we can agree or not agree with management, we may approve it or not. And that is very important to highlight this. We need to have this concept of having this commission to be able to give a voice to the society and the users. And that is very important. and it needs to be understood. It needs to be built on daily, and it needs to be developed on a daily basis. We cannot miss out on this. This commission is here, and this week we are going to produce a report from the conference, and then we will have a national conference on mental health, which is another issue that also needs to be considered and tackled head on, because it also involves primary health care. We have other issues we also need to think about. We need to think about sexual and reproductive rights, which have been slightly evolved, and this is part of primary health care. When we talk about primary health care, this construction involves many other things. I would like us to ask, do you have any question? What would you like me to answer? But for us in our commission, we are working greatly on. I am certain that we need to continue to work even more. The commission has a lot of work to done, because it's not only about primary health care. There are also other issues that we've been had 6 years where they've not been working on. We were nearly wiped out. We resisted, but Jesus was there, and he resisted, because he had the support of the community, and that is the most important thing. We resisted because we were able, and the social society was there, and it is participating in the decision. If that didn't happen, we would have lost the greatest public system of healthcare. Of course, we have at least 100,000 hospitals. In the latest census in Brazil, we have 100,000 political active spokesperson. I could speak about the local representatives. They are very important. They part of the small towns and small groups, and this commission, the local commission of healthcare, of 3 areas, neighborhoods, they come together, and they build all this on a local level, and generates the commission. We have the Commission of Brazil. It is organized in local groups, regional and national groups. So I'll give you, for example, of Curitiba. I live in Curitiba, in the south of Brazil, and we have 32 regions of healthcare. Of those 22 regions, we have other units as well, organized by neighborhoods or by groups of neighborhoods, which work where there is public health care in this unique system.
That group is called the local council. What the council does is take up all the demands of those health units, and it monitors a unit in particular. And how does it do that? Well, do they have medicine? And then if there is no medicine, they would go up to the municipal audit. If there are no results there, then it would go up to the municipal council of the city, and that municipal council will reivindicate through the audit to the state council. So you have different articulations there, the local council, the municipal council, and the state council. And that's only possible because the organized civil society is there to monitor and collect. And that's the reason why exactly that social control, that organization that supported and supports, so that in any time of political crisis, they don't do away with it. And that's what supported the pandemic, particularly in the state of Paraná. The city of Curitiba was considered technically one of the best cities in relation to how to face COVID, and because of that organization of councils and the position and the political role played by the civil society. That's extremely important. All of our colleagues here know that they won't have any possible answers in health if the civil society is not united. We have to have management that makes this articulation, and the civil society must be there because it's society that knows what it requires and needs. We here I know what I need. She knows what she needs. And the reivindication on the basis of what we need, in fact, and not what someone else could have told someone that we need. There is a large difference when you think that you know what she thinks or what I need, and so on and so forth. It's a question of experiences. These are daily experiences in the construction of public health without the social participation. And what I mean is the participation in the construction and monitoring of public policies, and to accompany all that. In that way, we'll get the results that we need.
Elian,
it's important. It's very important to understand this dynamic, and as Eliana mentioned, the experience of social participation in Brazil was born with a single healthcare system. It means in their constitution and in the organic law, specifically for social participation, an architecture of participation was created, starting down in the municipalities. Then the municipalities go through the municipal health councils, and then the provincial council and the national council. And this architecture involves over 100,000 people who are health counselors, who are working for free, but they are officially recognized as representatives of the various sectors and segments described. And they are part of the process. They approve plans, allocation of resources, they receive the account rendering of the authorities, and they can make decisions, and they can block processes so that they reach an agreement. And that's why there are important conflicts sometimes about budgets, about account rendering. So the entire policy making starts there, and it's very vital. What Eliane shared with us is that in the previous 6 years, they had lots of conflicts with the previous conflict in the 6 previous years. There was a government after the coup that was quite contrary to human rights, but the constitutional force resulting from this activism to protect the right to health allowed us to go over that period and continue. So there is a very complex participation process in terms of architecture, but it's very powerful. I would like to ask Pablo to tell us about the dynamic in Uruguay so that we can have a final session for Q&A. Pablo, you can have the floor. Thank you. I would like to point out, first of all, that the experience of the National Health Council is very important and interesting for all of us in Latin America because of its participatory structure from the territories, as Eliana mentioned, and also because of the dynamic of conferences, the idea of holding conferences and organized civil society right from the grassroots, taking steps. Because the construction of social participation of health is not just one single act. It's a process going against many obstacles and factors, and it's supported on the strength of the social tissue. Now, the idea of going conferences by municipalities, by state, by national, you're now doing 17th. Yes, you're in number 17. We believe that that's a way of building a health process that is very interesting. Furthermore, it's coherent with the idea of the organized civil society, the main player, rather than corporate representations of a category. It's the civil society full of heterogeneity, and it's also a learning process because this dialogue of knowledge is very important, and that's one occasion of participating. On the other hand, social participation is important. We have a theoretical framework, and it's a right of the peoples, the power to be able to decide about healthcare policies. And we've seen how difficult it's been, facing many obstacles resulting from a conception about health and medicine that has been extremely vertical and existentialist, and is very much enshrined with the economic power, as it happens in other fields. The inequality of power is shown in a very interesting report of PAHO in 2022 because it stresses the inequalities of power. It's a way of facing the inequalities of power in society in relation to the state, but also not only controlling what the state does, but like trying to give a voice that to those who have the least power. In Latin America, we have a very sad reality because we are the most unequal continent in the world. I think that manual, although it isn't gathering experiences of the southern cone of Latin America, it would have been very interesting to take up the Brazilian experience, but clearly, and others, but clearly the Brazilian experience. I think that it discusses several important contexts and makes you see different experiences, 11 experiences from different parts of the world that are gathered in this WHO publication. And it's also a tool to think about this. I would like to highlight here the experience that Eliana mentioned within the framework of the pandemic and post-COVID, because we got to the pandemic with a hegemonic message of paralysis and isolation, stay home. As if that was the same for all of us, as if an important part of facing pandemic is to organize solidarity, taking care of ourselves, confusing social distances to avoid contagion with social distancing. In my opinion, it's iatrogenic because it focuses on the isolation of people at a time of crisis, not only because of the virus, but an economic and social and psychological crisis. Isolation. So in fact, I think solidarity should have been seen in the way of taking care of others. However, during the pandemic, with all the fear that we had and the message that, in my opinion, was wrong, and that reaffirmed some aspects of social fragmentation, however, it was possible to resist. Well, in the case of Brazil, when the government was denying it, and in other cases where governments were centralizing a response to the pandemic and did not include social participation from communities as a key factor to avoid contagions, but also to look into the entire social and sanitary perspective. And that's why it's important to point it out as an essential function of public health as a part of the global strategy. Health is not only to act against diseases, but it's also a social construction that needs a lot of protagonists. And the idea is that there should be a plurality of protagonists, and by strengthening those players, not those players abiding by the standards defined at political or technical level, but their protagonic participation with their knowledge, knowing that we all can learn and that we can all teach. And the question of popular education in health is a very important field, extremely linked to social participation, because popular education also means that we all learn, that we can all teach, and there's a dialogue of knowledge whereby we can build the best answers for the questions that health shows. Just a detail. A good example over the pandemic was the way the indigenous population faced COVID. They were absolutely abandoned by the government. However, the death rate was lower, one of the lowest in Brazil. In Uruguay, the creation of soup kitchens vis-a-vis food crisis has been an extraordinary and spontaneous phenomena covering all the country, and which had an enormous impact on the answer of one of the critical problems of the pandemic, which was the difficulty in having access to food. There are still very many soup kitchens that created coordinators among them. So the idea of organized solidarity is a fundamental part of any development strategy of social participation.
On the other hand, there are some critical issues in participation that this document of the WHO brings to the table, and others that maybe haven't been commented. And it's this dynamic between the need to producing new knowledge in a new situation on a social, economic, and ecological sphere. And there are many crises that today and globally they are occurring, and in our Latin American context as well. And it is necessary to research, generate new knowledge. It's not just repeat and apply information that's already been developed, but this construction of knowledge is part of research. It says participation and activation. And this is a way of researching and investigating, which also incorporate social movements as the main characters. They are subjects of research alongside academia and public government. And so here recently we had a research which was developed about levels of food insecurity in certain municipalities of Montevideo, which were very surprising, because the truth is that it was a lot worse than what we thought, and those figures were already quite worrying. So this study which was performed, it helped us see a reality that we hadn't been aware of before. And so this week we are presenting a research project of the effects of violence in the way in which certain neighborhoods of Montevideo suffer in their family structures, in youth everyday life, in children, a reality which is a particular area, which is Casabayo, which is a critical area. And this research helps the social area structures of the area to think about alliances between the governments and the public to construct new knowledge. Another thing that is related to this is what was mentioned by Eliana about public education and I've been speaking with colleagues from Brazil who are trying to incorporate one of these elements to work against the pandemic, was training up people and who are forming part of this structure, have a continuous training of these commissions and generating education to lead to action, especially in these contexts in which there is a lot of uncertainty and many challenges that are related. And you can't think of health without thinking about housing and correct nutrition and having a health-safe life. So this idea of continuous training and developing, I think that this document by the WHO, which is very interesting, is this way of learning from each other and the experiences from others. These experiences that Brazil has also said, we were speaking about this earlier with some of the colleagues in the innovative laboratory for social activity. It's supported by the PAHO, and from these enriching experiences of Latin America, we all have a lot to learn from each other, and this is essential to be able to give a response to these challenges that we have today and to strengthen social participation. So learning isn't just hearing academics speak, but also hearing each other and valuing the voice of those who have the popular experience and everyday experience. And another of the issues which has been considered is the way we do planification. How do we plan actions in healthcare in each territory? How do we build on this? There are certain services which depend on certain demands, and that is a way of planning. We need to generate this. We need to respond to this demand. It's a very reduced way of thinking of this. We respond to what is asked for and requested. And what is requested is often related to disease. So we need to plan from another perspective. In Uruguay, we have an interesting experience, which was the planification based on sanitary objectives and goals. There are some colleagues who were involved in that process, such as Wilson Peña, and they said there are 15 critical problems. We have 15 critical problems in healthcare. This was 10 years after having an integrated national health system. And what are we going to do with each one of this problem? We're going to have this strategy. The strategy wasn't only to respond with better assistance and healthcare provision. It also included prevention and promotion of healthcare and collective action. And those objectives, those healthcare objectives, were created goals, and it led to accountability. Accountability of what was agreed with the social society is also important. It's not only generating the voice to create a document in someone's office, but we want to affect planification and planning. And the other thing is these local sanitary goals, that planning needs to be based on diagnosis, which considers the diversity of each context, each country. Brazil is a classical example, Argentina and Colombia are very large. Uruguay is very small, but there are a lot of different realities as well. So there need to be objectives which consider the problems which are prioritized by the community in each territory, and they need to be accountable for the actions that are carried out. And I think modulating social control is something which is very interesting socially, because it's not controlling what the others are doing, but social action to transform and build a better healthcare is a part important of any reform that is going to be talked about in health. Thank you very much. As you can see, there is an enormous dimension of this debate of social participation and social involvement. Over these days, we've been talking about primary health care and the focus for health care, but it's not only always present. Who's going to define the priorities of action and what is their reach? And I think it's very important, this aspect of power, because in a society which is very asymmetric, such as we have with inequalities, people are often very far from the possibilities of actually impacting decisions. And so constructing a power which isn't, it's not delegating part of my power to someone, it's generating power, which is coming from this action and testimony and experience, saying what is actually happening, and generating a strategy to resolve problem. This is very important. I think a very interesting thing is to have the possibility and debate on the economic situation of the healthcare systems. We've been talking about convincing our finance ministers and convince the decision makers and legislators is through society, the pressure of the society, their elections and voting rights, but also it's very important to have a good organization which works as a collective, and I think that is the strength of this National Commission of Healthcare in Brazil. I'd like to invite you for last few questions or recommendations, because we before we are left all alone here, say, what do you think is your take-home message that you want to give us in this regional forum, which is building an alliance for primary healthcare in the Americas? This is quite worrying. We need to understand social control so that we can generate this apparatus of financial and economic power is given to the people. So we as WHO and PAHO, we have the right of and we want to dialogue with different international structures. What was the message that you would give from regarding social participation for this to continue to work towards a democratic process? I think that as a national representative, what I would say, it is necessary to consider precisely, as we've said a lot about Brazil and what people are saying, because we need to step out of this political model that is built top down, and we know perfectly well what the results are of that model, the results that this model brought and continues to bring. We need to change the model and build from the bottom, and this constructions of power that seems very populist, but it's the power that comes from the people. That is power of having the ability to listen. And when you spoke about power, you said it many times. How do we build that power? How do we listen to each other? We need to hear each other truly. The power that can be held by the people, and it can't be destroyed over time. I don't know if you understand what I mean. It's got to be a power that it's something that is constructed for everyone, and it is done based on equality, with sensitivity, understanding that people are people, and sometimes you can't have a pre-prepared package. No, sometimes it needs different ingredients: 2 eggs, flour, chocolate. It may make a fantastic cake, but it may actually say that it needed 3 cups of flour. So how are we going to build this power? With the opinion of everyone, understanding that everyone needs. We spoke earlier about the knowledge. We have different knowledge sources that can complement each other. We need to build on this construction depending on who is thinking and those who think they know everything, and step away from that belief. That power does not exist. That power is constructed. It isn't real. that includes everyone. At least that's from my position as an activist woman of the social society, a historian. I like to say that I'm a historian because as a historian and researcher, the history repeats itself all the time, and it's the power that comes top down, saying what we're going to do with everyone else. I know everything and I'm going to tell you what you need to know and need to do. But I think we need to invert, this is my opinion, we need to invert that process. We need to build society's power and democratize political policies without minimizing the role of the state and the government. That is key in very fragmented societies, and the role of the state is key, but it can't be autocratic. It has to incorporate the voice and the role and participation of society, and the society needs to step up to this challenge, and it's a process of learning together, but based on this thing that we have to challenge and relearn certain things and understand what's done, learn from others' experiences. It's been spoken of by Freire. It's still applicable today, a strategy for healthcare that helps us to think. If it's social participation is something that is essential, because that allows us to, implies we need to be a more dialoguing between yourselves, sharing our experiences and learning from the different experiences that the society and collectives are developing. In each one of them there are certain wins and certain errors, but we need to change the current model, especially in our global context, which is so complex with such a critical and serious environmental crisis. We need to think that we thought we were going straight towards one thing, but now that has changed. It's not so clear. It's not so clear that society is going in a specific direction, but which is directed by something. We need to build something that isn't catastrophic, and that those who are the most vulnerable who are going to pay the highest price, and losing their lives or their quality of life or their futures to different generations.
Very well. We're coming to the end of our time. Most certainly, this is something that we can discuss at length. I would like to give the floor to any of you if you'd like to make any questions or comments before we conclude. Since you are so willing to stay on, any comments or questions? It's that I have a very strong light in my eyes.
To ask a question, I was hoping that it would come to this point. My name is Jillian Bartlett from the Bahamas. I really enjoyed the presentation on social participation. I think that is something that needs to be strengthened in our public health system. And as I said this morning, we are archipelagic, which means all of our 30 islands differ in population, they differ in culture, they differ in needs, and they definitely, one island doesn't paint all. So each of them would need that level of social participation that you described. So my question is, how do we get that in an archipelagic nation? What constitutes? I see the topic is strengthening, but what actually constitutes? Because you have to have social participation in order to strengthen it. So what is the constitution of a robust social participation in primary health care?
I'd like also to say that processes aren't ideal processes. they have their lights and darkness, and to know that that's the case. We can improve on that basis. So from that experience, knowing the process of laboratory and innovation, I think that Brazil has participated, to know these other experiences. And from the Council, particularly, what elements do you think can improve or make more democratic and representative and obtain results beyond the political and rules and regulations to really improve the services in healthcare? What would be missing? Because sometimes we can think about idealization. I think it's important to discuss it and think it over. Any other questions? Please come up front so we can hear you. Thank you. I think mention to power is very important when we're talking about social participation, and I think this is something that is a cross-cutting issue and questions the effectiveness of participation practices. I would like to go deeper into the thought about how much tensions and conflicts of power take part when we're talking about healthcare in particular. Thank you. Anyone else? I think that all these issues are going to continue on the agenda. How to build these processes? Well, we have to learn from history and see how they've developed, to see where the new critics are. And a part of those new critics must be agreed and discussed collectively. And that's why I reivindicate this idea of conferences. In Uruguay, we had a consulting council at the beginning of the reform with the national comprehensive health system. And then 10 years later, we discussed those matters and see what the priorities were, how much we have advanced, where we had to put our stress. I think that the creation of those spaces and to make sure that those spaces, social movements have the possibility of raising their voice and have an impact on a horizontal dialogue with public powers, with the academia and alliances and contradictions and debates is one of the tools to continue building Latin American processes, which, according to the latest elections, show us, particularly in Argentina, particularly complicated with different answers. And the peoples decide at different times, not just one type of answer, but several types of answer. So it's that complexity in that scenario where it's fundamental, I would say, to rebuild the social tissue. If we don't have a strong social tissue with its own capacity to deal with this, you will be in much worse conditions to develop any social protection policy or any policy in general terms. That's why it's important to democratize public policies. From the standpoint of PAHO, I think it's most important to make a contribution, to have a dialogue of the various experiences. What the WHO did of choosing 11, well, that's a tool. You have to put it into practice. In Latin America, we need more dialogue, more exchanges, more players to look at the lessons learned and also to look at training and action. Those are key components. Thinking of strengthening democratic players based in society. They should be diverse, not one single player. It's the organized society, as Eliana said. This has an expression at the political institutional plane, but there are many other expressions in the social plane, and those expressions are very valuable when discussing policies that involve the real, the true reality in the territories, and also the global debates, because in our experience in Uruguay, both a comprehensive health council result from social participation is not only to give social answers and know in the territory, it can also help you to think about complex problems between the relation of policy and technology, setting out priorities, the way we come out from technologicalized and vertical and autocratic level to an organized level. It's not easy, and there are many experiences showing that it's possible, so let's learn from them. Also, another element from what Jacqueline Ponce said, social movements related to health care have contradictions because they are different, and health policy and participation have problems with the component of the medical hegemonic medicine. Everything's organized around doctors' power, and this is what Jacqueline was saying, through interdisciplinary approaches, but we have to recognize the value of other non-professional players. That's learning. There have been contradictions, but there are also very valuable experiences of joint participation, working together, thinking about problems, including the various disciplines. This can't be thought out as one discipline or subordination logic to one of them. We have to think about it in a multi-sectoral manner. Furthermore, there must be a dialogue of knowledge, as Eliana mentioned, and the challenge of building on the basis of the knowledge better possibilities and better answers, more adequate answers to the players together with the civil society. I would like to answer the person who asked about how to build this. There is something that we have been working a lot, and it's on the guidelines to build the young leaders. We need a strong ally, which is education. Education in Brazil at present is a space which isn't promoting health as it should. Training and everything that we have thought about training, which something is just a topic. We have to think about the utopic times that we want to live. That's not for now. We have to think, but sometimes we think for things that are not for right now. Utopias are nice, but we need the alliance with education. Education. In this past 6 years, Brazil put an end to everything: education, health, and social issues. That's a tripod in the question of training people. Education has gone to terrible times where everything was forbidden. You can't say anything. You can't have any discussion about um, sexual and reproductive rights, for instance. There are words that you can't mention. They continue doing their work, but it's us and them all the time, and people cannot forget that. We are here full of hope in this role of rebuilding, reconstructing this, and saying, you can't do it, we can. No, we have to know what the population knows, the academia and the government. And when they talk about how to do that, that's the construction of activism. How we can start. We didn't start like that. We started from back behind discussing these matters over dictatorship in Brazil, where we decided we had to set up an entire project to discuss about openness. That's a work that requires a lot of effort, being aware that you can do things and you can think about this group of people. The project isn't there. The project is here with you in your place, in the government, in the population, in the academia. That's what's missing, that understanding that is missing because we haven't been given it. It has been denied all the time. And so you have to remember that you form part of this project that we are discussing here. But I'm not only listening, I'm listening to think how I can integrate in this discussion that we're having now all the time, and how we can integrate that discussion, because I also form part of that discussion. I cannot look at that looking elsewhere. It's very difficult, of course, but I have to include myself how to do this idea of belonging. We like to use this word belonging, how to make people in the spaces where they are, in their territories, to have this feeling of belonging, which is the construction of those intersectionalities that are necessary in those spaces of debate, raising awareness, sharing knowledge. It's everywhere because we all belong to it. That's roughly what I wanted to share with you. Thank you. Thank you, Eliane. Thank you, Pablo. Minimum closure now.
Our colleague from Bahamas, how do we bring it to a territory in primary healthcare? The experience that has been shared from the communities in these local spaces, generating processes for participation, focusing on those problems and those challenges, and then creating a nucleus of people and a space for dialogue, a democratic space, so that that will find its ways of expression. And that was the origin of these social protests and fights that have been generated. It's not. These experiences are unending. In the case of Brazil, I know there is a lot of spaces are missing for participation that would be important for political, economical policies and for the society to participate more. And here we have this tension between social policies and economic policies. There are certain experiences with spaces into different sectors, and then also the experience of the national Committee for Economic Development, and they're a representative of the society, and we also have politicians. So this is a complex architecture that has involved the quality of democracy. There are many conflicts, and that needs to be considered. That's why I insist specifically in conflict. If we want social participation for real, we need to learn how to manage conflict, and we need to learn that is essential. So I thank our participants, Eliana and Pablo, and I think it's left us with many issues to think about, and this journey of empowerment from the focus of primary care, we need to truly incorporate social participation and its important aspects. Thank you very much. Thank you, everyone. We can now leave. Thank you for staying. Tomorrow in this session, we will have sessions about innovation throughout the life. And in the second session, there will be another tract with planification of interdisciplinary teams. And tomorrow, there will be a few workshops as well. We hope you can have a good, restful evening. Thank you.